We are truly delighted to extend our warm welcome to each of you at the annual CME of the Ophthalmic Society of Pathanamthitta. It is a privilege to host the conference in this tranquil and culturally vibrant district of Pathanamthitta. Pathanamthitta, revered as the pilgrim capital of Kerala, is a realm where spirituality, nature, and tradition intertwine seamlessly. Home to the renowned Shabarimala temple, one of the largest pilgrimage destinations globally, attracting millions of devotees annually. Yet, Pathanamthitta transcends temples and prayers. It embodies culture and nature in their most authentic forms. The hallowed Pamba River, meandering through its core, nurtures all that it encounters. From the resonant rhythms of temple drums to the elegant flow of Aranmula Vallam Kali, the district pulsates with heritage and vibrancy. With its mist-laden hill stations, rubber plantations, verdant forests, Pathanamthitta is indeed a microcosm of Kerala. It is a locale where tradition thrives in every household, where festivals illuminate every spirit, and where nature murmurs in every zephyr. In a sense, Pathanamthitta is not merely a destination, it is an emotion, a cadence, a sacred symphony. On behalf of the Ophthalmic Society of Pathanamthitta, I would like to extend a warm and sincere welcome to Nethram 2025.
Today signifies a remarkable assembly of leading experts in comprehensive ophthalmology, an opportunity to connect, learn, and advance the frontiers of our field. The organizing committee is excited to host Nethram 2025, particularly as this year's event is distinctive with cutting-edge session that encompass the entire range of ophthalmic subspecialties, an electrifying PG quiz featuring thrilling prizes, practical wet lab workshops aimed at enhancing your surgical abilities. We are genuinely privileged to have an exceptional roster of speakers who will impart their knowledge, innovations, and expertise. Without further delay, let's commence our thrilling sessions immediately.
Good morning, all. We will start with our first scientific session, Rara Riddles Taming the Flame. We are fortunate to have renowned experts as chairpersons for today's panel discussion. Our first topic in this session is itis behind conjunctiva. We invite the chairpersons of this session, Dr. Sabida S., Director, Sabida Eye Care, Pathanamthitta and KSOS representative from Pathanamthitta, and Dr. Jisha K., Professor, Government Medical College, Kottayam. Madams, please come forward and get seated. Prepare to gain an insightful and comprehensive understanding of red eye conditions covering everything from allergies to dry eye. It's with great enthusiasm that I invite our esteemed expert speaker, Dr. Sharath S., to the stage. Please join me in offering him a warm and gracious welcome. Dr. Sharath is Consultant Cornea, Cataract and Refractive Surgeon, Chaithanya Eye Hospital and Research Institute, Trivandrum. Over to you, sir.
Very good morning to one and all. First of all, I would like to thank the Ophthalmic Society of Pathanamthitta for inviting me as a speaker for this conference. Red eye as such is a very broad topic. I would like to touch up some of the red eye conditions in this short time with some of the cases which I've encountered in my clinic. So I have no financial interest for this talk. So conjunctivitis as such is defined as inflammation of the conjunctiva, which is characterized by dilatation of the conjunctival vessels with hyperemia and edema of the conjunctiva. Cala, ruba, dollar, everything is there with associated discharge, which may be purulent one, watery, depending upon the type of condition. So etiology, either it can be a primary conjunctivitis. The primary cause would be a conjunctival inflammation or infection, or it can be due to any other disease of the associated or associated structures, like in uveitis or keratitis, panophthalmitis, endophthalmitis. So the primary pathology would be somewhere nearby the conjunctiva with associated inflammation in as a conjunctivitis. So location, based on the location of the inflammation, it can be affecting the eyelid, which can be in acne rosacea, staphylococcal marginal keratitis, or staphylococcal marginal blepharitis. And conjunctival, it can be allergic, infectious, and immune causes mainly. Allergy can be chronic or an acute one. So I'll deal with the allergic part later on. And infectious could be due to either a viral infection, bacterial, or a fungal infection. And immune may be due to autoimmune diseases and contact lens associated inflammations. So lacrimal disease also can cause inflammations, which results in dry disease, or intraocular inflammations like uveitis. So first, infectious conjunctivitis. Most commonly what you can see is, this is a case of a 76-year-old diabetic male came with complaints of redness and discharge in the right eye for 2 days. On examination, mucopurulent discharge, matted lashes and papillae. So it's a sure diagnosis, everyone can diagnose, there is no confusion with this. And so we'll go to the bacterial conjunctivitis. Bacterial conjunctivitis generally results from direct inoculation or infection of infections, and it can be due to contaminated fingers, fomites, or oculogenital spread. Most commonly in adults, the common organism would be a Staphylococcus aureus, Staphylococcal species. Other organisms like Staphylococcus pneumoniae or H. influenzae can be there. In children, most commonly would be a respiratory infection, like respiratory spread. So H. influenzae and Streptococcus pneumoniae will be more common than Staphylococcal organisms. And it is usually self-limiting in 7 to 10 days. And these are the risk factors for bacterial conjunctivitis, like a compromised tear film or any adnexal pathology, trauma, or systemic immunosuppression, or a local immunosuppression as such. So mild forms you can treat, either it's a self-limiting disease, you can give supportive treatments in the form of lubricant drops, or you can give an antibiotic drops, empiric antibiotic drops. Most commonly which we use is a fluoroquinolone antibiotics. In children you can use tobramycin, which has a broader spectrum, and it resolves in 7 to 10 days. So the frequency may be increased according to the amount of discharge and the amount of symptoms. In moderate to severe infection, there will be much more purulent discharge, pain, marked inflammation. So in such cases, if it's not responding to the treatment, you can always send a conjunctival swab and look for the organism and give an appropriate sensitive antibiotic, or you can use a compounded antibiotics or a fortified one if required, if it's not responding to your normal empiric therapy. And in children, if there is Neisseria or chlamydia infection, or in adults also, systemic antibiotics are necessary. You have to give IV ceftriaxone, or a tab azithromycin or doxycycline has to be given. So systemic treatment is required in cases of Neisseria and chlamydia infections. These present with severe purulent discharge. So in severe diseases, the first goal is to treat infection, not to treat the inflammation. So most of the time I've seen many of the conjunctivitis patients comes with a combination of drugs, antibiotic, dexa and moxifloxacin. I recommend everyone not to do that. You have to control the infection first. So if 1 hourly or 2 hourly, you can initially start on antibiotic, a supportive lubricant drops, and if it's too severe, you can always start on an antibiotic, broad spectrum oral antibiotic like azithromycin you can start, or a ciprofloxacin if you want, you can start that also. And later on, after 1 or 2 days, once the infection controls a little bit, you can add on topical steroids to control the inflammation. And as I said, please avoid combinations in the initial setting whenever you get a acute bacterial conjunctivitis. Neonatal conjunctivitis, so this is most commonly due to post-delivery infections, which can be due to Neisseria gonorrhoeae or chlamydia trachomatis. So it normally presents as 2 to 5 days of delivery with severe purulent discharge, matted lashes in a newborn baby. It needs a pediatric referral, it needs an IV antibiotic therapy, and needs a pediatric care in an ICU or a normal ward at least. So it's better to refer these patients to a pediatric specialist. Chlamydia conjunctivitis, most commonly due to D to K, even though these days it's very rare to encounter a case of Chlamydia trachomatis. We have even India is even free of these active chlamydial infection. Even the trachoma trichiasis has been eliminated from India. So recently we have got a certificate for elimination of active as well as the trachoma sequelae. So this is another case where it's a 52-year female patient, diabetic, presented with redness, lead edema for the past 3 days. On examination, there is lead edema, watery discharge, conjunctival congestion, chemosis, and follicles are there. So there is no purulent discharge or a mucopurulent one. It is watery, severe congestion, and chemosis. So it goes in favor of a viral conjunctivitis. So you can see there is follicles in the conjunctiva. Other eye also shows, the third picture shows the other eye. Okay. So on follow-up, the patient was given on CMC drops 6 times per day, 2 weeks on moxifloxacin. If you think that there might be a superadded infection which can there, especially in case of severe infection, severe viral infection, you can always add on moxifloxacin. Otherwise, supportive treatment with a lubricant is enough. And in severe infection, you can start on loteprednol to contain the inflammation. So this was cured with just CMC, moxifloxacin, and loteprednol. And this is a third case where 22-year male patient presented with redness, watering for 3 days in the left eye and irritation in the right eye. So bilateral conjunctival congestion, left more than right, with a watery discharge. Follicles on the palpebral conjunctiva, left eye shows a punctate staining. So this is the image. So you can see that there is punctate staining on the cornea. So it is a keratoconjunctivitis. It has involved the keratoconjunctivitis, cornea also. So this patient was treated with lubricant drops along with steroid drops. It is recommended that you have to taper the steroids, because over a period of time, once you stop the steroids, there is recurrence of the SPKs. So you have to monitor these patients and follow up. So viral conjunctivitis and keratoconjunctivitis, most commonly it's an adenoviral infection, which is most of the time self-limiting, and you can give supportive treatment. And maybe 30 to 40% of these patients develop keratoconjunctivitis. So it's usually bilateral, self-limiting, and lubricants are enough. Call these patients after 3 to 5 days to look for any corneal involvement. If there is corneal SPKs or nummular infiltrates, you have to start on topical steroids. And when to start steroids in these patients? Either if there is severe lid edema, severe congestion, chemosis, or SPKs. These are the indications where you should start on topical steroids. SPKs as such, you have to control inflammation, corneal inflammation. But why in case of severe infection, severe chemosis and lid edema? Because most of the time these patients are also prone to develop corneal infections, corneal infiltrates. So in such patients also you have to start on topical steroids. And choice of steroids depending upon the severity of inflammation, maybe you can start on prednisolone. I will take up 2-3 minutes more. Start on topical steroids, whichever you are comfortable with, and whichever based on the severity of inflammation. And antibiotic cover has to be given whenever you start on a topical steroids, and these have to be tapered very slowly. Next would be an allergic conjunctivitis. So this is a case of 12-year boy with itching, redness, and both eye on and off for 6 to 7 years. Right eye had giant papillae with shield ulcer, left eye with papillae. So this is a case with giant papillary conjunctivitis. These are giant papillae which resulted in corneal shield ulcer. So this child had to be given a intralesional tricot, triamcinolone acetonide, to reduce the papillae so that this corneal ulcer heals. So this is the other eye of the same child which was treated medically. So allergic conjunctivitis, generic predisposition to ocular response to the environmental allergens. It is 10 to 20% of the common population, and up to 40 to 60% of allergic patients have ocular symptomatology. So there can be seasonal allergic conjunctivitis which comes in seasons, or there can be perennial throughout the year, or there can be vernal as in children, or atopic conjunctivitis associated with atopy or giant papillary conjunctivitis. So these are the risk factors, as you all know. Genetics, dust exposure most commonly would be a pollen infection or dust mite, which is commonly seen in the household. So symptoms, they present with limbal, hornetranta, spots, papillae, okay, conjunctival hyperemia. So they comes with on and off recurrences. And these needs management with exposure, avoiding exposure to the allergens or protective glasses, and educate the patient about the general allergy care of the patient, and discourage rubbing of the eyes because it can predispose to ocular inflammation and keratoconus or other corneal diseases, and cold compress for soothing and reduce inflammation and maintain the good ocular hygiene. And these patients need to be referred to a pediatric specialist, or you have to tie up with a rheumatologist or a dermatologist, so that the systemic allergy needs to be managed. Otherwise you will be giving always your Vinolab, olopatad and all these drops. The patient comes with the recurrence, you have to give steroids, but these needs a proper treatment with a pediatric specialist or allergy specialist, so that they can get a skin test or a patch test. If an allergen is found, you can avoid that. This will maintain the patient in a state of good recurrence, or a long-term recurrence can be achieved. Okay. Treatment, so allergic conjunctivitis you can treat with your lubricants or your olopatad mast cell stabilizers or dual stabilizers, or you can acute recurrences you can start always on loteprednol. And to maintain the patients on long-term resolution, you can give cyclosporin or tacrolimus. Always prefer, if there is corneal or limbal involvement more, I would prefer to go for a cyclosporin. If it is more involving the palpable conjunctiva or the lids, I'll go for tacrolimus most of the time. And in some cases, severe VKC, chronic VKC needs oral immunomodulator therapy, so that the eye can be salvaged, because these eyes develop corneal scarring. Severe inflammation can result in severe damage to the cornea. So these patients needs to be referred to a rheumatologist or a allergy specialist. And management of shield ulcers, maybe you need AMG in acute states. So blepharoconjunctivitis, mostly it's an extension of blepharitis from the lids, or it can be due to any drug allergy. Most commonly in a chronic glaucoma patients, they are on benzalkonium chloride, which is a preservative there in most of the glaucoma medications. So in such conditions, you can stop these medications and start on oral or topical anti-allergic medications, and preservative-free medications can be reinitiated. Next would be a case of a patient presented with these kind of stuck-on nummular infiltrates. As you can see, these are stained on fluorescein. These are stuck-on infiltrates, which is a case of microsporidal keratitis. So as I've started these patients on moxifloxacin, loteprednol and CMC drops, these stuck-on nummular infiltrates resolved in a week's time. So what is microsporidal keratitis? It is an intracellular spore-forming protozoa or fungi, which mostly occurs from a contaminated water exposure. So you have to ask the patient whether you are bathing from the well water or pond, or you are using such kind of contaminated water. So you have to tell them to avoid using these contaminated water, so that you can prevent the recurrences. And these can be stained with calcofluor white or pastine, but most of the time this is a clinical diagnosis. You don't have to send them for scraping, or you don't need a microbiological investigation. These are usually self-limiting 2 to 3 weeks, but some patients will have severe inflammation which needs to be treated. They have to be given lubricants. And fluoroquinolones, even though this condition is...
Can you summarize?
Yeah. So just some more conditions where I can say these are some of the foreign bodies. You can see there is a canalicular foreign body. So if there is focal inflammation, you can look for these kind of local pathologies like a canalicular foreign body, which is there in this. Another patient which presented with the inferior congestion, you can see there is a foreign body in the inferior limbal conjunctiva. And last one, these are more common in Kerala, I would say. These are caterpillar hairs which can occur in the lids, cornea, or even it can penetrate up to the vitreous, and it can cause severe inflammation. So these has to be carefully looked for and to be treated or removed. And conjunctivitis can also be associated with systemic diseases like rheumatological disease, all these graft versus verse disease. So these needs to be managed with a rheumatologist. So again, red eye can also be a part of dry eye disease. So that's it. So management of, so these are the miscellaneous conditions, as I said in the beginning. These are the primary pathology like a keratitis, keratouveitis, anterior-uveitis, iridocyclitis, glaucoma. All these can also present with red eye. So early presentations is the real dilemma actually. Some patients in the early stage, you don't know the typical findings, you can't diagnose. So difficulty in diagnosis is there. So always around the side of infection more than inflammation, because if the infection uncontrolled, you cannot control it later on, but inflammation you can always control later. So lubricants works best to uncover the infection. You start on lubricants, call the patient after 2-3 days, tell them that you have an unsure diagnosis, it can be infection or inflammation, and avoid antibiotic steroid misuse. Don't give combinations or don't give steroids if you are in doubt. And close follow-up is very important, and avoiding steroids is the key, and avoiding steroids and communication is the key. You can tell the patient it might be an infection, you have to come back again after 3 days, maybe we'll get the typical symptoms and you can treat them. Okay, so that's it.
Thank you, Dr. Sukhat. And it was an extensive presentation on conjunctivitis. Conjunctivitis is a very common condition that we come across in our clinical practice, but seldom discussed in detail. Now, we have mostly the infective conjunctivitis part has been discussed in detail. I think it's very important to take a detailed history, because most of the cases are infective, yet we come across some cases like gonorrhea, where if you miss a conjunctivitis, the result can be devastating. And this is a condition where we have to treat systemically also. And some of the immune-mediated conditions can also have presentation as conjunctivitis to us. So by taking a proper history and maybe just asking for a urethritis or other some systemic manifestations will help us to conclude, to make a final accurate diagnosis. So, and I have a question, like you said viral conjunctivitis, moxifloxacin is prescribed. Like as a fraternity, I think we should think whether we should need to give moxifloxacin in all cases like this, at least to prevent the
It is
the
not
drug
recommended
resistance.
to give antibiotics in the case of viral conjunctivitis. If it is very mild, you should give lubricants alone. That is enough. And if it's severe, you think that it can be, there can be a secondary infection which is a possibility, then you can always add on antibiotics. Or if you have to give a steroid, it's better that you add an antibiotic cover. Otherwise, lubricants is enough for most of the viral conjunctivitis.
Nowadays, actually, antibiotics means it's almost equivalent to moxifloxacin.
Yeah.
We rarely use, I don't think nowadays we are seeing ciprofloxacin or floxacin or some other antibiotics we never hardly see. So, like, I think we should change that practice.
Even now, I'm mostly using gatifloxacin instead of ciprofloxacin or the other old generation antibiotics, because it's most of the time it's resistant or ineffective, because we are all using antibiotics right and left for all conditions.
So, any questions from audience, we can just.
What antiviral is there for? There is no antiviral drops for viral keratitis. There is no. For the adenoviral infection, there is no antiviral as such. If it's a herpetic viral keratitis, then of course you can add on antiviral drops. No, if it's commonly what we see is an adenoviral conjunctivitis, there is no antiviral for adenoviral conjunctivitis or keratoconjunctivitis. Only antiviral is there for the keratitis, which is of herpetic keratitis. In such conditions, if you suspect a herpetic keratitis, you have a dendritic ulcer, a small vesicular ulcer which is bursting, maybe you can think of adding and topical aciclovir ointment, valaciclovir, whatever it is.
And how long we should use that?
These topical antivirals are mostly epitheliotoxic, so it is recommended that you use it at a moderate dosing, like TDS you can start off, or then you can taper every 3 days or 4 days, like that, whatever you're comfortable with.
Can we start steroids along with that, or?
No, epithelial keratitis, because if you start on topicals in epithelial keratitis, you have to contain the infection only, there will not be much infection. So you don't have to start on topical steroids. If you start on topical steroid, that will become a geographic ulcer, a large ulcer. So it should not be started on in cases of simple epithelial keratitis. But if there is stromal inflammation, stromal involvement, you have to start on topical steroids as well. But one that I think sir will be dealing with that.
We have that.
We have another session on that.
Okay, thank you, doctor. Then we will move on to the next talk. I welcome Dr. Sujit Nayanar to talk on solving the puzzle of viral keratitis management.
Dr. Sujit Nainar is Senior Consultant, Cornea and Anterior Segment, Medical Director, Trinity Super Speciality Eye Hospital, Director, Ophthalmic Services, Aster MIMS, Kozhikode, Kerala. Now, get ready to confront the complexities of viral keratitis head-on with insights from Dr. Sujit Nainar. Over to you, sir.
A very good morning. First of all, thank you for giving me this opportunity. First time I'm having an opportunity to talk in Pathanamthitta Association meetings. Thanks to Dr. Shane and his vibrant team. You have arranged the hall and everything looks so vibrant. A fantastic meeting. Coming to the topic, I'll be discussing on the various puzzles or solving the puzzles of viral keratitis. It's like you're trying to find a way to get out of the maze, because the viral keratitis can present with a plethora of presentations. It can affect from the lids to the various layers of the cornea, various types of presentations. It can recur. There is no actual cure for it. It could be actual infection, active infection, or an immune reaction to it. And unfortunately, we don't have one simple diagnostic test to see if it is actually viral or some other masquerading thing. So mostly the common viruses that is seen are the DNA viruses that causes the corneal pathologies, and for majority of cases it's herpes simplex virus. So my talk will be concentrating mainly on the herpes simplex virus, with few overlaps from the varicella zoster and CMV. So as you know, it can affect all the layers of the virus of the cornea. But there is a pattern, like the primary infection always affects the outer layers, like epithelium or the lids, conjunctiva, blepharitis, the lids, or the dermatitis. So the primary infection is from outside, but rather the recurrent infection comes from within the eye, affecting the endothelium or stroma, due to either immune reaction or from the latent virus that is there in the cornea. And there is a timeline for all these, and it's very well described in the literature. We should also know the pathogenesis and the timeline, because we may be seeing the patient presenting at some stage in between. And at that stage, if you can identify it's a viral, you can really extrapolate what will be the consequences or what will be the sequence of events that might have happened before or that's going to happen in front, and accordingly you can manage that patient. A simple case presenting like this, like what Dr. Sharad told, maybe a simple conjunctivitis. If you don't look at it properly and you just add a steroid or any other medicine, you may land up in a problem if you don't do a proper staining. If you stain, if it was otherwise looking normal, but if you stain it, you are not going to miss this dendrite. And one of the most important takeaway of this talk will be that you have to do a fluorescent staining in such patients, so that you don't miss picking up a dendrite in early stage. So a case scenario like this, where a patient is presenting with the similar symptoms and you have picked up a dendritic ulcer. So the next question is this HSV1? And what will be the next step? Most commonly what we see will be HSV1 only. And don't miss out associated blepharoconjunctivitis or dermatitis, which may be overlooked. Like in zoster, you may have very bad vesicles which will not be missed, but in HSV, you will be having very small lesions along the lid margins, which may be missed if not looked for it. And dendrite, and you should not miss a dendrite, and you should not get confused it with a dendrite versus a pseudodendrite. A simple, see, you know that there will be terminal bulbs and all that, but sometimes it may not be easily identified on slip line. If you put a topical antivirals, you can see that slowly it goes off. That is by trial and error only you can identify. But if it is not going and if it is still persisting, that may not be a dendrite, and it may be a pseudodendrite due to many other causes, like even a medication medicamentosa, or a neurotrophic keratitis, even an acanthamoeba keratitis if there is a contact lens history, or a varicella, or a healing epithelial defect. So The anti-glaucoma medications are very commonly or notoriously involved in such lesions, which can very well represent lesions that look like dendrites. So once you have identified a dendritic corneal ulcer, one more thing you can look for is a reduced corneal sensation. But a reduced corneal sensation may not happen even with the first episode, and recurrent dendritic ulcers or a geographic ulcer may ultimately lead to a hypoesthetic cornea. But first case or first presentation may not have a proper less corneal sensation, and PCR is not done routinely, but that is one diagnostic modality. As already discussed, management is topical antivirals. What is more commonly available is acyclovir and ganciclovir, and the steroid is absolutely no in active epithelial disease. So that's another take-home point. But having said this, this patient may come to you at this stage, just before erupting it into a proper dendritic ulcer, and you may miss that it is going to be a dendrite. So it is a punctate that is going to dendrite, then geographic, probably leading to a neurotrophic ulcer, which remains as a non-healing ulcer. So if it is coming in this stage, and if you have missed, and if you have started steroid for some other reason, this patient is going to develop into a geographic ulcer. This is a case in the literature where you can see all types of ulcers like punctate, geographic, as well as the dendritic ulcer in the same patient, because it was the case was unidentified and a steroid was used in the initial stages. So flare-up of epithelial keratitis will happen with steroids. So steroids is absolute no in epithelial keratitis. So there are other clinical puzzles regarding what could be the actual or topical antiviral of choice, dose, duration, tapering, and all those things. So we have the American Academy of Ophthalmology guidelines, basically based on HEADS study, which is one of the best studies in cornea, herpetic eye disease study. According to American guidelines, which we also follow, is either you have to use a therapeutic dose of topical antivirals or therapeutic dose of oral antivirals. So oral antivirals are also equally effective in topic dendritic ulcer. The therapeutic dose means in acyclovir, what we commonly use is acyclovir. It is 5 times a day for 7 to 10 days. It can be tapered. Like after 7 days, if you feel it, you need to use it for another days, you can actually reduce it to 2 times and continue. Topical also, it is in American it is always trifluridine, because they don't have access to the acyclovir or ganciclovir. Installation of drop 5 times a day for the first 7 days, followed by 3 times a day. So tapering is allowed in antivirals. A few questions like, will oral acyclovir give? So why you want to use oral acyclovir rather than a topical acyclovir in a dendritic ulcer? Is it going to prevent a recurrence? The studies say there is no evidence for that. So even if it is oral, there is no evidence that your recurrence is going to be prevented. So, okay, so then what is the next? If you use an oral acyclovir, whether the stromal keratitis can be prevented? No. The HEAD study shows that even the stromal keratitis can also not be prevented. So it is just an alternative to topical, where you feel that topical may not be the ideal case because the patient may be on multiple anti-glaucoma, there will be a medicamentosa, so you don't want to put another epithelial toxic medicine. So in such cases, you can add an oral antiviral instead of topical antiviral with no additional benefit. So choosing the right antiviral for us, it's the easiest is acyclovir. If it is not available, you can think of ganciclovir. Both are equally effective. Actually, acyclovir is little more broad spectrum for HSV, but ganciclovir has an additional advantage of CMV spectrum also. Acyclovir has a higher risk of resistance, but there is a cross resistance with ganciclovir also. Valacyclovir has got very good bioavailability. It is like the oral valacyclovir has equal bioavailability like as it is given in as an IV. Toxicity wise, trifluridine is the most toxic. Again, acyclovir gives a better profile in toxicity also. A second scenario where you don't have any epithelial lesion, the stromal infiltrate is there, so most probably it will be an immune mediated HSV. A very similar scenario where there is along the stromal infiltrate is there with ulceration. The treatment varies in both conditions. So here the role for the steroid comes. Steroid is not an absolute no in all viral keratitis. It is only for the viral epithelial keratitis. So herpetic eye disease study actually proved that steroid is very effective in treating herpetic stromal keratitis. And the other we'll be going into each points of that. So the guidelines for the stromal as well as the endothelial as per the American guidelines without the epithelial ulceration is therapeutic dose of topical steroids plus prophylactic dose of antiviral agent, which means topical steroids at around 6 to 8 times a day, which should be tapered over 10 weeks or more, along with the prophylactic dose. For more practical reasons, it is acyclovir. So you just remember acyclovir 400 milligrams twice daily. How long? There is no actual study how long, but you have to continue it as long as you are. I may take another 5 minutes because I cannot complete it in 15 minutes. So as long as the steroids are there, you have to continue the systemic steroids or systemic antivirals also. Those with epithelial ulceration, please note, with the epithelial ulceration also you are putting steroids, but limited dose of steroids along with the therapeutic dose of oral antivirals, which means prednisolone as twice daily and acyclovir as 5 times daily for 10 days. Oral prophylaxis to be continued, like exactly what I told. It has to be continued till the topical is continued. So steroids, it's a myth that it's always contraindicated in viral keratitis. It's not so. It's only for the epithelial keratitis, whereas for the stromal keratitis, it is the treatment of choice as proven in head study. So, and the fourth scenario is an endothelial keratitis. Is almost like a stromal keratitis where you have to use both in therapeutic dosage, like topical steroids as well as the antivirals. Both you have to use in the therapeutic dosage. So, a few questions which are the observations of the head study. So, does oral acyclovir help when it is given along with the steroid as well as the topical? Is there any other additional advantage for oral acyclovir if already the patient is on topical antiviral? There is no evidence for that. So, is the therapeutic dose oral antiviral useful in treating HSV iritis? The study shows that there was the significant trend was seen, but it was not statistically proved. So, still it is recommended as per the American guidelines. So, does prophylactic dose of oral antiviral minimize HSV recurrence? Yes, almost by 50%. So, the oral prophylactic dose at 400 milligram BD is one of the most important way of reducing the recurrence and not completely preventing the recurrence. So, what triggers recurrence? We say common cold, ultraviolet, sunlight and all, but nothing is confirmed as such. So, some special scenarios in pediatric cases, like this patient right from age of few months have been following up with me. Every time cough and cold comes, common cold comes, she lands up with a epithelial as well as stromal keratitis. And such patients, long-term acyclovir oral is supposed to be safe. This patient already is having amblyopia, so it's a difficult scenario. Interstitial keratitis with deep vascularization, central opacity, we can control it with long-term soft steroids or prophylactic oral antivirals without progression, but this patient actually wants vision. What should be done? So, a keratoplasty, if done in such cases, is not going to survive. More than 50% chance of recurrence in the graft in such cases. So, these are all difficult conditions. And a similar case, a necrotizing stromal keratitis with perforation, a good grafting was done. He was a patient having renal impairment, unable to tolerate acyclovir. The recurrence started, ultimately it perforated again, repeat grafting was done, and repeat same thing happened. And steroids was topical steroids, systemic antivirals was not tolerated, topical antivirals was toxic for this patient. So, ultimately it's a failure. So, surgical treatment in such cases is the last option. Having said that, it is one of the most unsuccessful option in many cases. And sometimes the scarring happens, not sometimes, most often the scarring happens again. It may be a scar where you need a keratoplasty, or something like in the second picture you can see lipid keratopathy, secondary lipid keratopathy following this thing. And one or two last slides, steroid sparing agents in conditions where we have to use it for a long period, topical cyclosporin or tacrolimus is one good option. So this is another condition where when one more take-home point is, whenever you see this non-healing epithelial keratitis or geographic ulcer, don't think that it is that your acyclovir is not working. It may be a neurotrophic keratitis. So non-healing ulcers, you have to think three things, like one may be an acyclovir resistance, another may be a medicamentosa, third may be a neurotrophic keratitis. And we have a very good option of using insulin drops for this. I cannot go into the details because paucity of time. Insulin, this patient completely cured the neurotrophic keratitis just with the insulin drops, and he is maintained on cyclosporin for prophylaxis. Another similar case, this patient just wanted to show that I'm just scraping this, debriding this ulcer without paraffin. He's totally cooperating and not even knowing that I'm touching his eyes with a needle. And classical adenoviral already been discussed. So few take-home points. Steroid, it's absolute no in epithelial, but yes in stromal and endothelial. Oral antivirals, important role in treatment and prophylaxis. No known triggers of recurrence as of now. Oral prophylaxis can reduce risk by almost 50%. Renal impairments needs dose adjustment for acyclovir. Oral ocular surface toxicity of the agents should be considered. Non-healing defects may be neurotrophic ulcer and should be treated accordingly. Thank you very much. Sorry for taking extra time.
Thank you, Dr. Sujit. It was quite informative. We all have practical difficulties, and in diagnosis, in making diagnosis, and in treating viral keratitis. And I think something which has not been mentioned is about the peripheral ulcers, viral ulcers. So like that is quite confusing. Like sometimes you'll be confused with whether it is immunological or a viral peripheral ulcerative keratitis. What is a tip on a differential diagnosis?
Ma'am, if you are asking about the marginal keratitis.
Yeah, peripheral corneal ulcers also can occur.
Yeah, marginal keratitis or peripheral ulcerative keratitis. The viral keratitis can also present in the same way. Like, but as we already told, we don't have a proper diagnostic method. It's only clinical. And if you're really suspecting a viral, then you have to give acyclovir and see the response of the patient, and if it is responding. But if it is not responding, probably, and most of these peripheral will be an immune and will be responding to the steroids actually.
Do you clinically have a suspicion of viral? It's not immune mediated. Can you
if I have started steroids without an antiviral coverage and I'm not seeing the response to it, then probably I will think that it may have an infective component. It could be, even fungal can present like that. Even fungal can present like this. This pythium, which is very commonly told these days, can present as peripheral keratitis. So, but there is a possibility that if you use steroid, it may flare up. But I have seen cases which has not flared up, it just stays like that. It does not respond to steroids also, though you don't get the expected wow result with the steroids. If it is a pure marginal keratitis, you will see that within 2 days the patient symptomatically will be better, it will start healing and all those. But if there is an infective component, it will remain like that, then probably you will have to use a clinical acumen and try adding one by one. So if you can take a scraping and look for the fungal hyphae, if it is not there, you can add antiviral to see if it is healing. So that is the only problem with the antivirals. I mean, viral, we'll have to use it a little more empirically, because we don't have, the PCR is the only way we can detect it, which may not be accessible all the time.
Use PCR in your clinical practice?
No, ma'am, no, it's very difficult.
One question, how often you check the renal function while the patient is on?
See, if the patients, like I have few patients who have undergone keratoplasty, who will be on long term, maybe lifetime, on acyclovir. Such patients, I get them checked every 3 months. 3 months. Especially serum creatinine. So the one case which I have shown, within 2 weeks of acyclovir, his serum creatinine starts climbing, like 1, 2, 3, then he stops, it starts coming down. I think famciclovir is, I don't have any experience with it, it is better in such cases, in which cases with the renal problem.
Actually, the protection is only, the protection for the recurrence of the keratitis is only while, as long as you are giving the Tazivir.
Yes. So that's why the how long, there is no answer for it, you will have to use it long.
Sometimes we see that even without the systemic antiviral, just giving steroids alone will prevent, maybe an alternate single drop sometimes will prevent the recurrence of keratitis. A very low
Steroids
dose.
actually will control the inflammation. So in the cases where you have seen stromal edema with no epithelial ulceration, steroid will take care of the inflammation. But there is a possibility that the latent, initially it was thought that the latent virus is only in the ganglia and it is traveling back through the nerves to the cornea causing the recurrences. But it has been proved now that the latent viruses stay in the cornea also. So the more period you use the steroids, these latent viruses can cause a recurrence of the epithelial keratitis. So you are using antivirals only to prevent a recurrence of the epithelial keratitis in such cases.
Any more questions?
Topical itself is giving you the good results, then I don't think you will have to use oral, because you are unnecessarily exposing your other body parts to the steroids.
What are the red flags as a cornea surgeon? You say that, okay, when I see these things, I think it has to be referred either to a cornea specialist or yes, it is something unusual.
See, the dendritic ulcer, I think any comprehensive ophthalmologist, they may be seeing on a daily basis in the clinics, you can treat. So that's what the first slide which I showed, do a fluorescent staining, identify it's a normal dendrite and not a pseudodendrite, try an oral, topical acyclovir. If it is not responding, then that is the time you have to revisit the diagnosis, whether it is a pseudodendrite or is there any other reason why it is not responding to, even if it is a dendrite, why it is not responding. Two things, you will have to look at the immune status of the patient. It may be an HIV patient or some already post-transplant patient, or these bone marrow transplant patients, that they are very prone for HSV infections. So some underlying immune problems may be there which is causing less response to the antivirals. So that is the situation where you may have to think a little more and add other things or treat that patient in a customized way. So that is when probably a comprehensive ophthalmologist can take help of a cornea specialist. If there is clear-cut stromal ulceration, better give it to a cornea person so that he can take care of it. Because it's a long-term treatment, you know, the first dendritic ulcer sometimes may not recur, but if it has already come to a cornea stage, there will be some sequelae which needs a long-term care also.
Thank you.
Optical keratoplasty, an optical keratoplasty in such patients, how long will you give the prophylactic acid?
Lifelong, or as long as the patient is coming to you. So that is the only problem, and like as per the study, they in textbooks they say 1 year, but doesn't carry any value. You have to use it lifelong.
Sir, how long we have to give this to prevent recurrence, prophylactic?
Prophylactic also, ma'am. In textbooks, it's always 1 year is what they say, but there is no, the head study or the American guidelines is not specifying any time period for that. So as madam told, as long as you are giving the medicine, you are protected. As once you stop, this virus particles is there in your life, in your eyes all the life, either in the ganglion or in the nerves or in the cornea in the latent form. And if you're very lucky, your body will try to, the immune system, see, sometimes it's in the textbooks, it is also told that these dendritic ulcers can be self-limiting. Even if you don't treat just like viral conjunctivitis, it will be taken care of by your body, provided you have that particular immune power. So similarly, at some point of time, if your body tries to conquer the virus particles, you may get through. Thank you.
Thank you.
Thank you, sir, for sharing your knowledge with us. With this, we have come to the end of this session. Now, I would like to request Dr. Anna Matthew to hand over our token of appreciation to the chairpersons and the speakers of this session. I welcome Dr. Sabita S. Dr. Jisha K. Dr. Sharath S. Dr. Sujit Naina. I request Dr. Anna Matthew, chairpersons and speakers of this session, kindly engage for a photo session.
Coming up, next session is Orbit in Focus. We invite the chairpersons of this session, Dr. Preeta Nair AK, Oculoplasty Consultant, Chaithanya Eye Hospital, Palarivattam, Dr. Shebin Salim, Oculoplasty Consultant, Giridhar Eye Institute, Cochin. Our first topic of this session is proptosis and hot seats behind the bulge. Navigating the complexities of proptosis is essential for effective patient care, and we are poised to tackle this challenge with Dr. Anju Suresh. She is Senior Consultant, Orbit and Oculoplasty, Chaithanya Eye Hospital and Research Institute, Trivandrum and Kollam. Join us for this empowering session as we enhance our understanding and commitment to manage proptosis with confidence and expertise. We welcome you, Dr. Anju Suresh, onto the stage.
Thank you, and good morning, everybody. Let's discuss the red flags in proptosis. So, as we all know, proptosis is the one clinical sign that localizes the pathology to the orbit. And all orbit conditions require a close analysis. Assess the clinical process, whether it is a mass effect, vascular effect, an infiltrative effect, etc. Look at the location of the lesion depending on the displacement of the orbital structures. And the onset is also important, whether it is acute, subacute, chronic, or catastrophic in onset. Detailed history taking and evaluation of the patient for signs and symptoms, and apply your knowledge of epidemiological understanding to arrive at a diagnosis. Now coming to the red flags in proptosis. Any red flag is a sign that indicates urgent intervention. In proptosis, the most important is loss of vision. So in all patients with proptosis, assess the optic nerve vital signs, which will include vision, color vision, pupillary reactions, examination of the fundus, a perimetry, and a VEP. Second red flag is redness of the eye itself, which is possibly due to either infection, inflammation, or it may also be due to exposure keratitis in a chronic proptosis. Third most important red flag is a tense orbit where the soft tissues feel hard to touch. This is a sign of an orbital compartment syndrome which can result in loss of vision very soon and requires immediate intervention. Other red flags are limited extraocular movements and diplopia, which means that either the extraocular muscles are involved or the cranial nerves are involved. Extremes of age are always red flags, especially young age, because in young age, more often the diagnosis will be an infectious or a malignant cause. And general condition of the patient, again very important. For example, in very sick, debilitated patients, possibly bedridden or wheelchair bound. So this was a 65-year-old lady with uncontrolled diabetes, presenting with history of uncontrolled diabetes or a chronic kidney disease, history of organ transplant, on treatment for hematological malignancies, etc. The first thing you should rule out is a mucor. This is a file picture to show you the typical facial eschar. Facial eschars occur over the sinuses or the lateral wall of the nose. Though diagnostic of a mucor, it's often a very late sign also. The investigation of choice will be a contrast enhanced MRI with fat suppression. The avascular areas, as you all know, mucor is angioinvasive. The avascular areas fail to take up contrast and appear darker in color, and this leads to the typical black turbinate site in mucormycosis. This is the right turbinates are black in color, but the orbit looks vascularized. How will the patient be managed? First, control the diabetic status immediately. Start them on IV amphotericin, preferably liposomal. And if you get avascular tissue within the orbit, you might need a orbital exenteration. In the nose and paranasal sinuses, aggressive surgical debridement till you get vascularized tissue. However, if the general condition of the patient is good, and the patient presents with fever, nasal obstruction for the past 1 or 2 weeks, then you will suspect a bacterial orbital cellulitis. In this case, an immediate contrast enhanced CT is essential. So what are you looking for? You're looking for sinusitis. 90% of cases of bacterial orbital cellulitis are due to spread from an adjacent sinus, and 90% of the time the ethmoid sinus will be the culprit. So what we need to do is start the patient on broad spectrum parenteral antibiotics, preferably a 3rd generation cephalosporin, an ENT opinion to do a FES and clear up the sinus infection. Systemic steroids are also very important to reduce the orbital edema and allow more of your antibiotic to reach the orbit. So every patient has to be admitted and kept examined daily. And with daily follow-up, the red flags you will look for are change in proptosis and development of bilaterality. So change in proptosis. For example, this boy presented with axial proptosis and orbital cellulitis. After 2 to 3 days, he started to develop abaxial proptosis. So what will you suspect? You will suspect a subperiosteal orbital abscess, which in addition to your antibiotics, you need to surgically drain the subperiosteal abscess and place the drain for 24 to 48 hours. So that, or this is a CT showing the medial subperiosteal abscess. Or you can get worsening of the axial proptosis, worsening of the orbital edema, etc. In this case, you will suspect a orbital abscess behind the globe. Again, needs immediate surgical draining and placement of the drain for 24 to 48 hours, in addition to the remaining management. Rarely, the signs and symptoms start to become bilateral. So you develop periorbital edema on the other side, limitation of abduction first and limitation of all extraocular movements. Pupil becomes sluggish on the other side. The patient will develop severe headache, drowsiness, altered sensorium, and new onset seizures, all suggestive of cavernous sinus thrombosis. At this stage, you refer the patient to a neurosurgeon. In addition to your management, the patient will need IV heparin and antiepileptics. And the MRI will show dilated superior or thrombosed superior ophthalmic vein, filling defects in the cavernous sinus, and it becomes distended. The concave lateral walls usually become convex. Removal of the thrombus is not an option because cavernous sinus thrombosis develops as a body's attempt to prevent spread of the infectious organism into the brain. Now, in a patient with very good general condition, no significant systemic comorbidities, presenting with sudden onset, painful orbital edema, you will consider non-specific orbital inflammation. This is mainly a diagnosis of exclusion, but responds very well to systemic steroids. Actually, the dramatic response to steroids is in itself a diagnostic criteria. So here, when you ask for CT, look at the CT, the sinuses are perfectly clear. However, he has proptosis, inflammation of the fat, a slight lateral rectus myositis, mild lateral rectus myositis, mild acroadenitis on the left side, responded to steroids within 3 days. So, and steroid treatment has to be tapered and continued for 8 to 12 weeks. In case of recurrence, evaluate for other collagen vascular diseases, connective tissue diseases, etc. Across all ages and genders, the incidence of unilateral and bilateral proptosis is most common in thyroid diseases. So all proptosis cases evaluate the thyroid function. This was a 27-year-old male patient who presented with diplopia of 2 months duration. His TSH at the time of diagnosis was 134, and now it's approaching 10, still not euthyroid. His CT showed enlargement of all extraocular muscles. A typical feature was that the medial rectus is relatively okay. Inferior rectus is maximally enlarged. So one of the red flags you look for in clinical examination of TAD is the presence of chemosis, congestion, carangular edema, which is a sign of active orbital inflammation. And on CT, the red flag you're looking for is approximation of the inner margins of the recti muscles. So if they come closer together on both axial and coronal views, especially behind the globe, it's extremely suggestive of impending optic nerve compression. So that requires high dose systemic steroids, preferably 1 gram IV methylprednisolone weekly for 6 weeks, followed by 500 mg for weekly for 6 weeks. And of course, attain euthyroid status as far as possible. Even after 72 hours of starting treatment, if you don't get the expected clinical response, then you start thinking of other causes that you might have missed. So you can go back to the initial history taking, your CT examination, etc. So this was a 72-year-old male patient, initially treated as orbital inflammation, but the redness persisted even though his pain subsided. So his repeat CT showed, this is an MRI film, but the repeat CT showed a dilated superior ophthalmic vein on one side, and then it became bilateral. He was referred to the interventional radiologist for a CT angiography. CT angiography is the investigation of choice. However, if you are planning intervention, then you can do a DSA, but that you leave it to the interventional radiologist. Treatment is usually endovascular embolization. Very rarely patients respond to carotid compression exercises also. But even though the exercise appears simple, a carotid Doppler has to be done first to assess the carotid blood flow, and then only start doing carotid compression exercises. And rarely you can get neoplastic causes for your proptosis and red eye. So this was a 67-year-old lady complaining of inability to close her right eye for more than 1 year. So she had been at different points of time, she had been treated for Bell's palsy, then she was treated for myasthenia, then finally for multiple sclerosis, and then in the end she was being treated elsewhere for pseudotumor orbit. They tried to do a tarsography. Because it was difficult, she was referred to me. So her examination showed congested eye because of the exposure keratitis, but it also showed a mild proptosis, limitation of extraocular movements, obvious globe dystopia, and palpable hard non-tender masses in the supralateral orbit and of the right eye and inframedial orbit of the left eye. Her CT showed corresponding masses, which were then biopsied, and the biopsy report was metastatic breast disease, even though she never had treatment for CA breast and was not aware of such a problem. So she is now on chemo after radiation. Now, pediatric age group is a huge red flag. So this 5-year-old came with a history of periorbital swelling after playing in the garden. The mother insisted that it was an insect bite. However, imaging showed a solid tumor in the supranasal quadrant, which was excised in toto and turned out to be rhabdomyosarcoma. She completed chemo, radiation, etc., and has started going back to school now. However, This orbital swelling may also be the initial presentation of a hematological malignancy, or in non-fully treated cases, it can be the first sign of a relapse. So all pediatric cases ask for a peripheral smear. The demonstration of blast cells immediately changes the diagnosis and management protocol. You need to refer them immediately to the hemato-oncologist. So if you go the normal route, imaging, biopsy, etc., you waste a lot of time. Even after sending to the hemato-oncologist, they will still require imaging and biopsy for further treatment. And then the dreaded complication of trauma is orbital compartment syndrome. Mostly post-traumatic, can also be iatrogenic. So patient presents with a tense orbit, shiny lid edema. You cannot press the globe or the eyelid, and loss of vision is very rapid. So it has to be rapidly treated with a lateral canthotomy, a superior and inferior lateral cantholysis till the intraorbital pressure is relieved slightly, and high dose systemic steroids, preferably IV methylprednisolone, to protect the optic nerve and vision. So this is a dire emergency. We don't usually image the patient, but if you image, you can see the classical guitar pick sign, which is due to posterior tenting of the globe following extreme proptosis. The lateral and medial walls of the globe are at an angle of around 120 degree in this patient. If less than 120 degree, it's highly suggestive of impending vision loss. So, to conclude, unlike all other ophthalmic diseases where the diagnosis is visible, orbital diseases are more concealed. So, in addition to a detailed history taking and a comprehensive ophthalmic checkup, you will inspect, palpate and auscultate the globe, and imaging is the investigative cornerstone of orbital diseases, and along with your biopsy report and your laboratory evaluation results, you can come to a final diagnosis or conclusion. Thank you.
Thank you, ma'am. As we all know, orbit is indeed like a Pandora's box, and we need to keep in mind all the DDs of various suspected pathologies, orbital pathologies. You have given a detailed overview on all various orbital entities. So, what are the clinical features or clinical clues that we need to know to differentiate an orbital infectious or inflammatory etiology?
Infectious or inflammatory, one is signs of sinus tenderness suggestive of sinusitis. Patient usually presents with nasal obstruction, history of nasal obstruction. Patient will be febrile and sick at the time. Severe pain will be there in both conditions. Then you examine the blood, leukocytosis will be there, raised CRP levels will be there. All these will be absent in a plain orbital inflammation. The patient will be afebrile, no history of particular nose block. But very rarely a sinusitis can cause orbital inflammation without being infectious also. But that's very rare. So those are the clinical signs. And blood cultures may be positive in.
Often do we suggest primary blood investigations in like orbital cellulitis?
Always, every patient. Actually, when you admit the patient, insert a cannula, take blood for investigations and start your parenteral antibiotics in one go, and then send them for a CT.
What common investigations are we supposed to send?
Other than lab investigations. Cultures, if there is discharge in the eye or nose, you can send that for culture. Contrast enhanced CT, compulsory. Apart from then, investigations for optic nerve function.
And any case of chronic redness, like are we supposed to suspect CCF also in direct?
Yeah, if it doesn't respond to treatment,
so imaging is
even
important?
There are some cases of indirect CCF that are not cannot be made out on DSA also. So in those cases, they won't go for any intervention, but you can suggest carotid compression exercises. Patients actually respond in many situations.
So would like to ask, in orbital inflammations, for example, dacryoadenitis, myositis, when should we consider the biopsy? Can we primarily treat?
If it doesn't respond, so the first injection of steroid itself will cause improvement in the patient. The first clinical sign is decrease in the pain. But if it, like I said before, if the response you expect is not seen within the first 72 hours, then you'll rethink your diagnosis. Very rarely you can get sclerosing variant of pseudotumor, so which will require a biopsy. So first you rule out all other causes like a CCF, any neoplasia, all other causes rule out, and you still think it's orbital inflammation, then go for a biopsy.
Okay, thank you. Unless I'm not suspecting, if I suspect fungal orbital cellulitis, I will withhold steroids. But in all other cases, I give steroids because it reduces the orbital inflammatory edema. The edema itself compresses all the blood vessels in the orbit, and so much of your antibiotic won't reach the orbit. So in order to reduce the inflammatory edema, the systemic steroid helps very well. And it's also a diagnostic test. Some patients, you think it's orbital cellulitis, but it is actually non-specific orbital inflammation. So the next day, you know, if the patient is almost all right, it's most probably inflammation. If there is just a slight reduction in pain, then I will continue treatment for orbital cellulitis. But always steroids are very helpful.
Yeah, because because
there is actually no contraindication.
Very good, because previously I think we used to think that it's an infective condition.
Even
so
now,
whether it's all right to actually go ahead with steroids.
Even now, a lot of people withhold steroids, like it's infection, so how do we give steroids? But
so what dosage would you do it, and which is the agent?
Dexamethasone, I'll give 2 cc IVBD along with taxim, amikacin and metronidazole if all other the metabolic panel is normal. And by the second day, you know, if the steroid causes a dramatic response, then I will convert the IV antibiotics to oral antibiotics and continue steroids. Then you can fine tune your antibiotic based on your culture reports and all that and response to treatment. But IV Dexa, BD for at least 3 days and then taper rapidly depending on the patient's response. Antibiotic for 10 to 14 days if cellulitis is suspected.
I have a doubt. If the imaging shows subperiosteal abscess with sinusitis and the patient is being taken up for FES surgery, do you wait for the subperiosteal abscess to settle by imaging, or you drain the subperiosteal
Most don't
along?
settle unless it's a very small child, a very small medial subperiosteal abscess. All others require drainage.
If FES is being done from ENT side
along with the FES, if you drain the subperiosteal abscess, that's good. But otherwise, it has to be drained. Some subfrontal periosteal abscess has to be drained otherwise.
You will start steroid along with antibiotics at the same day itself or after?
Same day. First injection, steroid injection plus taxim 1 gram, amikacin and metronidazole will be given. And then you will reduce the antibiotic depending on the results and the patient response. But the first time you give all of it.
We usually start antibiotic first, 3 or 4 days.
Yeah.
Then we will start steroid after that.
Yeah, that's what I said. The rationale is you want to reduce the inflammatory edema so that more of your antibiotic reaches the orbit. So that is the rationale. And usually it responds very well. And many cases, orbital cellulitis is actually a fairly uncommon disease that is commonly diagnosed. So many patients respond very well the next day. So then you know that it is orbital inflammation and not actually cellulitis. But always treat initially as cellulitis and then you can reconsider on follow-up.
Yeah, okay. Very well presented, ma'am. Just that the inflammatory part, most often in infections also, rather than the infection itself, the inflammation is the thing that is causing the damage. That is why we are considering steroids. Thank you.
Okay, thank you.
Thank you, ma'am, for your insightful presentations and the engaging discussions followed. Now, let us have a discussion on how to end the misery and mystery in painful blind eye. When vision diminishes and discomfort lingers, a deeper understanding emerges into the quiet battles faced by those with painful blind eyes. This compelling exploration, titled Relief and Restoration, is presented by Dr. Marian Polly. We invite Dr. Marian Polly, Senior Consultant and HOD, Orbit Oculoplasty and Ocular Oncology, Giridhar Eye Institute, Cochin, for this session.
Okay. Good morning, everyone. At the outset, let me thank Pathanamthitta Ophthalmic Society for giving me this opportunity, and I'm always be very happy with all the Pathanamthitta ophthalmologists. So today, next 10 minutes, I know the meeting is running almost 45 minutes late. So I will just try to stick on to my time. So going to speak about how to manage painful blind eye. So when you manage painful blind eye, it is in simple words, it's a palliative care by the ophthalmologist for the patient. So there are, to start with definition, as per the literature, it is defined as one with a visual acuity of counting fingers or worse with no expectation of recovering function associated with the chronic pain and discomfort for at least 4 weeks. Even though this is in the literature, for me, when in my clinical practice, painful blind eye is always no perception of light or suspicious perception of light. Etiology-wise, mostly glaucoma, trauma, inflammation, chronic RD, etc. And when you encounter a patient with a painful blind eye, do complete ophthalmic evaluation, especially we should be very careful in the examination of the other eye also. And B-scan is a must in all the cases, especially to rule out the etiology and to rule out intraocular tumors. So for us, there are 4 things in our mind. Either it is raised IOP, inflammation, or corneal surface creating the pain, or a combination of all these. So let us see what can be done. So the management falls under 3 headings. Either it is non-invasive, invasive, or ablative. So first start with the topical therapy. So it will reduce the inflammation, reduce the intraocular pressure and ocular surface symptoms. Key principles, always minimize the number of drops which we are giving, because these are going to be a long-term treatment. And lubricating drops, especially preservative-free. Steroids, the type of steroids depending on the amount of inflammation, starting from soft steroids to the high-dose steroids. NSAID is not really recommended because of the corneal adverse events, and along with a combination of cycloplegics and IOP-lowering medications. The other option is to give a retrobulbar injection. Retrobulbar injection of alcohol has been practiced, but for me, in my experience, ropivacaine works well. Why ropivacaine? Because it acts specifically on nociceptive fibers, which is responsible for the pain. In the initial period, for example, when a patient in chronic renal failure presenting with severe painful blind eye, you can give a retrobulbar ropivacaine. It is freely available. What's the role of custom ocular prosthesis? So this is a 28-year-old female post-trauma, painful blind eye due to corneal decompensation, not willing for any big surgeries. So he had BCL, then under BCL he had a perforation, then again we put a glue and BCL, and the one surface is little quiet, we have fitted him with a customized ocular prosthesis. So these are a very motivated group of patients, not willing for any ablative surgeries, but they want pain relief as well as aesthetics. So these are the few patients which we managed following trauma with a customized ocular prosthesis. So now coming to the role of stellate ganglion block and other systemic medications. So now pain management is a separate specialty per se. It's an upcoming specialty. So the role of systemic medications, NSAIDs, but you can give NSAIDs in acute pain, but it's very cautious because it can cause renal problems. The second thing is gabapentinoids. It takes care of the neuropathic aspect. Again, it's better to be done in a consultation with a pain specialist. Studies have proven that it has got effect on painful blind eye, especially due to glaucoma. Another good thing or new thing is stellate ganglion block. Even though I don't have any personal experience, there are a lot of pain specialists doing this stellate ganglion block. So when I searched in the anesthesia journal, there was an article. It was tried in painful blind eye due to glaucoma, where they have used bupivacaine. So stellate ganglion in the cervical chain, where you inject bupivacaine and clonidine under ultrasound guidance to the stellate ganglion. Here you should be very careful. It has to be done by a very experienced person, because all the major structures like jugular vein, carotids, etc. go through that area. And the second thing, it supplies to the other areas also. So you can get a transient diaphragmatic paralysis also. But still, this is a block that can be tried in some of our painful blind eye cases due to glaucoma mainly. So now move to an invasive treatment. Our aim is to decrease the IOP. So here we can do either transscleral cyclophotocoagulation or a cyclocryotherapy. IOP reduction by 30% and pain relief by 30%. So most of the time they will be okay with cyclocryotherapy and avoid 3 o'clock and 9 o'clock because it causes phthisis sometimes. So coming to the treating ocular surface, because due to the very bad corneas can cause severe pain, photophobia, and they can't work. So in that case, we can do a Gundersen flap or even amniotic membrane transplantation. So what does Gundersen flap do? Because it prevents the tears and proteolytic enzymes to reach the corneal surface, causes vascularization, and avoidance. The bullae will not be exposed to the atmosphere, and it reduces the corneal sensitivity so that later we can put a prosthesis on the top. So this is one patient managed with a Gundersen flap. So this is 1 week post-op and this is 1 month post-op. So if he's aesthetically, he's okay with this. If he's very much concerned about aesthetics, either you can put a cosmetic contact lens on the top, or you can leave it like that also with the tinted glasses. So now after non-invasive and invasive treatment, we'll reach the ablative treatment. So painful blind eye management is a stepwise approach. When a patient first presents to you, it's better to treat them conservative initially and then only go for ablative treatments like either evisceration or enucleation. So as we know, evisceration includes removal of intraocular contents, leaving the sclera behind, whereas enucleation, we remove the entire globe and sclera. Video this I am skipping. After doing a peritomy, the main thing is after removing the intraocular contents, you have to wash the sclera with absolute alcohol because this alcohol will destroy the nerve endings. Otherwise, sometimes after evisceration, patient can present to you with phantom pain. Again, that can be a problem. So my technique is 4-petal evisceration where sclera is divided into 4 petals with the recti on each petal and horizontal recti sutured together, vertical recti sutured together on the top. Suture the tenons and conjunctiva together. It gives good implant stability and good aesthetic results also. So enucleation, in my practice, painful blind eye always prefer evisceration, but if you are suspecting an intraocular tumor, always go for enucleation. So this is a case of choroidal melanoma who underwent enucleation with a ball implant. So now again a confusion will come, evisceration or enucleation should I do in this case? So I already told evisceration will give no pain and give a proper diagnosis, good cosmesis and prosthetic motility, less complications and good long-term outcome, and the surgical technique is also very simple, less operating time and flat learning curve. So now in terms of complications and pain relief, which is best? So there are different studies say differently. In British Journal of Ophthalmology 2000, they have found a similar outcome between both enucleation and evisceration in terms of pain relief, complications and postoperative discomfort. Whereas in OPRS 2019, where they studied around 28 patients, they preferred evisceration over enucleation in painful blind eyes. So now comes is sympathetic ophthalmia a concern? So we have few case reports, but the big data says they have not seen a single case of sympathetic ophthalmia. This is in 1999 OPRS, Ophthalmic Plastic and Reconstructive Surgery Journal, 880 cases, no sympathetic ophthalmia. Similarly, this is from 502 cases of trauma, no sympathetic ophthalmia. But still, we will always take care to remove the whole uveal tissue. And if it is a non-infective case of evisceration, I add steroids also. So coming to few cases, this is a female who presented to us with a painful blind eye, and she was under our care from 2018 onwards. She was a high myope, so she was not really bothered about her vision, and she had chronic RD. So when the pain started, she actually presented to us, other eye was normal. So this is her 2018 B scan, showed a chronic RD with a calcification in front of the optic nerve head. This is 2020 B scan, more or less similar picture. So initially she was managed conservatively because she was not willing for any drastic procedures. Finally, we planned her for evisceration, but intraoperatively we had a suspicion of mass, so converted to enucleation with the biopsy from extraocular muscles, and it turned out to be an RP adenocarcinoma. It's a very rare case, but sometimes this can happen. Even though posted for evisceration, intraoperatively, if you think anything abnormal, better to go ahead with enucleation. Another case, again, 50-year-old male treated chronic diabetic with a facial palsy, exposure keratopathy, panophthalmitis, post-intravitreal antibiotics since 8 months. He had a history that he was being treated for chronic lymphatic leukemia. So he was also posted for evisceration, but intraoperatively the whole sclera was necrotic and converted to enucleation. This was also a combination of Richter syndrome with tuberculosis. That's a very rare complication of CLL, but we have to keep in mind intraoperatively. So finally, psychological consideration is very, very important because reduction in visual field and stereopsis, most of them will have some anxiety, and there are lots of queries from their side, job-related queries, driving license. Always stress for regular follow-up and tell protective glasses. So to conclude, always quality of life remains most important when you treat these patients. We have to be empathetic and not sympathetic. So management depends on the mutual discussion between the patient as well as the doctor, varies from topicals to ablative treatments. And finally, psychological counseling is very, very important as they are going to be one night. Thank you.
Thank you, ma'am, for that detailed and novel approach in the management of painful blind eye. So, few doubts. One is how long the retrobulbar injection works?
Yeah, I have given ropivacaine. It lasts only for 1 day because usually patient presents with severe pain, they can't do anything, vomiting, etc. So ropivacaine will last only for 1 day. By that time, you can start something oral, and then by that time, the patient will come all right. Chlorpromazine has been used. It will last up to 1 year, but I don't have any personal experience. Alcohol also, I don't have any personal experience.
And when should we consider help from a pain specialist? Is it for both the physiological pain as well as the neuropathic pain where it is damage to the nociceptors? Or is it difficult to identify?
It's actually a very good question. So while I was preparing for this talk, I actually spoke to the pain specialist. The thing is, there are very few people who practice only pain, especially in Ernakulam, only 2 people. So you have done your level best, still patient is symptomatic, but he is not willing for any ablative procedures. So in that case, you can discuss this option with them and always speak to the pain specialist also what you are aiming for. Because stellate ganglion block is the one that can be given, or oral gabapentinoids. So these 2 are the options for them, but I mean, it should work. So when I discuss, they are willing to do, but then we have to give the patients.
Okay, and I think this is a very good topic and big applause to choosing this topic to the organizers, because often when the topical treatment fails, the next line is evisceration. But often a set of patients, they choose to live with the pain than losing their eye. So I think we have to think in line of your other modalities of management. Any questions from the audience?
That's actually very, very important. Actually, I am the last person in managing the painful blind eye. Before that, all others will see. So before a patient undergo enucleation or evisceration, at least 3 doctors in our hospital will see. Because even if I see one patient, I will send to the cornea, whether can you do something for this? I will send to glaucoma, can you do something for this patient other than evisceration? If they say no, then only I will do something. Okay. So that is very, very important in our practice.
In order to prevent sympathetic ophthalmia, you told that in all cases you will give steroid, either systemic or topical.
Systemic. Non-infective.
Okay.
For 1 week.
For one week only.
Thank you.
Thank you, madam, for your insightful and inspiring presentation. Now, I request Dr. M.I. Varghese sir to hand over token of appreciation to the moderators and speaker. I welcome Dr. Anju Suresh. I welcome Dr. Anju Suresh. Dr. Marian Polly, Dr. Preeta Nair AK, Dr. Shevin Salim, I request chairpersons and speakers of the session to engage in a photo session with Sir.
Thank you, everyone. Next, let's dive into one of the most prevalent surgeries out there, cataract surgery. Though often routine, it can throw a few curveballs your way. We invite the chairs of this session, cataract memoirs, Dr. Satish Thomas, Professor and HOD, Believers Church Medical College, Thiruvalla, Dr. Dahlia S., Professor, Government TD Medical College, Alappuzha. With a best corrected visual acuity of 6.6, one might expect that our patients leave the clinic feeling pleased and fulfilled. Yet, it is crucial to consider the situations where these expectations fall short. To deeply explore this important matter, unhappy 6.6 red-faced patient, I invite Dr. Sony George, Head of Cataract and Refractive Services, Vasan Eye Care Hospital, Cochin and Thrissur. Over to you, sir.
A very good morning, Oculars, Ophthalmic Society of Pathanamthitta, delegates, faculty, and dear friends. At the outset, let me thank Dr. Shane for inviting me to be here for the prestigious annual CME of Pathanamthitta Ophthalmic Society. And I also thank Dr. Chaitanya and the team, OSP, for all the help. Okay, now I've been talking about this topic for quite some time, and recently when I was attending one of the scientific programs, I got a new insight. That is, if the patient is already unhappy before cataract surgery, then it's not very easy to make him happy after cataract surgery. And this is not one of those procedures to make an unhappy patient happy. So we will be dealing about patients who are otherwise happy other than their visual problems, but become unhappy after cataract surgery. And why does this happen? It's obviously a mismatch between the expectations or our promises and what actually happens in real life. So what does a patient expect from a cataract surgery? And of late, we have been promising the moon to most of our patients. Like, we have oversimplified this procedure as if, you get back to your 20s or 30s and see everything. And that is the reason we have more 6.6 and 6 unhappy patients these days. So you promise them quantity of vision the Snell lens quantity, the improvement in vision, and we also promise them quality of vision. And at certain points of time, describing the quality of vision post-operatively also gives a little bit of a problem. For example, you counsel a patient for multifocal or a trifocal, you tell them you can see everything, and at the end of the day, patient wants to read the ampule, injection ampule, or most of the time reading the medicine strip, and most of the time it will be the medicine which you have given post-operatively, and you had it. So it's always better to under-promise and over-deliver, especially in cases of premium IOLs like multifocals. We will come slowly in detail about most of these things. Maintenance of vision is very important because an early PCO can make the patient very unhappy. So while you counsel, you have to tell the patient about why you are going for a better material like a hydrophobic material which causes less PCO, etc. Ocular comfort. Patient is very bothered about the ocular comfort. Most of the time you miss out some lid infections, lid margin disease, and otherwise the patient would have washed his face daily. He doesn't wash for a period of 45 days and everything gets aggravated and the patient really becomes unhappy. And we always promise them a painless and comfortable, painless, stitchless, injectionless, and if they have a bad experience during surgery, again you had it. And vision-related complaints, most of the important thing is can't see properly. Mind you, we are talking about 6/6, N6 unhappy. We have to tell the patient, especially if it is a multifocal, etc. There is a split up of light. Like for example, it's 50% for far. So obviously they will need more light. It's not in the common scenario, but when the patient is in a low light situation, like see if all the light is put off because the slide has to be seen, he's going to be unhappy. And for near and you have to clearly explain, you need more light. You cannot read in a dark corner of your room. Earlier when you didn't have a cataract with a +3 addition, so obviously you should be able to do that. Night driving issues definitely has to be told to the patient, especially if it is you're dealing with multifocals. Can't see fine print, just like I told now, and color perception problems. Although you did a very good surgery, the first 2-3 days I am seeing more red, more yellow, more blue. That again has to be counseled properly. And other problems, I mean, you think it's only about the vision, they are unhappy. Itching, watering, discharge, especially if they don't clean, if you don't insist on cleaning the lid margins after cataract surgery, it is going to be a real problem. In fact, all the itis after, it's a fantastic title, itis. So most of the itis actually is aggravated. Cataract surgery causes an itis, inflammation. Now, the lid margin is the home ground for all inflammation. In fact, one of the studies in Nethralaya, now they propose to start lid hygiene at least 3 to 4 days prior to cataract surgery to reduce the inflammation so that the patient is more comfortable. Eye pain, intractable eye pain in certain cases, we have to resort to certain measures. Photophobia. So I never give my patient dark glasses, okay. Might as well start suffering from day one, and instead of giving dark glasses for 1 month and then he goes out and he has photophobia, you might as well start everything from day one. So you're okay by the end of 1.5 months. Small eyes after cataract surgery, especially if you give a block, patient can complain of that. Cat eye reflex, much reduced after the aspheric IOLs. Color perception defects. Because with a brown cataract, they would have seen a totally different color. Now suddenly in one eye, they have a brown cataract, the other one, it's a clear lens. Now they have a disparity between the lens. But these things, you can always, too bright and too dark. Too bright, we can deal with it. We can tell them, okay, all the while you had 10% of light entering, now it is 100%, so it's okay. Too dark, you have to be careful. It might be a, subtle macular edema, cystoid macular edema. And so how do we deal with it? See, most of the time it is an ocular surface disorder which is predominantly the reason, and dry eye. So you see, we have forgotten that the tear surface, tear film is one of the refractive surfaces other than the cornea and the lens. So unless you have a healthy ocular surface and the tear film, you will have a very unhappy patient. And every step has to be taken to make sure. And the biggest sufferer of this is the multifocal lens. Because oftentimes than not, it is not the multifocal lens, it is the ocular surface which is the cause of an unhappy multifocal patient, and we blame it on the lens. And that's why actually the growth of the multifocal practice was hindered many a time. Higher order aberrations, definitely it will cause amount, especially in multifocals. IOL alignment, dysphotopsias can be really difficult to the patient. A residual cylinder or a sphere, posterior capsular phimosis, or a PCO, and subtle retinal pathology, all this. See, if you have a patient like this, unless you treat him properly, he is going to give you misery. Because as it is, he has got a blepharitis. It is dangerous to operate on this patient for chance of endophthalmitis. But otherwise, after surgery also, if he is not going to clean, his eye is going to be miserable. And again, MGD, you have to treat this patient because otherwise the ocular surface is going to be very, very tough. See, if a patient presents like this after surgery, he's going to kill you. Every time he puts a drop, and we give Nepafenac also to prevent CME. So the patient had it and he'll heal this thing. Second is the dysphotopsias. You have the positive and the negative. Positive, most of the time we are talking about the multifocals because as it is, it reduces the contrast sensitivity, and that's because of the loss of light. Now, with the newer generation, with the EDOFs, it's come down to almost 10%. And this 10% is the reason for all the positive dysphotopsias. The lower the loss of light, the lower the dysphotopsias, to make it very simple. So this is how the patient still, our optometrist will make sure the patient reads E in all these situations, but you know how the patient feels. And the other reason is because after cataract surgery, there is a lot of space which was occupied by the crystalline lens, which is free now. The optical zone is 6 instead of 12, and then there is a space, the posterior chamber also is bigger. So there is a lot of reflection from the, instead of the 12 millimeter, the lens is only 6 millimeter. You can have edge glare and internal reflections, and this is what the patient sees. So obviously, in these kind of situations, the patient will be unhappy, and this is the multifocal which can give you all this kind of phenomena, the glare and the flare. And the negative dysphotopsias is because of the light entering through this area. And this is how the patient complains of a temporal crescent. So basically, one thing which can be tried is to try the reverse optic capture. Bring the optic out of the capsular bag and place it so that the edge glare becomes much lesser. Okay, now looking at the lens implants, okay, this is a perfect lens with a good 5 millimeter. The effective lens position is the most important thing we have to make sure during a multifocal implant. So there should be at least a 0.5 rim covering the anterior lens surface. And these lenses obviously will do well. See this, there is a peripheral PCO, and you see the irregular contracture of the anterior capsule. And see here again, it's a well done multifocal, but you see the edges jumped out. So the ELP is going to be a problem. There will be some amount of definite residual cylinder. Here again, it's the same case. Okay, always make sure the centration. There is no doubt this lens has to be explanted, and you have to go ahead with a new lens. Any early PC fold, especially in a multifocal, since it's reduced the contrast sensitivity, the patient can be very unhappy. PCO, obviously you have to do a YAG and make it clear. Capsular phimosis, although an undilated pupil, you may not see anything, this is definitely going to cause this thing. So to sum up, preoperatively, always rule out and treat as a dry eye or a surface disease, a good keratometry so that there is no residual astigmatism, OCT macula to make sure you are dealing with the right patient, especially for a multifocal, proper counseling and a good chair time. You have to explain all these things. The doctor as well as a counselor, proper communication, good surgical techniques. See, you do not wet the ocular surface during the surgery. Finally, the patient will end up with a very unhealthy corneal, and the reepithelialization can cause a lot of difficulties in an unhappy patient. Post-operatively, don't panic, don't blame it on the lens, look at the reasons for it one after the other, and if there is a residual cylinder, you can always do a bioptics or a touch-up. If nothing happens, reassure the patient and also distract the patient due to some reasons. Okay, you have to tell them some exercises like pencil push-ups, make sure everything is okay. Okay, by the time the neurological adaptation will happen, okay, I tell them to do pencil push-ups. I don't know for what, but yeah, it's a distraction. Okay, so precise biometry is very important. Detailed slit lamp and the centration of the IOL, the disc status and comorbidities also have to be taken care of. And maintenance of vision, always advise a better IOL so that the better material so that the PCO is prevented. And always look at treat the lid margin, and intraoperative, like I said, you have to keep the eye wet all the time. Post-operative, make sure the patient at least for 45 days cleans the lid margin properly. And counseling, and on the day of surgery, okay, always alleviate the anxiety. I always give a 0.5 mg of Alprax. I find that most of the cataract surgeons don't give any anxiolytics these days. I always make it a point, except patients who have undergone dialysis or something like that. The moment you give 0.5, he'll be deep asleep, then you have to give a block and do the surgery. And this, in short, I think in 10 minutes, this is all what I can say about this. I hope I made sense. Thank you very much.
So thank you, sir, for that overview of what most of our patients will be telling. How often patients tell about these dysphotopsias and all? Or have you done experience with reverse optic?
Yeah, dysphotopsias regarding a monofocal. See, if it is a multifocal, I don't do any of these things. Okay, most of the negative dysphotopsias, I've tried out in maybe 2 or 3 patients, and I don't know whether it is because of the surgical procedure, or the feeling that something is done. The patient was happy after that. The other causes like the post-operative, the multifocal patient, etc. If you spend time with the patient and screen out, if a patient who does a lot of night driving, you have to literally tell them, if you're desperate, you can drive, but then this is not suggested for you. And you can go in for one of these EDOF lenses. So they are quite comfortable. They can drive at night. Many of my EDOF patients drive at night. Even in Dubai at 120, they don't have a problem. Never ask the patient if you have a problem. Once they come to you, check binocular unaided vision and ask them, how are you? That's all. And your optometrist has to be informed, don't put any lens in front of that eye. Make them read unaided and then that's it. You can check your refraction. If that fellow puts a 0.5 cylinder, gone. Then he'll sit on your head. Okay, so unaided 6/6 parts N6, 6/6 N6, happy. If it is below that, then you send him back, ask him to do it in a very subtle manner, do the retinoscopy, don't put the lens. Lens, we can put. Yeah. That's what I do. I think the chair time is very important in these patients.
So when I read, one of my presentations, I read about it. Piggyback lens, when there is as you told, there is a space between that is producing the dysphotopsia. Yeah. You can also try a piggyback lens other than reverse optic capture.
Reverse a piggyback lens to be
because the space will be reduced. For
that is one. The second thing, if there is a growth of epithelial cells between the two, then it can be another trouble. Then going in again and cleaning between the lenses is not a really comfortable thing. You cannot yag it also because it can damage both the surfaces. I haven't tried it though.
Truncated edges, does it produce more
Which one?
The edge designs of the
truncated definitely it decreases. Okay, the absolute square edge, instead of that the posterior can be still square, so that it prevents PCO. The front can be modified. That also definitely helps. But no, of late, it has come down drastically, especially with the aspheric lens designs.
We don't have too much time for discussion in this session, so thank you, Dr. Soni, for this wonderful presentation.
Thank you so much.
The problem is the mismatch between the expectations of the patient and us surgeons. We see that the patient has 6x6 post-op, and we can appreciate how wonderful the eye looks on the slit lamp. But the patient is worried about a lot of other things, and Dr. Soni covered the whole range of problems that that lead to this mismatch. Can I invite Dr. Matthew Kurian for his next talk?
Next topic of this session is complicated cataract, tackling the itis and sequelae. Effectively addressing the challenges posed by inflammation and managing its subsequent effects necessitates a blend of surgical expertise, clinical judgment, and a great deal of patience. We are honored to invite Dr. Matthew Kurian, the Medical Superintendent and Head of Cataract Services at Chaithanya Eye Hospital, Palarivattam, to deliver the informative session. Over to you, sir.
Thank you very much. Thank you, Shane. And it's good to be back in Pathanamthitta and THIRUVALLA. This is the second time over here. And I see that the meeting has grown in stature and interest. Like Dr. Soni just mentioned, Alprax is a good indication preoperatively. In complicated cataract, 1 tablet for the patient and 2 for the surgeon. Okay, so this is in fact a family friend of Dr. Shane and his mum. 38-year-old female diagnosed with Behçet's disease, left eye uveitic cataract. Vision is down to 1/60. Early band-shaped keratopathy starting on one side, complicated cataract, pupillary membrane, small pupil non-dilating, almost 180 degrees of peripheral anterior synechiae, fundus is hazy, with barely any view, hardly glow visible, and the B-scan just shows that the retina is on, not much in the posterior side. So I'll just run through the surgical video and discuss things as we go. Okay, so paracentesis. Next, what we need to do is to stain under air and make sure that the stain goes under the posterior synechiae, so that once the posterior synechiae break over here with viscodilatation, the areas which were covered by iris is also blue. Then the pupillary membrane can be peeled, needs to be peeled with microforceps, and the microforceps itself is used to complete the capsulorhexis, and good control is achieved. Then hydrodissection, very good cortical cleaving hydrodissection ensures that residual lens matter and postoperative uveitis is minimal. This is a young patient, so just phacoaspiration is required, and with little or no power in several of these uveitic cataracts, we are able to manage to get rid of the lens matter. And then hydrophobic acrylic lens goes into the eye, and it needs to be placed in the bag. And all these things, we need to make sure that it is done as atraumatically as possible. A surgical PI, I do it with the vitrector, high vacuum, low cut rate, and then finish off the surgery with intracameral dexamethasone as well as moxie. The peripheral anterior synechiae, I discussed with my glaucoma consultant whether we want to release that, but we felt that that would increase the postoperative inflammation and decided to leave it alone. And this is the postoperative picture. Uncorrected vision, 618, quiet anterior chamber. IOP is controlled, the patent PIs are there. There was a debate whether to use pupil expansion device, but again we felt that minimizing iris handling would be the best option. And there is primary PCO, defer YAG capsulotomy for the time being, wait for the eye to settle down. And to summarize all the precautions that we took, Dr. Natasha here, I have taken anticipatory bail. All medical management questions need to go there. Ensures that the eye is quiescent preoperatively for at least 3 months, using a combination of topical as well as oral and steroids plus immunosuppressives as required. Preoperative complete evaluation is required. In de novo cases to identify the cause, rule out infective etiology, and it's good to be able to liaison with a rheumatologist or an immunologist for ruling out systemic diseases. Intraoperative considerations, already I mentioned, small pupil management with hooks or rings, but avoid to the extent possible. Capsular support, anticipate zonular weakness, so have a CTR ready. Minimize complications. We don't, already the eye is inflamed, adding to the problems with the posterior capsule rupture, difficulty in placing lenses, etc., is going to create new complications. If there is a PC rent or a zonular dialysis, probably it is better to leave that eye aphakic rather than try to do unusual positions of lens implantation. If it is not in the bag, don't put it in. Then minimize iris manipulation. So angle, peripheral anterior synechia release, pupilloplasties, etc. are all not a good idea. And we want to have a hydrophobic acrylic single piece lens in the bag. Post-operative considerations are very much longer than normal. So if it's like 4 to 6 weeks in my routine cases, here it would be probably at least 3 months, if not longer, of topical and 4 weeks of oral steroids, starting 1 week preoperatively and going on at say 10 milligram tapering per week, and the topical will be a much longer and slower taper. Monitor for complications, cystoid macular edema, IOP spikes, recurrence of inflammation, posterior capsule opacity. And the follow-up, normally I would do day 1, 1 week and 1 month, and then annual checkup. Here it would be probably day 1 in between 3-4 days, then 2-3 weeks, 1 month, 3 months, 6 months, and then maintain the patient on a 6-monthly checkup. No further intervention in the eye unless it's absolutely mandatory, and defer to the extent possible for at least the first 3 to 4 months after surgery. So this is another case where I had was a 68-year-old male. I did his left eye surgery. He was very happy. And in his right eye, he had this white membrane. He doesn't know quite what is the problem there, but he has had this from childhood. I said, like, see, why don't you try to get this white membrane out? It's quite cosmetically obvious as well. And if I get good vision, I'll be happy. Posterior segment showed that there was a complete PVD and a little more myopic fundus, but not very much else. So I was thinking phaco, SICAs, Yamane, what to do, and then this is what stained. Not able to get any decent pupillary dilatation, so I decide I have no option but to do hooks. The posterior segment, the posterior synechia quite strong in that corner. So now here, if I can pause this for a bit. So you can see actually the membrane is contracted. It's just one flat piece, it's contracted, and the ciliary body and the ciliary processes are visible over here. This is the first time I've seen something like this. So I was not quite sure what I was going to get into. But anyway, since I reached here, I tried to puncture it, not able to puncture it with the needle. I tried to cut it with the cutter, not able to cut it with the cutter. Finally, using a microforceps and a bimanual technique, I was able to dissect this thing. The glow, as you can see, in one area is very much altered, in another area looks okay. So got that out, did an anterior vitrectomy, and placed a multi-piece lens in the sulcus, closed everything, looked okay, and post-operatively, you can see this is a pre-operative evaluation. There is a squint, so he was counseled about the possibility of amblyopia. This is the left eye posterior segment. Right eye posterior segment is quite distorted, tilted disc, very gross alteration of the architecture, and no really a good expectation of vision. So neither he nor I know what happened in the past. It was just a membrane, it is not a lens itself, and I really don't know what to expect in the future, whether that will go into phthisis or whether it will remain quiet and remain the way it is, I don't know. But again, basic thing was preoperatively inflammation control, post-operative inflammation control, monitor for IOP and other problems. This is 636 vision. phaco was done about 2 months back. No trauma subsequently, no previous history of anything significant. Immediate post-op was 6.6 and a recent drop in vision. Anterior capsule phimosis, but why should I attempt to YAG it? Should I pull the entire thing out, or what to do? So again, what I did was, this one looked a lot thinner than the previous one. There's a IOL in the bag, and I just used a cutter, cleared up the entire thing, and high vacuum, high cut rate, the entire thing came off. I anticipate that there is going to be future issues with the lens centration and stability, but in the immediate post-operative period, this one was doing okay. What to anticipate in the other eye is something that I don't know. And with that, I thank you for your attention.
You give systemic steroids in all cases of difficulty?
No. So I'm fortunate. Where I worked earlier, I had Dr. Padma Malini, who's an international figure in uveitis, and currently I have Dr. Natasha. So I take their advice on which patients to start with systemic medication. But essentially, if topical medication is not going to keep the anterior chamber white and quiet, and no cells, no flare, then I think those individuals require to be on oral steroids preoperatively, at least for a week, if not 5 days.
Other agents which are given other than steroids?
So your uveitic patient who has developed cataract needs to be inflammation free. We say 6 months at least, but minimum 3 months. And also the speed of control of the uveitis is important. If you have been able to control it reasonably fast, then you can operate after 3 months. But if it has taken a long time for you to get the uveitis under control, then it's better to wait for 6 months. If the patient, most of the time your patient will be already on a steroid sparing agent and on a steady dose to get your inflammation under control. So in such patients, just a short course of 4 to 6 weeks steroid to cover the time of your surgery is essential. If you are looking at a cataract which looked uveitic, but the patient has come to you, there is no inflammation at all, but you think there are evidence of there are Seneca and there is old KPs, but there is no activity now. You don't know how long the activity has been there and when did the patient get controlled. So those patients also, you should go ahead with caution. Don't just post for surgery immediately. Wait for a few months, see if the inflammation is coming back. And in those patients, you don't have to start a steroid sparing agent if there is no other systemic cause. Here you just give a short course steroid when you're taking up for surgery, but try to give at least, explain to the patient that this is not a straightforward cataract. and it will require at least 2 to 3 months of observation to see if the inflammation is coming back, and then under cover of steroid take up for surgery.
Any role for Orlay cyclover in patients, cataract patients who have previously had a viral keratitis or something?
If you have a documented viral keratitis that the patient had and viral keratouveitis, I don't think prophylactic during the surgery is required, but chance of the inflammation coming back can be explained.
In congenital cataracts, you always give steroids, or depending upon the inflammation?
It's, I think only in terms of the inflammation, yes.
I just have a small doubt. There are sometimes when you cannot control the inflammation completely. No matter what we give, the last bit of cells and flare doesn't go away. And they develop bilateral cataract and the vision drop down. Now we are left with the point in which we have to restore their vision sometime. So are there any red flags by which you say that no, I will not take it up at any cost, or some sort of adjustment that we can give in such situations, at least in operating one eye? Or would you like to add another agent during surgery in these patients?
A child.
Yes, yeah, exactly. I'm looking at the JR.
Contraindication. Do not touch. Without controlling, whatever you need to do to get it under control, add another agent, which means systemic steroid sparing agent, get them to be on a higher dose, shift to biologicals, whatever you need to get the inflammation under control, and then only take up for surgery. But like you said, bilateral and really poor vision, then you can pulse and take up for surgery. But all that under very high risk, only if you're absolutely sure child is not able to function, that much reduced vision, like you're looking at 2/60, 3/60 in both eyes, then maybe under pulse and high dose steroid you can take up. But generally they have severe exudative reaction. So, and once the vitritis sets in, you've lost the eye, then it's very difficult to get it under control.
Role for an intravitreal Osidex along with cataract surgery?
Yes, we do give intravitreal Osidex in patients who can afford, and it is surely it is a non-infective, like a JIA kind of uveitis. You can give intravitreal Osidex along with your cataract surgery, or use it to control the inflammation. But usually just for a chronic anterior uveitis, Osidex doesn't have much role. So it has to be a condition in which there is some posterior involvement, like you're looking at a Blau syndrome or a infantile sarcoid that has pan-uveitis and a cataract, that has more role in giving Osidex than just JIA uveitis with anterior uveitis and cataract alone. Prophylactically, to prevent inflammation during your cataract surgery, no.
I don't think you'll ever find a situation where there is no flare in these patients.
Yeah, flare itself
will always be there.
That's right.
But cells, I think we should wait 0 cells or maximum 1+ and then take a call.
1+ onnum pattathilla, sir.
No, but in this kind of a bilaterally blind, one cell, yeah.
No, but the Western world has moved towards 0 flare as well. So they use a flare densitometer and assess flare in children. This is pediatric uveitis. The flare also is an indicator of inflammation, is what the newer literature says. So you're moving towards no flare. Currently we are looking at minimal flare and occasional cells. But we generally, these children, once they get under control, they will remain controlled for a long time. The thing is to just what combination will give them good control, to figure that out. That is the only trouble.
Regarding this capsular thyrosis, usually in post-uveitic or complicated cases we see this. And is it due to the small rexis because of the undilated pupil or something related to that?
If we start with any rexis will likely have phimosis. So if you have done a can opener, the likelihood of rexis phimosis is not there. But in the presence of a can opener, the possibility is that one or both haptics may come into the sulcus. So a can opener is not a good option in uveitic eyes. Preferable to go for a rexis. But when you do a rexis, the small pupil or a combination of other issues may make your pupil size smaller than normal. So what I typically do which because of want of time I was not able to show, is that end of surgery I will look at the lens in the bag and I will try a double rhexis if I feel that in any of these patients the rhexis size is slightly smaller. So my normal phaco is maybe a 4.5, 5. I am quite happy to leave it alone. But in a uveitic eye, I will go for maybe 5.5. I don't mind if it is little more than 6 also. PCO is the least of their worries. One thing that I forgot to mention, early PCO in a uveitic eye, don't yag. You are likely to have almost immediate retinal detachment. So that is going to be the end of that eye. So wait for 4-6 months before a YAG capsulotomy if at all required. I have lost one patient's eye. 2.5 months after the surgery was done, there was a membrane opacity reducing vision from 6.6 to 6.9, 6.12. I did the YAG. Next day she came back with total RD.
Child with JRA or sarcoidosis, 6-year-old, 7-year-old child with a near mature cataract. You get the inflammation under control and you do the surgery. What is your take on IOL implant? Will you implant it in all the cases, or would you?
So let me share an anecdote with you. Dr. Padma Malini had this very complicated bilateral uveitis patient who wanted to get operated out of Rahu Kalam. First I got operated. For whatever reason, the surgical list was such that I started the patient on the table just as Rahu Kalam started. I found it a lot more challenging than I expected, releasing the synechiae, doing the rhexis. I ended up losing the bag, ended up losing the, leaving the patient aphakic. Patient was very understanding and said, "Doc, you tried your best." The entire surgery was during that 90 minutes of Rahu Kalam. But they were very insistent when I did the other eye that we do it completely out of Rahu Kalam. So they looked at a day when Rahu Kalam was in the morning and I was operating in the afternoon, made sure that it went well. Operation finished like that. Equal amount of posterior synechiae, maturity of cataract, everything appeared the same, but surgery went in 5 to 10 minutes. Alcon IQ in the bag, no problem, everything beautiful. Post-operatively, the aphakic eye with a +10 reached 6.6. The phakic eye, vitritis posterior, which was not there preoperatively, developed membranes, cystoid edema, and then slowly that phakic eye, for which they were very thankful that I did it outside Rahu Kalam, ended up being the non-seeing eye. So it's very difficult to look preoperatively and say how the eye will behave post-operatively. You just keep your fingers crossed. Do your best, but like I said, preoperatively as less inflammation as possible, intraoperatively as less manipulation as possible, post-operatively keep very frequent, very long follow-up with as high dose of steroids and steroid-sparing agents systemically.
Thank you.
Unless you have an intraoperative, you don't have to leave the patient aphakic.
Now, why I asked this question is, I had operated a child, 6-year-old. The child was almost, debilitated, couldn't go to school. I operated both eyes, toric IOL, patient vision came to 6.6. And then suddenly the uveitis, the child was very cooperative. I could give a posterior substance under topical. But the vision was going down drastically, and I referred for a second opinion to the place of their choice outside Kerala. The first thing they did is yank out that IOL. And then the next thing is phthisis. So you feel very bad after giving the patient a 6.6 vision from a near mature cataract. And then the explanation is it is because of the IOL. Everything happened because of the IOL. So I mean, just wanted to know what is the... Yeah.
It may or really may not be anything to do with the IOL.
Yeah. That's what I thought, but this is from a premier institute, and then the patient is really, you know.
But then if the patient comes with severe inflammation post-op, then they do explant the IOL, because that is the only way to get the inflammation under control. Take the IOL out and do a vitrectomy, and sometimes put in oil also, make the patient aphakic.
Problem is, once you yank out with all the zonules, no, it's sure going into, instead of
Thysis.
removing it, it will become thysical.
So then
That's a very
that
painful.
cannot do an anterior alone. It has to be combined with a vitrectomy and sometimes oil also.
The second surgery
Many a
itself will
times-
incite more inflammation.
More inflammation.
Many a times there will be cyclitic membranes covering the ciliary body,
So that has
which
to be
will
cut
definitely be missed.
Yeah.
Nobody will see that. And then post-operatively that increases. Ideally you'll have to strip that, while you're doing a vitrectomy, you'll have to strip that out as well. And then finish it off, but which may not be possible all the time.
Just something I remembered about your question, hypotony. If you ask
Yes.
me one red flag that you should avoid surgery in, it is hypotony. Any IOP less than 10, do not take up for surgery, because there severe inflammation, ciliary body suppression, your IOL implantation will result in thysis.
And also it can have severe post-op inflammation.
Yes.
Yeah, UBM is and another technique. If the pupil dilates a little bit bigger, you use an indirect ophthalmoscope 20D to see the fundus. Similarly, if you ask the patient to look to the opposite direction and hold your 20 lens back, you will start viewing the iris and the iridolenticular recess. And in an aphakic patient, you can definitely see. While doing vitrectomy, we have methods with a hockey stick knife, hockey stick, tool. We can actually depress that area and see the ciliary body.
Thank you, Matthew.
Thank you so much for that lively session. Next, to thoroughly investigate the critical questions surrounding the efficacy of extended depth of focus EDOF lenses, we invite our next speaker, Dr. Aditya Joshi, Senior Consultant Ophthalmic Surgeon, Amita Eye Care, Thiruvalla. He'll be sharing his insights on the topic, EDOF, is it doing justice? Over to you, sir.
Thank you so much. Good morning, all. I would like to thank Dr. Shain sir, Dr. Chaitanya and the whole organizing team of Nethram for this opportunity. And my sincere thanks to my teachers, Varghese sir and Amita ma'am, for the guidance they gave me. So my topic is totally different from today's theme, so take it as a palate cleanser. I don't have any financial interest in any of the products presented over here. And this presentation is a part of ongoing research at Amita Eye Care. EDOF IOLs, whether they are just doing justice. So these IOLs are presbyopia correcting IOLs. They utilize the principle of principle of creating single, continuous, elongated focal point to enhance the depth of vision. EDOF IOLs have a better range of focus as compared to monofocal IOLs, and they provide intermediate vision in addition to a good distance vision. They reduce the spectacle dependence and have less dysphotopsia symptoms. There are mainly two types of EDOF IOLs. One is spherical aberration based, where an IOL surface is modified to create a small positive aberration in the center of the IOL, which gives a better depth of focus. And the other one is wavefront shaping technology, where two surface modulations are created on the surface of the IOL, and they stretch the wavefront and extend the focal range. The American National Standard Institute and American Academy of Ophthalmology have given some set of criteria for an IOL to be termed as effective EDOF. At Amita Eye Care, we have undertaken a study where we have compared two enhanced monofocal IOLs, or EDOF ones, where spherical aberration is used, that is Eye-Hans and Swissfo, and the wavefront shaping one, that is a VVT, and compared them against pure monofocals like Clarion and Vivinex. We included the patients with cataract and age more than 40 years, with no other ocular comorbidity, less than 1 diopter of precorneal astigmatism. Surgeries were done by 2 qualified experienced surgeons with standard surgical techniques. And the outcome was measured as postoperative uncorrected distance vision, corrected distance vision, distance corrected intermediate, uncorrected near. And we also plotted them for the defocus curve. and also judge them against the ANSI and AO criteria. The defocus curve was plotted for both monocular and binocular, and by keeping the patient at fixed distance from the chart, and we changed the dioptric power in the trial frame after correcting for the distance, and the power changes according to the focal length. So we tried to check whether the IOLs meet the criteria set by ANSI and AO. The first criteria states that an EDOF IOL should not be inferior to a monofocal IOL in comparison to the best corrected distance visual acuity. So as we see here, all the IOLs are faring very well for the best corrected distance. So none of the EDOF is inferior to a monofocal IOL. Second criteria states that an EDOF IOL should give at least 0.5 diopter greater depth of focus than a monofocal IOL at 0.2 logmar, which is the cutoff value. So as we see here in this defocus curve graph, there is a 0.2 logmar line, horizontal line, which is depicted, highlighted in the right color, red color. And the defocus curves of the different IOLs, from the red one is Vivinex, from there IHANS, Clarion, Swissfob and VVT. And we have pointed out the dioptric power where it actually intercepts the 0.2 logmar. So that is the range of focus given by that particular IOL, and we can find out the difference between any of the two IOLs for the whether they are giving additional 0.5 diopter depth of focus. So when we compared them against Clarion, the VVT showed a better depth of focus, but against Hoya, even Swissfob gave a better depth of focus as compared to Vivinex. The third criteria states that EDOF IOL should give a good intermediate vision at 66 centimeter. So in logmar, as you see, VVT is 0.03, and even the other IOLs are giving almost 0.2 to 0.24, which is as good as 6/9 parts vision, which is a good functional vision for intermediate purpose. The fourth criteria states that EDOF IOL should have at least 50% of the eyes with a monocular distance corrected intermediate better than equal to 0.2 logmar at 66 centimeter. So the pure monofocal Vivinex could not satisfy this criteria, but other enhanced monofocals, IHANS 50%, Swissfob 73%, and even VVT went up to 100%. We also checked these IOLs against functional visual acuity. That means a patient can use the vision for not for a reading purpose, that clarity may not be there, but for mobile gadget use and all, it will be a good functional vision. So here we can see all the EDOF IOLs fared very well against the pure monofocals. One more point I would like to stress here is when an eye is implanted in one eye against when IOL is there in both the eyes, the blue line for the IOL states that it's a binocular one. The red one is for the monocular. So when implanted in both eyes, the depth of focus is much better than when it is done in single eye. So we should always encourage the patients to get both eyes done so that they get a better depth of focus. There are some other factors also which affect the range of vision, like pupil size and what extent the IOL corrects the corneal positive aberration, age of the patient, astigmatism, and even the contrast sensitivity. To conclude, our study shows that monofocal serves best for crisp distance vision, but even EDOF IOLs give good distance vision along with functional intermediate vision, and almost more than 50% of the eyes will get a better depth of focus. There is another factor where cost is important. The cost of the VVT IOL, as we know, it's definitely higher than the other enhanced monofocals, which almost come in the range of premium monofocal IOLs. So that also needs to be taken into consideration. So to summarize, the EDOF IOLs provide continuous range of focus, allowing a clear vision at various distances. It reduces dependence on the glasses, has least dysphotopsia symptoms, and it overall improves the quality of vision. So EDOF IOLs are welcome change in the area of presbyopia correcting IOLs, and we should always educate patient about the pros and cons of the technology, suggest them a better IOL according to our clinical experience and the patient's expectations, and let them choose one out of them. Thank you.
Do you counsel all patients for this, or those who are so demanding for their work and all?
I always explained about the all type of IOLs. I mean, what are the options available, and I provide them with a chart, like what do they expect from the surgery, and according to that I would give them an option.
It's mainly for those who are requiring more of intermediate and near vision you counsel.
Yes, ma'am.
What about the distant vision also will be perfect for all these patients, or a slight?
Distance vision is good, but if we check the contrast sensitivity, it's little bit lower than the pure monofocals.
Yeah, maybe I wanted to ask Sony and Matthew also, since these, since Vivity and POC and all have come, how much do you use trifocals, and have you shifted more towards EDOF, or you use as many?
For me, I always take a history whether the patient drives at night. And if there's a long duration of night driving, probably I would dissuade the patient and go for an EDOF, like the Vivity. And I also do a micro monovision correction of around 0.5 to 0.75 if the patient is really interested in reading at a near distance. But the occasional night driver who would want to read probably at around 40 centimeters, a retired professor, people of that kind, I will still go for a trifocal IOL. And with the newer lenses, like the combination of EDOF and the trifocal, like the Geometric Plus, I find these kind of people are quite happy with these lenses. So that's how multifocal, definitely not if the patient drives or have a very active lifestyle kind of thing. That's what I generally do. I just wanted to ask you, have you compared the Vivinex Impress or the normal Vivinex?
It's Vivinex, not Impress.
You should have compared it with the Vivinex Impress, but in my hands I find it almost as good as Vivity in many of the cases. Because the whole mechanism is almost like the Vivity. The only thing is it is subsurface. The whole thing is subsurface, and it works very well. Compared to Vivinex, yes, definitely. That's not an advanced monofocal. It's a normal aspheric monofocal.
Actually, I do have some data, but it is not a good sample size, so that's why I did not project it. It does work well.
Regarding negative dysphotopsia, how soon should, if you want to intervene, how soon should you do an reverse optic capture? How soon can you do it? Means how late can you do it?
Yeah. No, basically now since we are not trying to disengage the haptics, you can go a little late. Only when you need to do a rotation of the IOL, etc., then probably the fibrosis, etc., can set in, and it can, you try to do it and then you end up with a subluxated bag. It can be a disaster. But generally, if you feel you don't need to tamper around with the haptics, you can delay it as much as possible. But if you feel it has to be rotated, like if you want to rotate the IOL also, if it is 90-180, I mean 0-180, if you want to make it in a different thing, then you will have to go early, probably at least within 2 months. Otherwise, you can go a little late.
Does the positioning of the haptics have anything to do with negative? No. No. And what about anterior YAG capsulotomy? Does that help?
Yeah, it helps. It helps, and the patient most of the time, once you do a procedure, what I felt, either of the two, they're quite comfortable, and they generally do not come back for a second procedure.
Primarily in the other eye, if patients complain in the
yes,
first
yes.
Primarily
if the second eye, if you're planning to do it primarily itself. Yeah.
On a lighter note, I have a familial disposition to this. I have two family members, two families basically. Both got operated and both has dysphotopsia. So it is, I think it is more of a perception part of it also, rather than this. I have two distinct families there.
fact, I have, much before all this dysphotopsia stuff came into picture, I've retrospectively thinking, I've had many patients who told me about this, this temporal, and I used to always tell the patient it is because of the section, which I put supranasally in all the patients. Later on did I realize actually the patient was talking about something else, but somehow I got away with it, maybe because the patient believed in what I said, and then you have to get used to it.
Any pupil size matters, sir, in dysphotopsia?
No, it doesn't. Matthew?
There are lenses which are now come in, which allow you to capture the anterior capsular axis, and some of those lenses are now available in the Indian market as well. Problem is they are currently all hydrophilic lenses, so if you are used to comfortable with the idea of hydrophobic lenses moving to hydrophilic, then may seem like a retrograde step for you. Other issue is because you are capturing the IOL optic on the rhexis margin, your possibility of posterior capsule opacity rates increases, and then your ear capsulotomy and other post-capsulotomy issues increase. So if I would have an individual who is complaining very severely of negative dysphotopsia, the second eye, I would do eccentric rhexis, which would be more on the nasal side. I would allow the anterior posterior capsule to fibrose there, and I would place the haptics vertically 90 to 70, so that the nasal portion of the optic can ride over the rhexis margin.
There is one other lens which is the Ray 1, which is a hydrophobic IOL. It has got two small extra haptics. Yes. So putting that, I mean capturing that over this thing could help if placed in the proper position.
The tabs is what you are speaking about?
Yeah, it's not the Ray 1 EMV, the plain Rainer, I mean Ray 1. Yeah, which has got two
tabs.
Yeah.
So are there any more questions? If not, we'll conclude this session.
Thank you, sir, for your informative presentation. I request Dr. Susan Verghese to hand over token of appreciation to the chairperson and speakers of the session. I welcome Dr. Sony George. Dr. Matthew Kurian. Dr. Aditya Joshi. Dr. Satish Thomas. Dr. Dahlia S. I also request the chairpersons and speakers of this session to engage in a photo session with Dr. Susan Verghese. Thank you all. I want to take a moment to express our deep appreciation to all our speakers and chairpersons for the insightful information they have shared with us. Your contributions have truly enriched our understanding. Thank you, dear speakers.
We would now be moving on to our inaugural ceremony. Let me take this opportunity to once again welcome you all to Pathanamthitta and to Nethram 2025. We extend a warm invitation to the distinguished dignitaries to grace the dais for our inauguration ceremony. We welcome Dr. Biju John, Dr. Rachel Jose, Dr. Sabita S., Dr. Soni George, Dr. Cherian Shane Matthew, Dr. Chaithanya Warrior, and Dr. Priyanka Tilak to grace the dais. As we begin the ceremony, I would like to invite Dr. Rosu George Matthew to lead us in a prayer song. I encourage everyone to please stand up.
നന്മയാകുന്ന കാന്തി കാണുവാൻ കണ്ണിനാകേണമേ നല്ല വാക്കിൻ്റെ ശീലു ചൊല്ലുവാൻ നാവിനാകേണമേ സ്നേഹമാകുന്ന ഗീതമായി എൻ്റെ കാതിനിണയാകണേ സത്യമെന്നുള്ള ശീലമോടെ ഞാൻ ശാന്തി അറിയണമേ ആ ഭൂമി അമ്മയെന്നറിയുവാൻ ഉള്ള ബോധമുണ്ടാകണേ ജീവജാലങ്ങൾ ആകെയും ജന്മബന്ധുവായിടണേ ജാതിഭേദങ്ങളെന്ന ശാപമോ ദൂരെ മറയണമേ ലോകമൊന്നെന്ന പാഠമെന്നുമെൻ മനസ്സിലെഴുതേണമേ ആ
Thank you, Dr. Rosu. Thank you, everyone. Now I humbly invite Dr. Cherian Shane Matthew, President of Ophthalmic Society of Pathanamthitta, for the welcome speech.
To see clearly is a privilege. To help others see is a calling. Good morning, delegates and dignitaries. It gives me great pleasure to welcome you all to Nethram 2025, the fourth edition of our annual CME. Just 3 years ago, the ophthalmic community of the Pathanamthitta had a modest strength of just 15 members. Today, we stand close to 100 tall. A remarkable journey from the being of an unknown entity to becoming a well-recognized society within KSOS. This growth has not happened overnight. It is the result of the dedication, enthusiasm, and active participations of our members. Every meeting, every initiative, every CME program, our members have actively participated. This collective spirit and commitment of our team needs a big round of applause. This transformation is a proof that we can achieve when we come together with a shared vision and purpose. Inflammation lies at the heart of many eye diseases, whether it is conjunctivitis, uveitis to scleritis, or an ulcer, or even an endophthalmitis. Now we know that inflammation carries a big role to play. We are increasingly recognizing this and managing it early for effectively changing the prognosis. Now, understanding and controlling inflammation isn't just a treatment step, it is a therapeutic priority. With this in my mind and our team chose to focus certain unsung specialities, unsung topics for us to know in depth and change our practice patterns. We are also thrilled to bring you a mega CME ophthalmic quiz, packed with excitement and very attractive prizes for the winners. Now, with great honor, I welcome our chief guest, Dr. Biju John, Secretary, KSOS. Thank you from the bottom of our heart for coming today and gracing this occasion. A warm welcome to Dr. Soni George, Joint Secretary, KSOS. I take this opportunity to reveal how privileged we are to have you with us today. I'd also like to welcome one among us, our leaders, our past presidents, Dr. Rachel Jose, our immediate past president, who was a pillar in kick-starting the progress of our society. Dr. Sabida, past president, still always evergreen member to the representative of our society to KSOS. Madam was our pillar of strength during our tough times. I would like to also welcome and acknowledge the presence of Dr. Sujit Nayanar, who is the website editor-in-chief of KSOS and a really good friend of mine with fond memories. And also Dr. Marian Pauli, member of the scientific committee. A special word of gratitude to our eminent speakers for accepting our invitation so graciously. We would like to welcome and place it on record Dr. Matthew Kurian, Dr. Natasha, Dr. Sharath, Dr. Lekha, Dr. Saju Thomas, Dr. Anju Suresh, Dr. Rahul R. Menon, Dr. Aditya Joshi, Dr. Kiran Gopalakrishnan, Dr. Sarita VK, Dr. Thanya CA, Dr. Roshni, Dr. Manjit, Dr. Jisha, Dr. Preeta Nair, Dr. Shebin Salim, Dr. Dalia S., Dr. Thanya, and Dr. Indu VP. And last but not the least, Dr. Satish Thomas, who is one among us. Thank you all for coming. Although this is a welcome address, I would be failing in my duty if I don't thank the backbone of this event. Our beloved Nethram 2025 team members, our organizing secretary, Dr. Chaitanya, secretary, ever charming, of OSP, Dr. Priyanka, and the treasurer, Dr. Ann, for the dedication and flawless execution. I sincerely hope that each of you take home at least few pearls for your academic insights from Nethram 2025. Thank you.
Thank you, sir, for a very warm welcome note. It is with great honor that we invite Dr. Biju John, Professor and Head of Department, Government Medical College, Kollam, presently General Secretary, KSOS, to ignite the flame of our aspirations by lighting the ceremonial lamp. We encourage the other dignitaries on the dais to join him in this illuminating moment. Thank you, everyone. It's my pleasure to welcome our chief guest, Dr. Biju John, for the inaugural address.
President of the Ophthalmic Society of Pathanamthitta, Dr. Shane, Rachel Madam, Dr. Soni, Dr. Sabida, Dr. Chaithanya, Dr. Priyanka, and a host of the other dignitaries of the dais. Among there are the seniors like Sugana Madam, so many other seniors, my teachers, then the esteemed faculty members, colleagues, some of the PGs are there, and my friends. So I'm extremely happy and privileged to stand here representing the KSOS in this CME. Dr. Mahesh, our president, has got other commitments with respect to the Bombay Ophthalmic Association. He is not here, and that is why I get this privilege of inaugurating the CME, which I'm very thankful to him also, because once in a while only I get this opportunity. And as Shane has told, because I have been watching the growth of Pathanamthitta Ophthalmic Society for all these few years, and I have been discussing with Rachel Madam also for that when she was talking about the registration of the club and all those things. And used to hear this thing from Madam that, I think now Madam is extremely delighted. Yeah. So you have got a vibrant team now to lead the Pathanamthitta Ophthalmic Society, and as Dr. Shane has described, you have seen how it has grown also. And I think in the previous, you must all be aware of that the Kerala Society of Ophthalmic Surgeons has actually bagged that award for the best ophthalmic state in our category in the AIOS. And the backbone of this has been the excellent reporting of the activities that we were doing. And I used to compile all these reports. This compilation will be possible only if the secretaries of the affiliated clubs gives me the report. So this reporting is a little complicated now because we have got so many reports. One is the Google form we have got. Then Sridhar needs his website report. Then Sony needs this report in the PDF or the Word document. So it has been a little resistance from some people also because there is a lot of work need to be done. A lot of reports has to be done. But then there is one charismatic lady who used to send me all these reports right on the 3rd or 4th of every month. So you get one report in the mail and one report in the WhatsApp. Then she tells me that, sir, I have sent the report already. So I get every 3rd or 4th of the month. And that is Dr. Priyanka. So in fact, I don't need to now get an alarm because I need to compile everything, no? So her message, when I get her message, then I start compiling all these things. So please continue the good work, Priyanka. And as far as the CME is concerned, I think this is the 26th CME of this KSOS year. So every week we are having CMEs, and 32 CMEs are already scheduled. So talks about the vibrant CME scientific activities that is going on in the KSOS. And regarding this CME, as Dr. Shane has already mentioned, I think it's a very relevant topic because inflammation and its complexities, we need it's the in thing, and we need to unravel the complexities and the perplexities of the situation and the different scenarios. I think the OSP has succeeded in bringing out a faculty of a galaxy of excellent faculty or experts in this field, and who will actually lead us through these topics. And I'm sure that all of us will benefit from this CME. So all the best for the Ophthalmic Society of Pathanamthitta, and we'll be in for a very good session. And also, I think they have got promised something, that this quiz, which they termed as the Igniting Young Mind of Postgraduate Quiz. And I think we have got the right person to ignite everything. Dr. Natasha is here. And And one more thing regarding this organizing team. You know, I mean, when I landed here, I mean, when I came to the hotel yesterday, because I just drove from Kollam itself, I had a reception committee waiting here. Dr. Ann, the treasurer, and Dr. Chaithanya. Of course, they were telling me that they have got another excuse for that also, which I tend to ignore. I would like to think that this is mainly for this. So, and Dr. Shane was actually, inquiring in the evening regarding my comforts and also thank you for this wonderful hospitality. And Dr. Chaithanya and her team, I mean, she's the organizing secretary, is doing an excellent job. I know her from my RIO PGs. She was one of my favorite PGs, and she has been spreading Chaithanya in Chaithanya and the OSP, and will be continuing, continuing to do so. And regarding the regarding the Drishti, I think last week we had a DCC meeting also, during which we had discussed regarding the preparation of DCC, so that is also going on very well. And with these few words, I declare the CME as inaugurated. Thank you.
Thank you, sir, for your warm and gracious inaugural address, which sets a positive tone for our gathering today. At this juncture, I am pleased to welcome Dr. Priyanka Tilak, Secretary of Ophthalmic Society of Pathanamthitta, who will take us on a journey through the remarkable growth of the Ophthalmic Society of Pathanamthitta.
Good morning, everyone. Once again, I welcome you all to Nethram 2025. It gives me immense pleasure and happiness to present before you the annual report of Ophthalmic Society of Pathanamthitta. To begin with, we had a phenomenal Nethram 3 on August 4, 2024. It included scientific program, Alcon Phaco VR simulator. We introduced Nethram Film Festival, and there was PG case presentation as well. Following Nethram 3, Ophthalmic Society of Pathanamthitta, along with Sabita Eye Care, conducted Onam CME. We had exhaustive sessions on endophthalmitis, OT sterilization, and asepsis. The handing over ceremony was held, and new office bearers for Ophthalmic Society of Pathanamthitta were announced. The lady doctors of Ophthalmic Society of Pathanamthitta displayed the true spirit of Onam in the form of Thiruvallala. Musical chair and Onam bumper fascinated everyone. The traditional game of Sundariki Pottu Todal was made more exciting by placing a fundus image and fovea as the target. Onam feast was enjoyed by everyone. We participated actively in Drishti 2024 held at Kochi. There were instruction courses, scientific talks. We took part in Teachers for Tomorrow as well. We had a wonderful Christmas CME on December 16th. Scientific talk on patient safety, a silent problem, was presented by Dr. Saju Thomas. We had Christmas cake cutting, Christmas dance, Christmas friend. For the first time, members of Ophthalmic Society of Pathanamthitta staged a choir. The inception of Family Day was from our president, Dr. Cherian Shane Matthew, who believes in nurturing strong bond among members and reconnecting with our senior members. The serene destination of Lake Canopy Resort was chosen as the venue for the Family Day. It was a one-day program on January 19th filled with fun and laughter. Our Glaucoma CME was held on March 14th to celebrate World Glaucoma Week. Dr. Kiran Gopalakrishnan sir presented on glaucoma snippets of wisdom. There was PG case presentation on glaucoma. We introduced Beyond the Academics session. Members' birthday were celebrated by cutting the cake. To commemorate Eid celebration, Eid bumper was launched. Eid message was given by Dr. Kamila. The most awaited segment, Stress Buster Corner, was initiated by our president. On April 25th, we had our KSOS president visit. Dr. Mahesh Gopalakrishnan sir presented on 10 classic judgments in medico-legal cases all of you should know. The session offered insight into medical negligence, consent, and legal pitfalls in healthcare. On July 20th, KSOS PG highlights took place at Believers Church Medical College Hospital. The session imparted the much needed practical knowledge on glaucoma to postgraduates. A glimpse of our recently conducted monsoon CME, which had special session on pediatric ophthalmology, stress buster, and cardiopulmonary resuscitation. Coming to the important days, last year Medifest was held on September 29th to October 1st at Believers Church Medical College. School screening camps were held as a part of World Sight Day. Vidyarambam program was inaugurated by Sabita ma'am on October 12th. Diabetic screening program, awareness programs were held as a part of World Diabetes Day on November 14th. Sabita ma'am participated in Nethram held in the beginning of this year. Women's Day was celebrated with color and passion. Several awareness programs and screening programs were designed and executed to celebrate World Glaucoma Week. Recognizing the invaluable contribution of optometrists in eye health care, World Optometry Day was celebrated on March 23rd. Coming to the individual achievements, Dr. Shishir Verghese received Best Video Award at APVRS. Dr. Satish Thomas Sir, Professor and HOD, Believers Church Medical College and Hospital, cleared FRCS Glasgow in January 2025. Dr. Shishir Verghese was the winner at VRSI Image competition for his image Fading Glory. Dr. Aditya Ganesh Joshi and Dr. Ann Teresa Anthony cleared FAICO cataract on February 15, 2025. Dr. Shishir Verghese bagged Best of Show Award at Pune Icon. Two of our members were among the first 5 best performers 2024-25 in cataract surgery. Dr. Sini NV from GH Pathanamthitta and Dr. Matthew George from GH Adur. And our AIOS winners, Dr. Ann Teresa Anthony, Dr. Aditya Joshi and Dr. Shishir Verghese. Dr. Pratibha Tilak and Dr. Ann Teresa Anthony cleared FRCS Glasgow in January 2024. Dr. Pratibha could attend the award ceremony held this year. Our upcoming CME OptoGlow, organized by Amita Eye Care, along with Ophthalmic Society of Pathanamthitta, under the AGESIS of KSOS, will be held on September 21st. It will focus on topics related to optometry and general ophthalmology. Drishti 2025 will be held at Kollam in November. We will be co-organizing Drishti along with Kollam and Trivandrum. Coming to our presidential initiative and innovative programs, providing travel arrangements for scientific meetings, family day celebration, stress buster corner, birthday celebrations of our members, celebrating important festivals. Astronaut Kalpana Chawla had once said, "You must enjoy the journey because whether or not you get there, you must have fun on the way. The journey matters as much as the goal." So let there be fun, let there be everlasting friendship and magical moments as we learn, grow, and evolve. Thank you.
Thank you, ma'am. Now it is with great honor that we take this moment to acknowledge and celebrate the extraordinary dedication and excellence of our respected senior ophthalmologist. Her unwavering commitment over the years has not only laid a robust foundation for our society, but also inspired generations of professionals to pursue their passion for ophthalmology with the same zeal. I request Dr. Leena Mariam Varghese, Vice President of Ophthalmic Society of Pathanamthitta, to highlight the life and contributions of Dr. Leela Matthew before this esteemed gathering.
Good morning, all. It's my privilege and honor to speak about our most esteemed and senior ophthalmologist in our society, Dr. Leela Matthew. Madam was born on February 13, 1943. She completed her schooling at Holy Angels Convent School, Trivandrum, and then pursued her higher education at Women's College, Trivandrum. She then went on to earn her MBBS from TDMC Alappuzha and later specialized in ophthalmology with her post-graduation from Government Ophthalmic Hospital, Trivandrum from 1972 to 76. Madam has also served as president of our Ophthalmic Society of Pathanamthitta in 2005. In addition to her medical achievements, she also holds a diploma in human rights from 2007. She has worked in Pushpari Hospital from 1976 to 1996, in Aravind Eye Hospital, Tirunelveli, Minathotam Hospital, Pathanamthitta, and currently working in Karunya Hospital, Pandalam. Madam is a devoted wife and a mother of 3 daughters. Her husband was professor at Catholic College. Her hobbies include gardening, which shows her love for nature and beauty. Her eldest daughter followed her footsteps and became a doctor, Dr. Shobha Philip, married to Mr. Pramod Philip. Second daughter, Lada Panikar, and her husband, Sernti Panikar, are software engineers. Youngest, Nisha Kurian, and her husband, Danan Kunnuswamy, are PhD scientists. Madam has been an inspiration for all of us. Her career spanning over 50 years and her interest in academics truly marvelous. She makes it sure to attend most of our monthly scientific meetings. She is a shining example of what it means to be a true professional, and her conduct both in and out of workplace sets a high standard for all of us to follow. Her charisma is unbeatable and her presence is an enigma. Thank you, Madam, for being a beacon of light in our society. This recognition is to celebrate your remarkable career and ongoing dedicated work in the field of ophthalmology. Thank you, ma'am.
May I now request Dr. Biju John to adorn Dr. Leela Matthew with a punnada and a memento as a token of our deep respect and appreciation.
Everybody, I'm very proud to stand here representing the senior most ophthalmologist in the Pathanamthitta Society. A little history of what we went through. When in the late 1976, we started this ophthalmic meeting. It was not a society then, it was just a meeting consisting about just 5 people. And we had these occasions in our residence. It went on for quite some time, and then it lost its vigor, and we were in the ICU for some time. We regained our power later and became a small society, growing slowly, and finally into a big tree containing about 100 ophthalmologists. Isn't it a wonder? From a small beginning to a great heights. And in no time, we'll be the best society in our KSOS. That's what I believe. My advice to the juniors, I consider myself and people along with my 70s years and above as dinosaur ophthalmologists, whereas the new gen tech ophthalmologists are the in thing today. I request one thing and one thing alone. See the people who come to you as persons, not only as patients. Keep your empathy with you always, which I find so lacking in the new generation. Try to be more, to consider your empathy to the patient always, and to all those around you. We may be old, but we are not. We have the privilege of seeing everything from intracapsular to the latest technology, from unknown etiology of uveitis to precise diagnosis now. So I request all of you, always have empathy. That's the main thing we need today. Thank you all.
Thank you, ma'am, for your gracious presence and your very valuable pearls of wisdom. With great respect, we now invite Rachel Jose, ma'am, to extend her felicitations to this esteemed gathering.
I'm so happy to be here to take part in the inaugural session of our CME, annual CME 2025. We had, after our society was formed in 2021, we started, initially it was walking, slow walking, fast walking. Now it is almost running. So I'm very happy, how the whole ophthalmology society and ophthalmologists, they all ran along with me, because at that time, the only advantage of mine was I was an administrator for 20 years. So initially, the society had a lot of administrative issues which could not be solved by the ophthalmologists. But once my experience of 20 years in health ministry, I could do something, I knew that I can do it. I said, if I can do for India government, for the whole country, why not Pathanamthitta society? I took it as a challenge, and I have seen the changes, lot of changes. See that now lot of CMEs, 5, 6 per year. Annual CME, this is the 4th CME. Now we have got a dynamic team under the leadership of a young man, Dr. Shane, and his all team. We have got tremendous, very good manpower. Now I can sleep properly, because initially my husband said, you can think about only our society, because that was it was little, I was upset, why this was. When I used to attend the KSOS meeting, they were ridiculing, Pathanamthitta, nothing happens. No society. You remember? Yes. No, many people told me directly, Madam, why society, no society, only in Pathanamthitta? It is not. I said, we will see the change suddenly. So I have interaction with Biju and so many of our previous KSOS presidents. Because I was, 2 years I was in KSOS, one of the members. So there is a change, especially with after Shane had taken over, lot of visible changes. Because even though with lot of difficulty, I could convince him to take over. She said, you will continue, madam, please continue, you are administrator. I said, how long? Till the age of 80, 90. So with difficulty, but he has got an excellent team. Excellent team, under this Pradibha and Anne and Leena, and other all executive. I am also one of the executive to continue to keep the continuity. I am also one of the executive member. but this CME has been arranged excellently by Shane and his team. As Biju said, Priyanka, every day we will see something message from her on WhatsApp. Every day, some new change, some new change. And Dr. Chaitanya, another organizing secretary of this CME, doing wonderful work. I used to tell her 1 year back, what you will do, you have to try a lot, work hard and all. But now I am seeing the change, what she has attained under the leadership of Dr. Shane. So I'm very happy to be here, that so many of our people are sitting in front of. We are also doing a lot of interest, taking interest in the PGs, PJQs, PG taking classes, CME, we invite all of them, bring them here so that they are benefited from such CMEs. Thank you very much, Dr. Shane, for inviting me for the inaugural session.
Thank you, ma'am, for your inspiring and encouraging words as always. May I now request Dr. Sabita S. to kindly offer her felicitations and share a few words with the Assembly.
Thank you, Chaitanya team and the Ophthalmic Society of Pathanamthitta for conducting a wonderful CME as we are going through now from the initial stages of walking step by step now. As ma'am told, it is running. So excellent work is going on by the entire team. And I congratulate once again the young and dynamic, vibrant team of Pathanamthitta to continue our society and bring it to the top of the KSOS. We got the best award for the district clubs in Pathanamthitta in 2020. Once we got the best club award. But now the competition is very tough and we have to work a lot to reach to that realm. And I think our Priyanka is doing a tremendous job and hope we will get it soon. And thank you once again for all of you coming and making it a good program. Thank you.
Thank you so much, ma'am. I request our esteemed chief guest, Dr. Biju John, for delivering the keynote address on posterior segment. Sorry. At this moment, I would like to invite our organizing secretary, Dr. Chaithanya Warrior, to express our heartfelt gratitude by delivering the vote of thanks.
A warm good morning to one and all. Thank you is such a prayer that cannot be seen or touched. It must be felt from heart. I feel honored and privileged to get the opportunity to deliver vote of thanks at Nethram 2025. I, on behalf of Ophthalmic Society of Pathanamthitta, convey deep regards and hearty thanks to Dr. Biju John Sir, General Secretary, KSOS, to accept our invitation as chief guest of the occasion. Thank you, sir. I wish to thank all our esteemed speakers and panelists for their presence and active participation, who all rearrange their schedules, travel either overnight or early morning. Especially Dr. Sujit sir, who travel all the way to our CME, Dr. Soni Jose sir, who rearranged the talks at ISKCRS Delhi for our CME. Thank you, sirs. I also extend my gratitude to Dr. Natasha madam, who agreed for conducting our postgraduate quiz. I wish to thank Dr. Marian Pauli madam, who agreed to be part of Nethram this time too. Once again, I cannot thank enough our speakers and panelists for their efforts they have taken for the smooth running of our CME. An event of this dimension cannot happen overnight. The wheels start rolling months in advance. We have been fortunate enough to be backed by the unwavering support of OSP under the dedicated leadership of Dr. Shane Matthew sir, OSP President, Dr. Leena Mariam Verghese, Vice President, Dr. Priyanka Tilak, our Secretary, and Dr. Andreza Anthony, our Treasurer. I extend my sincere gratitude to Dr. Rachel Jose Madam and Dr. Sabita Madam for the constant motivation and encouragement. I express my gratitude to our organizing team, my dear colleagues and staff, for the exceptional dedication and also for the smooth running of wet lab sessions and quiz preliminary session. Thank you to Team Alcon for arranging FACO VR simulator. I extend my appreciation to all delegates for their kind presence at this CME, especially to the postgraduates who made a very high presence for our CME in a large volume. A special note of gratitude to our MC team and especially Dr. Pradipathalar, who arranged her holidays to meet our Nethram 2025. I want to express my thanks to all pharma company for their invaluable support. A special note of gratitude to the audiovisual team Mahadeva, photographers at the photo booth who made our real-time memory, and KG Elite Continental and all its staff for arranging a remarkable event. Once again, thank each one of you present here. Last but not the least, I express my sincere gratitude to each and everyone who directly or indirectly become part of our Nethram 2025. Thank you.
Thank you, Dr. Chaithanya, for your invaluable contribution in making the event come true. At this moment, I would like to invite Dr. Biju John for delivering the keynote address on posterior segment manifestations of trauma and its management.
So thank you once again for this opportunity. So this is my topic. So in order to fit this into the rest of the scheme of the things, I think that have been labeled as traumatizing. I promise that this will not be traumatizing to anybody. Okay, so because of that, I will just actually skip through this, because any trauma, I think you need is classification. So this is there in all the textbooks. So in academics and all institutes, I think we need to go by this classification, the scoring system and all. But I would like to skip through this. The plan will be a case-based discussion of closed globe trauma and management and a few important open globe injury in the posterior segment scenarios. Because only with this case-based discussions can, it is difficult to meet this deadline otherwise. So if you go by this case discussion, I think I can stop at any moment when the bell rings. Okay, so this is what happens in a blunt trauma. Just to explain the trauma, that is the compression waves that sets in, then the decompression, then the overshoots and the oscillation. So these waves, along with the coup and the contrary coup impacts, actually is responsible for all the manifestations of the trauma that you see in the eye during a blunt trauma. So the commonest, it's usually a common question that we ask even the undergraduates, what is the commonest manifestation of a posterior segment trauma and as far as a closed globe injury is concerned. So this is the picture. Everybody is familiar with this thing, the whitening around the macula, which results in the cherry red spot, the commissural retina. So everybody is aware of this thing as a result of the contrary coup forces acting on the macula. So some of the few aspects that I just want to highlight here is that sometimes this whitening can extend even up to the periphery, and sometimes you may not see the whitening in the macula, it may be in some other areas also. And as far as the management is concerned, I think some of these OCT findings, nowadays the OCT, I think even if you don't see the vision is 6x6, the OCT will throw up many interesting findings, and it has actually helped us to actually pinpoint where exactly the forces are acting. So the main blunt of the trauma will be on the photoreceptor cell layer and results in disorganization and disruption. As you can see, a few findings in the OCT here, thickening and hyperreflectivity of the ellipsoid zone and the RPE, and sometimes a band of hyperreflectivity above the fovea, again in the outer layers. So these are findings that you can see in the OCT. As far as the management is concerned, I think even without worrying about the rationale, once we see the whitening, most of us will start on steroids, but actually there is little evidence in the literature on that thing, other than the anecdotal evidences. Most of these cases, about 60% is resolved within 4 weeks of injury without any residual damage, but some of the others, maybe less than 40%, may end up with permanent macular damage with absolute or relative scotoma, pigment retinopathy, etc. Now the OCTs will pick up so many findings that you would have otherwise missed. So for example, this was a 14-year-old boy with blunt trauma. He had a grade 2 hyphema. There was no visual improvement even after complete clearing of the hyphema. The vision remained at counting fingers 1 meter. The fundus doesn't tells you much here, but this was the OCT finding. So the 5th day, you can see that there is a sort of a traumatic macular hole which has happened here. And you can see what has happened in the further days also. By 8th day, 12th day, the hole has sort of closed. So this is just to highlight that in the traumatic macular hole, many of these cases, there is a large incidence of cases which spontaneously close. And so these traumatic macular holes has to be given a chance of the spontaneous healing rather than being so, we should not be so enthusiastic to take it up for surgery. So in the literature itself, there are about 10 to 60% is the incidence of spontaneous closure. And are there any factors which tell us that this is a hole which is likely to close in the case of a blunt trauma? Yes, you can look at something like this. Young age, small holes, then absence of PVD, absence of intraretinal cyst. So such cases may be good options for actually observing, provided it's not a child who is less than say 8 years, because then there is the chance of amblyopia and you may have to intervene. So this was a 45-year-old male who had blurred vision following injury with a tennis ball. So this is a very rare form of injury which we picked up here. There's an RP tear here. Now this is rare because the force has to be so precise so as to actually, it has to be, if it is too little, there won't be any tear. If it is too much, it will be choroidal rupture. It will be something in between, then only we get the RP tear. And generally, there will be retraction of the RP edge, which actually prevents it from healing, as a result of which many of these cases, you have got a bad prognosis. But this one, actually, you can see that just because there was no retraction, I don't know why there was no retraction, it could end up in a optimal result with the final vision being 6/9 and it's healed spontaneously. Again, cases like this, when you have a hemorrhage, this was, we had this case even before we had the OCT in the RIO. So at that time, we didn't know at what level specifically this hemorrhage was, but now an OCT will actually help us to exactly tell us which level, whether it is under the retina, subretinal, or whether it is under the RPE. Because this is important because the type of management that we would be looking at here would be an injection of gas into the vitreous cavity, and that is more amenable to subretinal blood, which can be easily displaced by sub-RP. It may not be that much effective. So the OCT is very important here. But in this case, because we didn't have the OCT and we just went in and injected the 0.3 cc of C3F8 gas, and this is what happened. We got very good result. Second post-op day, the blood could be displaced. And the 6th post-operative day, okay, good. But the only thing was that the patient was not happy. There was no improvement in vision. And we are also not happy now because we can just about make out the choroidal rupture which has happened and which is between the fovea and the disc. And so this patient is not going to improve. And the only thing that is to be left to be done here is to actually follow up this patient because there is a chance of a CNVM developing. Now, a case like this, a tennis ball injury during a cricket game. They used the tennis ball, he had a hyphema, patient was admitted, cleared in 2 days, vision is 6/6. Patient was about to be discharged. So this is very, very important. Now, don't just look at the posterior pole. It is very, very important that you do an indirect and look at the periphery before you discharge the patient. And this is what we found in the periphery. So there was a horseshoe tear there. And the mechanism, by when you have a tear in this shape, it means that there was a vitreous detachment which has sort of pulled off a part of the retina and the horseshoe tear has happened. And we could actually laser the patient. But think of what would have happened if the peripheral examination was not done. Now, this is another type of tear. This is an intraoperative picture. Patient had vitreous hemorrhage. So, during the surgery, we took this photograph. You can see that this tear is a slightly different architecture. It's a curvilinear configuration. This is a stretched tear as opposed to the tractional tear in the previous case. So, here we had to actually do the vitrectomy. Now, so this is a patient who was initially lost for follow-up. Then the patient came back with cataract. We removed the cataract, and this is the final picture after the cataract surgery. Vision is 612. There is some ERM, and that is what is limiting the vision here. Now, this is the commonest type of stretch tear of the retina that you get in blunt trauma. That is the stretch forces because of the sudden compression and expansion of the globe. These forces act on the vitreous base, which results in the tear in that region. So as a result of the retina become disinserted from the ora serrata, this is a retinal dialysis. So here the vitreous is actually attached to the posterior edge. Now this is also very easily missed, especially in young patients, because it will be initially seen as only a very small slit. It doesn't progress very quickly because there is no posterior vitreous detachment here, and there is the vitreous base which is still intact and the vitreous is solid. So such cases actually gives you more time to actually detect it, because even when the patient comes after 1 or 2 weeks, it might have not progressed anteriorly so much. So repeated examination can actually help you detect the dialysis and treat it, because if you don't treat it, then you get into a really great trouble, because as it goes for detachment and extensive surgery. A 38-year-old male who got trapped in the Wayanad landslide of August 2018. He survived multiple fractures. Then after repair of the fractures, he was found to have visual loss in one eye. Then he was referred here because he was a native of Trivandrum. And this is what we found. So we can see that there is a giant retinal tear here. And the flap is completely inverted. That is why you don't see the optic disc there. And here, of course, there is nothing else. Surgery is the only yeah, so this is what we done. So we did a complete vitrectomy, and after removing the entire vitreous, then now next is to reinvert of the flap. So we use PFCL to actually reinvert the flap. You can see the flap reinverting now, and you can see that the edge of the flap is actually again inturned, telling you that there's a lot of PVR changes there and there's a traction there, which means that that edge also has to be amputated, because otherwise the retina will not settle. So we did diathermy, that is the diathermy being done, and after the diathermy we will be actually amputating that in downturned area, because there's a PVR there. And once that is removed, then under PFC the retina settles. Then it is exchanged with air, and the air is exchanged with silicone oil, and the retina is flat now. So this is the picture after 2 months. You can see that the barrage is holding the retina very well. This is the area of the tear, and he had good result. Now, this is a case where I think I can show most of the things that has happened goes wrong in blunt trauma. So severe blunt trauma, 70-year-old injury with a wooden log. You can see there is a posterior dislocated crystalline lens. You can see the vitreous in the anterior chamber. There is vitreous hemorrhage. There is retinal detachment. So everything can be learned in one single case itself. So what we do here, we start with the vitrectomy. So remove all the vitreous from the anterior cavity, and remove all the additions, some of the vitreous which is adherent to that lens which is dislocated. So once the lens is freed, then it now falls down onto the retina, which also it is detached. So you need PFCL. So PFCL is injected actually to separate the detached retina from the lens, as well as that is the tear that you see here. So the PFCL will actually help to actually displace the blood which is under the retina peripherally, and also helps to protect the retina. So that is the fragmentation which is going on. So you fragment the lens and you remove the crystalline lens completely. Once the lens is removed, then you turn your attention towards the detached retina. So more PFCL, and more blood comes out from under the retina, and more fluid also comes out. You can see that the blood and the fluid coming out. So that is removed now, and that is the laser being done under PFCL. So that it is exchanged with air, and that is silicone oil which is injected now. So everything, whatever happens in the blunt trauma, you can see here. Yeah, this is, I mean, you all know, 30-year-old male hit by a tree branch. So what is the diagnosis here? So this is what has happened here. No, you get an anterior-posterior rotation of the globe, which results in actually the optic nerve being pulled out. This is an optic nerve avulsion, and there is nothing much you can do here. So 40-year-old male who had an injury with an iron mesh, he actually fell on the iron mesh due to some other reasons. He didn't know actually whether it was an iron mesh or not because of the state he was in. So he was brought to the casualty, and the diagnosis was a closed globe injury with vitreous hemorrhage. Okay, that is what it is. Everything was intact. So next day he is being presented to the chief, and this is what I saw. So I think you can all see that eyelash which is here, no? An eyelash, it is not lying down, it is just standing up. It can only mean one thing. Why should an eyelash stand up like that? It means that it is stuck somewhere. So the obvious conclusion is that there is a tear there. So the officer was advised to actually take the patient to the theatre and explore, and fair enough, we found a small penetrating injury, full thickness wound on which the cilia was impacted, and that was removed. Okay, so that is the end of the story. No, still B-scan, I mean, we found these findings. So there was an area, there's a track like this, there was a retina which was elevated like this, and on top of that the CT scan is reporting, the reports comes that there is multiple small hyperdense shadows in the vitreous which suggests you have foreign bodies. Okay, so there is sufficient indication for going in. So vitrectomy was done, and so you can see a lot of hemorrhage. This is actually after removing a lot of the vitreous hemorrhage. So all the hemorrhage is removed. That is the vitrectomy being completed. So once the vitrectomy is completed and the hemorrhage is cleared, you can actually see an area of a white elevated retina. You see here. So this is the part which was actually seen as the elevated area, and you can see this red patch here. I mean, I didn't exactly know what was happening because no other tear could be detected there. So I just left this area and walled off that area with laser and just exchanged with air. So it's not very clear about what has happened here, but see, now everything is clear. 5 days post-operatively, this is what happened. So you can see the precise way by which the iron mesh has gone in. You know, if you have a trauma, it should be like this. So it has just transected all the nasal vessels and saved the entire macula. As a result, the patient is nothing, I mean, having any visual loss. Vision is 6/6. And the OCT tells us to what depth the iron mesh has gone in. So these are things which you need to suspect and you need to act accordingly. Yeah, the signs of occult rupture, this is what you need to rule out when you have a case like this. Now, 3 important scenarios in open globe injury requiring urgent posterior segment intervention. So that is the only thing that is remaining. Yeah, so this is a patient who has been again brought for VR opinion after repair of a penetrating injury, a full thickness laceration. So this is what we see here. Now, there is no confusion regarding here. Retinal detachment, you need to intervene. So that is one. But only thing is that when I look through the indirect, so this is, I saw something which I had never seen through an indirect in a trauma here. I could actually see the open injury still there. So which means that there is part of the penetrating injury, part of that full thickness wound which is still unsutured. You are seeing it through the indirect. So I asked the help of the skin surgeon, and you can see that the muscle is being retracted like that. You can see that the open wound still under the muscle. So the muscle has to be disinserted here, and that area, so there is the muscle being disinserted and the full lacerated wound is being now sutured. So I mean, just to tell you that you need to sometimes explore and find out the full extent of these wounds sometimes. And once we have got everything sutured, now we go for the VVR intervention here. So you can see what is the situation inside, hemorrhage, the RD, retinal detachment, and this is the area of that. There is still some area which is still open, it seems. But anyway, could settle it under PFCL. And had to do some amount of retinotomy also, and this is 1 week post-operative picture. After some time there was some PVR and had to intervene again. So that is how it goes in trauma. So he needs multiple interventions many a times and should be ready for all those things. Now, scenario 2, so was referred from another medical college. As per records, 4 days back an injury, there was hypopyon on presentation itself, intravital antibiotics is given, and CT scan showed an intraocular foreign body and was referred. So that is another situation where you need to intervene immediately. Endophthalmitis, when do you need to do a primary vitrectomy? Initially itself is that one is when you have an intraocular foreign body, second is when you have an RD, third is when you have suspect and antifungal and a fungal endophthalmitis. Even otherwise, nowadays I think most of the VR surgeons generally go for a vitrectomy initially itself. So here it was a no-brainer, you need to intervene immediately, but luckily for us the intravitreal antibiotics has actually worked very well and infection was sort of contained. So this is the vitrectomy being done. First of all, you have to remove the, there's a cataract also. So I just did a Blumenthal and removed the cataractous lens initially. And yeah, that is the cataractous lens coming out. And after that, you go ahead with the vitrectomy, remove all those exudates. So nowadays I think initially it was only core vitrectomy. Now with the modern vitrectomy techniques and all, we generally go for a near total vitrectomy. Anyway, in order to access the IOFB that was needed. So after the exudates are all removed, you can see that that is intraocular foreign body remaining there. And we have this large electromagnet in the RIO, which actually helps us to do these things, just to extract that without actually going in. So that is the intraocular foreign body. Okay, so these are some of the risk factors, when you have an open globe injury, when you have a retained intraocular foreign body, when you have a delay in wound closure of more than 24 hours, when you have an injury in a rural setting, when you have a ruptured lens capsule, these are all the situations which tells you that there is a possibility of endophthalmitis happening. It would be prudent to actually give intravitreal injections of antibiotics also along with the repair at that time. Okay, so that is all. To conclude that with the advent of the modern vitrectomy techniques, and we have got actually an improved prognosis in cases with post-segment involving trauma. There's a shift towards earlier vitrectomy, more complete vitrectomy and more frequent vitrectomy. But the patient and surgeon should be ready for late intervention, multiple procedures because of this PVR, ERMs, then later cataract surgery, silicone oil removal, etc. Thank you.
Thank you, Biju sir. I request Suguna ma'am to hand over our token of appreciation to Dr. Biju John. Now we will resume our next scientific session, uveitis, the silent storm. Here we will explore the complexities of uveitis, its intricacies, and discuss strategies for effective management. We are honored to have two distinguished consultants serving as our chairpersons for this session. Dr. Dhanya R.S., Assistant Professor at Government Medical College, Alappuzha. Dr. Indu V.P., Consultant Vitreoretina Surgeon, Chaithanya Eye Hospital, Kottayam. Managing uveitis requires a collaborative approach involving a team of specialists, including rheumatologists, physicians, ophthalmologists, and respiratory physicians. In this session, titled Demystifying Anterior Uveitis, Dr. Lekha T., Senior Consultant in UV and Medical Retina at Giridhar Eye Hospital, Kochi. We are pleased to have Dr. Lekha to join us for this important discussion. Over to you, Dr. Lekha.
Good afternoon. I thank Dr. Chaithanya and the scientific team for giving me an opportunity to be a part of this excellent CME. So the topic for me is demystifying anterior uveitis. As we all know, uveitis is a heterogeneous collection of diseases with more than 80 different causes identified. And it is important because it causes 5% of legal blindness. It can be due to local immune phenomena, but majority are systemic diseases with ocular manifestations. And etiology can be widely ranging from autoimmune to infections and even masquerades. Accurate diagnosis is very important because the treatment and prognosis vary. So how should we proceed? Let's start with a classification, and as we all know, the basic classification is into anterior, intermediate, posterior, and panuveitis. And today in my talk, I will be dealing with anterior uveitis, which is the commonest form of intraocular inflammation. It's generally less serious and less sight-threatening, provided it is treated early and appropriately. But sequelae can sometimes lead on to long-term complications. And these are known to everyone. These are the typical symptoms of pain, redness, photophobia, blurred vision, and lacrimation. And these are the signs, starting with corneal congestion, keratic precipitates, anterior chamber cells and flare, changes in the iris, nodules, synechiae, and complicated cataract. And it's very important that we assess the severity and grade the amount of cells and flare in the anterior chamber. There are other dimensions to characterize the uveitis because that will help us in our final diagnosis. We should look at the onset, the duration, the laterality, whether it is granulomatous or not, the possible etiology, any systemic association, and host factors. And these are some of the common conditions which presents as anterior uveitis. So we will go through these scenarios and see how we can demystify anterior uveitis. A general approach would be to start with the history and physical examination, have an anatomical classification, look into the associated factors, incorporate the lab reports, and come to an etiological diagnosis, and then institute treatment. So we have a 54-year-old male who presented with redness, pain, blurred vision in the left eye since 1 month. But he gives history of similar complaints in both eyes, but alternating between 2 eyes. So this is an important point to note. He also has systemic illness in the form of joint pains and backache. He was diagnosed as rheumatoid arthritis and was treated with medications, but he discontinued. And this was his anterior segment with fine keratic precipitates, significant AC reaction, fibrin, and we investigated and found him to be HLA-B27. In fact, that's the first investigation that we need to do in such a scenario. And with the topical therapy, he improved well, as you can see here. So this is the classical presentation of acute non-granulomatous anterior uveitis with fibrin associated with HLA-B27. It is usually recurrent and alternating. And they also need rheumatology referral whenever they have the systemic issues. Now, I chose this case to indicate one more point, that this patient was actually diagnosed as rheumatoid arthritis earlier. So many patients come to us with labels of previous diagnosis which may not be entirely correct. We have to approach with an open mind, see what is the case, and then make your diagnosis. This is little off the track. This was another lady with redness and pain. She was treated elsewhere with topical steroids, but she came 4 days later saying that there is worsening with steroids. And you can see the pupil is miotic with significant fibrin. The only thing I did was add a cycloplegic. And within few days, you can see the synechiae is broken, pupil is dilated, and patient is symptomatically much better. This is just to emphasize the importance of role of cycloplegics in the treatment of any anterior uveitis, because many a times I find patients being treated only with steroids. It's very important that we add cycloplegics also. Now, this is a 33-year-old male who has been having recurrent redness for 20 years. And he also has ankylosing spondylitis, even undergone hip surgery. He is HLA-B27 positive. Very poor vision in both eyes, high IOP in the right eye, which shows all the features of a chronic uveitis with a posterior synechiae, non-dilating pupil, and complicated cataract, really a result of negligence. So this is a chronic HLA-B27 related anterior uveitis. Generally, HLA-B27, if treated early, it has good prognosis, but if neglected, it can result in such a poor situation. So HLA-B2, among all patients with recurrent, alternating, non-granulomatous anterior uveitis, almost 80% is likely to be HLA-B27, and that is actually the only test that we need to do in such patients. And in those patients who have HLA-B27 positive, almost 60 to 75% will have some kind of spondyloarthropathies. So that in almost 50%, it will be undetected, which means we are the first to detect this problem. So it is important that you characterize the uveitis, do the appropriate systemic investigation and detect the underlying cause. These are the various spondyle arthropathies which can be associated with HLA-B27, juvenile idiopathic arthritis, inflammatory bowel disease, psoriatic arthritis, etc. And for all this, uveitis is the most important extra-articular manifestation. If not treated, this can also cause complications like cataract and glaucoma, and recurrence is another issue, but generally this has a favorable prognosis. Now we go to our next case. This is a 38-year-old male who noticed a defective vision accidentally, and he has still good vision, 6 by 7.5, and what you're seeing is a white eye with multiple fine stellate KPs, iris nodules, PSC cataract, and this is a combination that you see in Fuchs uveitis. Investigations, if you are in doubt, you can do it, but generally no treatment is required. So this is the second most common form of non-infectious uveitis, usually unilateral and chronic. The typical ciliary congestion, cyanic A, and all you see with other uveitis is absent here. Diagnosis is clinical, no role for lab investigations unless you want to exclude the other possibilities. Etiology is obscure, it ranges various attributed to our infections, autoimmune, hereditary, degenerative, etc. No role for treatment except for the complications of cataract and glaucoma, and this is a condition which is very often underdiagnosed and overtreated. This is a young male who has redness, blurred vision, and pain since 4 days. He had similar complaints in the same eye, not in the other eye, and no systemic illness. And what we see is a typical whitish keratic precipitates with a low-grade anterior uveitis, and he resolved. But he also had high IOP. So this is a scenario of hypertensive uveitis, or the Posner-Schlossman syndrome, which is again comes under the group of viral uveitis. Usually it is unilateral and recurrent with ocular hypertension. Increase in IOP will be out of proportion to the amount of cells that you see, and it resolves soon with just steroids and anti-glaucoma medications. In between the attacks, the patient will be very much normal. Generally, they don't develop cyanic A or vitritis, and a viral etiology is attributed. Now this is an elderly man with pain and redness in the left eye since 1 week, and you can see the granulomatous KPs, and he also had a high IOP. And the another feature is this kind of iris atrophic changes. So when you see this combination of granulomatous uveitis, iris atrophic changes, and high IOP, the first thing that you should think of is a viral uveitis. So when we looked into the history again, he gave history of herpes zoster ophthalmicus. He was treated at that time, but whenever he stops the treatment, he gets a recurrence. So we were also initially treated him with only steroids. Then when we added antivirals, and he responded well. So when should you suspect viral? In any patient of anterior uveitis with high IOP, if they have associated corneal or iris changes. It can present in different forms, just as granulomatous uveitis or Posner-Schlossman or Fuchs, which I've shown to you. AC-TAP is useful to detect viral DNA, and treatment you have to include systemic antivirals. This is another elderly lady who's been having recurrent redness, responds to steroids, but the inflammation comes back. She gave a past history of TB, for which she was treated with anti-TB treatment. Her routine investigations for uveitis were normal, but she continued to have recurrence, so we went ahead with an AC-TAB, which was positive for MTB genome, and she responded to a course of topical as well as systemic steroids. We did not repeat the ATT because she has already taken it. So there are certain situations where AC-TAB is extremely useful, like in case of suspected infective uveitis, or you have an atypical or a recurrent inflammation, those refractory to treatment, or in an elderly which has very misleading clinical presentation. Generally, it has high reliability and low false positive rate. Now we see a young girl, 6-year-old, who's been having recurrent redness in both eyes in 7 months. And she's been already seen by rheumatologists, found to be ANA positive and on immunosuppressives. And incidentally, she was on steroids for her allergic rhinitis. She had relatively good vision, but her IOP was high. And we see this kind of uveitis in a white eye. So this is suggestive of chronic anterior uveitis due to juvenile idiopathic arthritis. We treated her we added the topical steroids, anti-glaucoma medications, but her IOP was not coming under control. She required multiple medications, and finally she stabilized only after adding biologicals. So JIA associated uveitis is one of the most common cause of pediatric uveitis, and especially more common those with the oligoarthritic type with positive ANA, and in females usually it is bilateral and chronic, and because it's a chronic condition there is a high risk of complications. Steroids are only for the initial treatment. Later you have to treat them with immunosuppressives and biologics. Can I take 2 more minutes? Yeah. So this is an elderly lady who was having recurrent redness in the right eye, not much of systemic complaints, and on investigation she was noted to have high angiotensin converting enzyme levels. So she was referred to pulmonologist, and then turned out to have significant hilar lymphadenopathy also involving the other lymph nodes, and biopsy confirmed granulomatous inflammation, and she was started on steroids. So this is a case of definite sarcoidosis with non-granulomatous anterior uveitis. So remember, sarcoidosis, though it's a multisystem disorder which can even cause span uveitis, sometimes it can present with only anterior uveitis, and that is why ACE is a part of workup for anterior uveitis. The typical findings described as iris nodules, trabeculitis, and tent-shaped KPs. This is a 37-year-old male who has been treated for recurrent anterior uveitis, and with like steroids, antibiotics, everything. Like many people do toxo, and invariably you get high titer and give antibiotics. Again, that has no role. You choose toxo only if you are clinically suspecting toxo. So he was having recurrent uveitis and CME, which responds with topical medications. He was then lost to follow-up, and then again came back with another attack of uveitis with CME. That is when I saw the patient. So because of his recurrent CME, I decided to go ahead with an imaging, and that showed diffuse capillaritis with fern-like leakage, hot disc, and macular edema. So we revisited the history. He had oral aphthous ulcers. He was referred to rheumatologist, found to be HLA-B27 positive, suggestive of Behçet's disease, and he stabilized following treatment with immunosuppressives, and this is after 2.5 years. So Behçet's can also present as isolated anterior uveitis, usually non-granulomatous, and they can have the typical mobile hypopyon, which is in severe cases, and the gold standard is imaging. So imaging has a role even in anterior uveitis when it is recurrent, atypical, bilateral, or associated with CME. This is a 9-year-old boy who also was having recurrent uveitis, white eye, and he was not responding to steroids, fundus, everything was normal, but he kept on getting recurrence. So we advised imaging, but the parents were not willing. Again, when he had the next flare-up, they agreed, and this boy also had diffuse fern-like leakage, suggestive of Behçet's disease, and this boy also required finally biologicals for stabilization. So especially in pediatric uveitis, the findings can be very subtle, and DFA has an important role, and it is also an indication for systemic therapy. This is a 56-year-old lady who had chronic anterior uveitis, synechiae, and complicated cataract. Actually, there is a clue in the slit lamp photo itself. I'll show it. So she has vitiligo, poliosis, and alopecia. So this is an acute exacerbation of a weak age disease. So sometimes an exacerbation can present as only anterior uveitis, and when you're seeing the patient for first time, these kind of subtle clues will help you to diagnose and avoid unnecessary investigations. This is a 28-year-old girl who presented with sudden onset of redness. She is a myope using glasses. She still had 6/6 vision, but you can see there was a significant increase in the myopia, bilateral non-granulomatous anterior uveitis with shallow AC and pigment dispersion. Then we asked the history. She said she is on topiramate, and she was treated and responded, and you can see the myopia also reversed. In such cases, they can also have choroidal detachment or at least a choroidal thickening, which will reverse after the treatment. This was another elderly lady on anti-glaucoma medications for a long time, recently diagnosed to have uveitis and referred to us. You can notice the lengthening of the eyelashes, a hazy cornea, and granulomatous KPs, all related to latanoprost. So these are the various anti-glaucoma medications which can cause uveitis, and these are some of the other drugs which can cause uveitis. So this is my last case. He's a 12-year-old boy with redness since 1 week, had 6/15 vision, but had severe non-granulomatous anterior uveitis with high IOP. We were not sure the gonioscopy showed closed angles, but unusual thing was an the thickening of the iris. So this you can see very well in the ASOCT as well as the UBM, and there was also an iris cyst. So because nothing else was there, we initially treated him with topical steroids. Fundus was also normal except for the glaucomatous changes in the disc. So then we looked into the history again. He was treated for ALL, but he had a review recently, MRI, blood workup, peripheral smear, everything was normal. But since he was not responding to our treatment, IOP continued to increase. We went ahead with an AC tab, and cytology showed lymphoblast in significant number, and he was referred to oncologist. So this is an example of uveitic masquerade syndromes. Various neoplastic and non-neoplastic conditions can present as uveitis, and we should be aware of this also. So to conclude, from the initial symptoms and signs, we can make a working classification or differential diagnosis. Then you revisit the history, do a more focused examination and tailored investigations, which will help to reach a diagnosis or at least narrow down your differentials, and then start the general and specific treatment. Sometimes you have to involve other specialists also. And once the treatment is started, we should monitor them for the effectiveness of therapy and also to look for an entry of any complications. Thank you.
Thank you, madam. That was a very comprehensive talk. Great. I just ask you one doubt, regarding the granulomatous uveitis. There are various infective as well as non-infective entities, but can you give me some clues as to go in for whether it is a non-infective or infective, from the beginning?
Yeah. So among the infective ones, like as I showed you, viral is one of the very common thing. So usually it will be unilateral and associated with a high IOP, or if you see any iris changes or corneal changes, you think of viral. Whereas if it is a bilateral granulomatous uveitis, if they have a past history of TB or contact history, either exposure to a patient with TB, then you think here it is bilateral granulomatous, need not be associated with high IOP, then you think of TB. And syphilis, of course, can be a mimicker for everything. So generally when you are in any granulomatous uveitis, unless maybe in viral, you can ask for investigations of TB and syphilis. Whereas non-infective is usually what we see is a sarcoid. Sarcoid, again, you can ask for pulmonary symptoms. We do AC as a common investigation, and then depending on the results, we can proceed with sarcoid workup if there is a strong suspicion. Behçet's usually is non-granulomatous.
Actually, the sarcoid will give a negative manto also, I think.
Yes, yes, good, yeah.
Madam, in which all situations do you involve a rheumatologist in the treatment of anterior uveitis?
Actually, whenever I think, if there, for example, in HLA B27, if the patient does not have any systemic symptoms till the presentation, I'll ask them for all the history. If they give, and majority of my patients have given history of either arthritis or joint pains, low backache, etc., then I usually refer to the rheumatologist because they will do the further evaluation for spondyloarthrosis. I generally never advise MRI, hip or sacroiliac spine directly. So that is one situation. Or in those pan uveitis, which we are seeing as anterior uveitis, but basically like sarcoid or Behçet's, they need long-term systemic therapy with immunosuppressives. I usually refer to rheumatologists because I generally don't start immunosuppressives directly. I usually involve the rheumatologist because I feel they are better off in monitoring the side effects and titrating the dose and other things.
Tell you that we are dealing with a masquerade syndrome. Any specific red flags that we have to look for when you're dealing with anterior uveitis?
I think in an elderly patient having uveitis for the first time, keep masquerade as a differential diagnosis. In children, again, like the two extremes of age are very important. And now we know the pattern of most of the uveitis. So if the presentation is not fitting into any of the typical patterns, even after investigations, we are not able to attribute the cause, then think of masquerade.
And presence of hyphema?
Hyphema, yes, like our child, actually I didn't describe, he developed hyphema immediately after the AC tab, but at presentation he did not have. But again, if you have a cause for the hyphema, like there might be a trivial trauma, which they would not have given. So if you know the cause of hyphema, then you need not suspect masquerade. Otherwise, yes. Then this juvenile xanthogranuloma, that's a condition which is one of the masquerade, though it's not a very common condition. And these masquerades will respond to steroids initially. So we tend to think that we are treating a uveitic entity. But if there is recurrence, even after steroid treatment, again you suspect masquerades.
Thank you, Madam. Yeah. And
Thank
I think even if it is an anterior uveitis, a thorough posterior segment evaluation is very essential before ruling out it is.
Definitely, definitely. All cases of anterior uveitis, please see the fundus in detail. And if in the first visit, because of synechiae, you are not able to see properly, at least by the time after the cycloplegics, the pupil has dilated and the media haze has come down, see the fundus. It's very important.
Thank you, ma'am. Thank you.
Thank you, Madam, for your insightful presentation. The final topic for this session is algorithmic approach to diagnosis and management of posterior uveitis. Get ready for an engaging exploration of posterior uveitis where the eye reveals its dramatic complexity. We are excited to learn a tailored approach to posterior uveitis from Dr. Natasha Radhakrishnan, Senior Retina Consultant and Head of Pediatric Retina and Uvea at Chaithanya Eye Hospital, Ernakulam. Over to you, ma'am.
Good afternoon to all. Thank you, Ophthalmic Society of Pathanamthitta, for having me here. So we are going to learn algorithmic approach to diagnosing and managing posterior uveitis. Though I have named it algorithmic, it's more than an algorithm for posterior uveitis. What is important is the pattern recognition. So that is what we will be concentrating on. You know that it is inflammation that primarily involves the choroid and by default involves the retina. It can be infectious, inflammatory, or it can be masquerades as well. So if you look at the differential diagnosis of the major causes, you can see that the list involves both infective like TB, syphilis, leprosy, Lyme disease, toxo, non-infective like your sympathetic ophthalmia, BKH, sarcoid, Behçet's, and masquerades can be lymphoma, but it also has endophthalmitis and trauma. So before you, when you're examining your patient, the questions that you need answers to are, is it posterior uveitis alone, or is it a posterior involvement as part of a pan-uveitis? Is it a choroiditis primarily, or is it a retinitis, or is it a retinochoroiditis? Is there associated involvement of the optic nerve or the retinal vessels? Does the clinical feature fit into any known infective or non-infective entity? Is there associated anterior segment inflammation or vitritis or any sequelae? Is it associated with systemic features? Is it recurrent? And if so, how has it responded to previous therapy? Is it associated with an immunocompromised state? And are you looking at a masquerade? So many questions you need answers to during your examination. So age, gender, ethnicity, medication history, past ocular history, pre-existing systemic conditions, like Lekha Madam has already said, it is so important to speak to your patient about how it has evolved and not just the present situation. After that, a dilated retinal examination, IOP, and do not just because you're a retina specialist or you are just looking at the fundus, don't forget to look at the slit lamp and don't use your indirect ophthalmoscope as a substitute. The retinitis, if you're seeing, it presents as fluffy yellow-white areas with poorly defined margins, which can be focal or multifocal. A simple clue towards distinguishing retinitis from choroiditis is the presence of vitritis usually. Usually, a retinitis will have some overlying vitreous inflammation, while choroiditis need not. And the margins will be not so well defined when it is retina. It will be more well defined when it is the choroid. It can be focal, it can be multifocal, so that you have to find out whether there are more than one focus there. And you know that the most common thing that we see with a focal retinitis lesion, it is a retinochoroiditis. So it primarily looks like a retinitis, though underlying choroid is also involved. It is focal, it has severe vitritis, it has venous vasculitis, typically not just along the lesion, but away from the lesion also, which is very, very classical of toxoplasmosis. It has arterial sheathing called the chiraliasis, which is not actually an arteritis, but just arterial perivascular sheathing. And traction with disc drag in the periphery with traction band and no vitritis is usually a late presentation of a toxocara. Sometimes we see it in children. They will be asymptomatic, presenting with a squint, or they will present with defective vision, and when you examine the fundus, you see this picture. The other retinitis that we deal with is acute retinal necrosis. Here it is multifocal, it is peripheral, there is vitritis, it is in an immunocompetent patient, and when it heals, it leaves patches of necrosis which can lead to retinal detachment. Now, this is a very important thing that is missed because it presents as a vitritis. So, patient will present with severe vitritis, and if you do not examine the periphery, you will miss these patches of vitritis in retinitis in the periphery. They are confluent patches. They will be very vaguely seen because of the severe vitritis. You may not actually see it very clearly, but if you see those tongue-shaped lesions anywhere in the fundus, keep the diagnosis of acute retinal necrosis. When it's an immunocompromised patient, then you may be looking at CMV retinitis. CMV retinitis has the classic picture of hemorrhages interspersed with whitish areas. It will have a healing edge, it will have an advancing edge, and it may be multifocal. It need not be a single patch, maybe multiple patches. Nowadays, like when we say immunocompromised, we think of patients who are having conditions like HIV or some other but nowadays the common situation where we see CMV retinitis has changed into patients who are taking biologics for other reasons, like rituximab for an SLE related nephropathy or something like that, because that is again an iatrogenic immunosuppression that is happening there. So you have to keep a eye, like just because the patient is not HIV positive does not mean the patient is not immunocompromised. So keep in mind that other reasons for immunocompromise may be there. Retinal vasculitis, here again characterization and picture recognition is very important, because here you are trying to answer whether it is an arteritis or is it a venous vasculitis or is it a combined, because that itself will give you a list of the conditions that are involved with it. So when you are looking at a predominantly arteritis, predominantly venous, you are thinking of conditions like sarcoidosis, which is the classic, the candle wax drippings, periphlebitis, patchy periphlebitis is a very classical picture in sarcoidosis. Then if you're looking at arterial arteritis, then you're looking at conditions like Behçet's and polyarteritis nodosa. Sometimes SLE can also present with arterial occlusions. Combined occlusive when both vein and artery are involved, which means you will have the picture like a venous occlusion with multiple hemorrhages, but you're also seeing retinal whitening where the arteries have become occluded because of occlusive arteritis. And this shows the angiogram in which you can very clearly see that both arterial and venous filling are completely absent in that area. Then other features that you have to look for in the fundus, exudative macular detachment, because then you're looking at conditions like VKH or posterior scleritis, cystoid macular edema. As an addendum to Madam's talk, the cystoid macular edema in an anterior uveitis does not convert it to panuveitis. It is a complication of the anterior uveitis. Then it is called anterior uveitis with cystoid macular edema. But if you have vitritis and you have cystoid macular edema, then it becomes a panuveitis. Then epiretinal membranes because of chronic uveitis, retinal neovascularization, the picture that I showed you before, in a few weeks' time that will go into retinal neovascularization, sometimes secondary vitreous hemorrhage, sometimes late presentation of a uveitis maybe as a choroidal neovascular membrane. Some of these ARNs present with rhegmatogenous retinal detachments, and you can have the optic disc edema also, which is the presentation as a neuroretinitis. So all these features also you have to look at. When choroid is the primary seat of the inflammation, choroidal inflammation can be again focal or multifocal. You can, TB will come in both. You can have it as a focal lesion and you can have it as multifocal. But classically, all the others are your focal conditions like nocardia, candidiasis, chikungunya virus, and multifocal is usually histoplasmosis, again cryptococcus, a lot of conditions that we don't see here commonly, but what we see here commonly, one is TB and the other is an idiopathic multifocal uveitis or multifocal choroiditis with panuveitis, which is an entity by itself. Now a little bit more about TB. peripheral venous vasculitis, what was previously told as Eales disease, is now reclassified as TB. Most of the time they come TB positive. Now Eales disease specifically is only if you are completely ruled out TB and you've got an idiopathic occlusive peripheral vasculitis. Focal or multifocal choroiditis, typically the lesions will be along the blood vessels. You know that it has been described as a serpiginous-like choroidopathy sometimes. It can be an abscess, it can be tubercles, like smaller lesions, it can be miliary where they present with multiple small lesions, and it can present as exudative RD and posterior scleritis. So this patient is like an Eales-like picture, peripheral occlusive vasculitis with secondary neovascularization leading to vitreous hemorrhage. This is a tubercular abscess-like picture near the disc, and this is a serpiginous like choroidopathy. VKH is a more typical constellation of signs which allow us to diagnose it much faster. Granulomatous panuveitis, headache, tinnitus, prodrome may be there. Disc edema will be there, multiple sensory neural detachments, usually bilateral. But VKH can also be confusing, especially when they come to you partially treated, when the fluid may have gone and you are just seeing a little bit of vitritis. Or it can be confusing when the fluid has completely resolved on its own, what we call an incomplete VKH, when all the features are not there. So in those conditions, FFA and OCT will give you a very typical picture. The fluorescent angiogram shows the typical pinpoint leaks that then coalesce to produce the large detachment areas, and the OCT will show you the very typical bullous sensory neural detachments with the borders in between. Optic nerve is commonly involved in posterior uveitis, either as an inflammatory papillitis or it may be involved in conditions like VKH as part of the condition itself. So it is important to test optic nerve function and also look for other cranial nerve involvements. Like I said, cystoid macular edema can be in both anterior and posterior. Now, approach to management, so identify the typical fundus picture, confirm with specific investigations. Like Madam said, if you have an acute anterior uveitis, there is no point in sending for toxoplasma. But if you have a focal retinitis lesion there, definitely toxoplasma should be high on your list and not HLA-B27. So tailor your investigation depending on your uveitis finding. And if it is a if it is an infective, definitely it requires anti-infective agent. And once you have ruled out infection, then systemic steroids. Always remember that if you need to use your systemic steroid for more than 3 months and you're not able to taper it off, definitely the patient needs to have steroid sparing agent. Avoid periocular or intravitreal before you know the diagnosis, and in diagnostic dilemmas like the AC tap, the vitreous tap can also help you in PCR identification. Now, Dr. Dhanya had asked clues for an infective cause. In posterior segment, it is when it is unilateral, when it is moderate to large KPs, if you have a raised IOP, a retinitis. A retinitis is almost always infective, except sometimes in Behçet's. You can get retinitis in Behçet's, but generally, if you have a retinitis, it is likely to be infective, more than just vasculitis. If it is an immunocompromised patient, and remember always that syphilis is a great masquerade. In masquerades, the important things that we have to remove, sometimes rhegmatogenous retinal detachments are confused with exudative detachments because there will be some pigments in the vitreous and it can be confused. Retinitis pigmentosa, again, can be confused as a posterior uveitis, endogenous endophthalmitis, drug-induced uveitis, primary lymphomas, and other metastatic tumors. Let me skip this. Let me just show you this patient, 40-year-old lady who presented with a very typical VKH-like picture with bilateral disc edema, multiple sensory neural detachments. FFA showed some the pinpoint leakages, and we treated her with steroids. After just sending the investigations, we didn't wait for the investigations. She presented after about 60 milligram, and then when she came down to 50 milligram, 2 weeks lost to follow up for some time, then she came back with this bilateral, severe, like an orbital cellulitis-like picture. And this time the fundus picture had already changed with multiple tubercle-like granulomas and large tubercle-like lesion in the macular area. And then her manto came back strongly positive, necrotic, even after the steroids. B scan showed a diffuse choroidal thickening. PCR for the aqueous turned out to be TB positive. And to this day, we don't know whether it was a latent TB that flared up because of the steroid, or did we misdiagnose it, TB choroiditis, did we misdiagnose it as a VKH? But that can happen. So always, always, before you start your full dose systemic steroid, rule out TB in our population. Imaging in uveitis, I think most of it we have already covered. OPHTA can use, we can use an OPHTA for inflammatory CNVMs later on. Always remember, when the patient comes back to you, it need not always be a uveitis recurrence. And when you're looking at the posterior segment, if you're seeing typical features of a choroidal neovascular membrane, it is a sequelae of your posterior uveitis. So keep that in mind when you're seeing a recurrence, and do not think it is a recurrence of the uveitis itself. B scan can help you in your scleritis and in retinal detachments, and to look at the choroidal thickening as well. So systemic investigation, your aim should be to confirm etiology and to rule out infectious etiology, and you should base it on the type and characteristics of the uveitis and the ocular and medical history, geographic and environmental features. This is a huge algorithm as to what to investigate when you have some particular features, which is a little difficult unless you have it printed out in your OPD. This patient, sometimes you are left with diagnostic confusions. 48-year-old female, she's a known case of adenocarcinoma of the lung, but presented with a large mass-like lesion near the disc, this one, like a large choroidal mass. Now, is it a METS from the adenocarcinoma, or is it TB? And she turned out to be having TB spine as well. So this was the supratemporal area, the nasal area. Fluorescent didn't give us much information. This is the OCT showing the massive elevation, B scan showing a rather solid elevation. And but patient has radiological evidence of TB spine. So finally we decided to do a vitrectomy, vitreous tap and take a sample, and it turned out to be TB. So it completely resolved with ATT. So to sum up, after history and fundus examination, look at the fundus. Is it a retinitis? Is it choroiditis, or both? Is it focal? Is it multifocal? Is there vasculitis or not? If there is it arterial, venous, or both? Is it peripheral or is it central? Is the patient immunocompetent or compromised? Optic disc is affected or not? Macula affected or not? Is there associated exudative retinal detachment? Use imaging modalities to characterize better. Do systemic and serological workup as indicated. Be ready for surprises and to change your diagnosis, and use a tap or biopsy whenever necessary. Just to remind you all of this society, that a trust that has been launched, Childhood Uveitis Blindness Support. It is very active. We have good funds with us. If any of your patients need support, please do approach me. I'll be happy to help them out. And also, if anybody wants to contribute, I'll be happy to accept the contributions as well. Thank you very much.
Thank you, ma'am. That was again another very extensive talk on posterior uveitis. You led us into many of the clinical entities that we usually come across in our clinical practice. There are so many questions to ask. I don't know at this time. I
think everybody is hungry.
Yes, everybody is hungry. I'll ask the audience if they have any doubts. Just one question, ma'am. How often do you go for a vitreous tap, and if you see a case like whether there is any definite indications if it is like severe vitritis? Some cases, like we used to come across a few cases of endogenous endophthalmitis. Like even we had 2 or 3 cases of bilateral endogenous we started on with a systemic antibiotic as usual because it was bilateral. There was no other previous records. They both were like elderly patients. So how early would you go for?
Endogenous endophthalmitis, most of the time we are able to make a diagnosis because of the setting of the patient, uncontrolled diabetes or a recent kidney surgery or some recent, like sometimes intestinal surgeries. So the setting usually gives us the diagnosis that it is not a uveitis you're looking at, it is an endophthalmitis. What do you do then? Again, depends upon the systemic condition of the patient. The first thing that you have to do along with your systemic antibiotic is an intravitreal injection of antibiotic. Whether you do it or antibiotic or antifungal, depending on whether you can see the fundus. If you are able to see the fundus, fungal end of, and if you've got fungus from the blood cultures and the urine culture, that is the first investigations that we send. Then you can put in accordingly. If you are looking at fungal, put in antifungal, but that should be done at the bedside, in the ICU, wherever the patient is admitted. After that, whether you want to take up for vitrectomy depends on the response. So if the patient is getting better and the fundus picture is also getting better, you're able to see better, then you can repeat your intravitreal after 2 days. Or if you have taken a tap and you've got it, the tap is not so important in endogenous endophthalmitis if you have already got a diagnosis from the serum, because always remember that it cannot reach the eye without it being in the blood. So sometimes it takes you have to talk to the physician. They will not agree. They will say it's all controlled, ellam controlled, UTI controlled, everything is fine. But you have to talk to the physician that a blood culture, repeat blood culture has to be sent, because they will get from that. If not, the tap helps us in one way because it removes a little bit of the vitreous, so it allows the volume of the antibiotic and antifungal to go in, send it for a KOH and a gram stain. If you get from that, modify your intravitreal according to that. If not, then you have to consider vitrectomy. If it is very severe endophthalmitis, hand movements, vision, and you have to consider vitrectomy at an early date. But how much will entirely depend on how bad systemically the patient is, because the patient has to finally tolerate the procedure. Or if you don't have facility in your hospital, you may have to refer to the VR surgeon. In the meantime, keep repeating your intravitreal.
And one more question, ma'am. If there is a focal necrotizing retinitis, as you suspect is a toxo, then how do you plan the management? You do go for the conventional quadruple or
toxo? Another thing that we can keep in mind is that nowadays we don't usually get IgM positivity for all the cases, but we get a very high IgG positivity. So with your clinical suspicion and a very high IgG positivity, you can still think of it as toxo and start treatment. I personally start, unless the patient has a sulfa allergy, start on Bactrim DS, which is the cheapest and easiest available drug, double dose, morning and afternoon. I also add an azithromycin, and then I send a Manto or a quantiferon TB. Once that comes as negative, 3 days of antitoxo, and then start on 1 milligram per kilogram steroid. Only condition in which I would avoid the steroid is if the lesion is really small and away from the fovea without much vitritis. Like some of these recurrences don't come with the florid picture. They will just come with a small lesion there. Those actually respond just with your antitoxo. You don't need to add steroid, but generally with the vitritis, you will need steroid also. Then I keep the steroid on for about a week to 10 days and start reducing by 10 milligram per week and stop the whole dose by around 5 weeks. Once it is over, so assuming you started at 60, by 5 weeks you will be able to bring it down to 10 and stop, and then continue your Bactrim and azithromycin all the way up to that, and 2 weeks after also. And then stop. In all of this, educating the patient is very important. Adu kadichilla, idu kadichilla, and all, they'll come back with half the things not eaten properly. So don't give a automatic taper. That would be my advice. So even topical steroids, when you give an automatic taper, it just ends in non-compliance. Like you say, angiosum, the pin angiosum, and every angiosum. So stop it there and say, till review, you put this and you come back to me and see and monitor, and then you reduce further. So same with the systemic steroid. Tell them it is steroid, and then you tell them that you have to come for review, and then so you will improve compliance.
Posterior uveitis is always a very confusing topic. You have mentioned a lot of investigations that we need to do. So in a normal routine OPD, when a patient with posterior uveitis comes to you, how do you decide on which test to be done? What is your normal routine?
You're talking about ocular investigation.
Yes, sir. Yes, ma'am. Ocular investigations.
Yeah,
ocular and systemic. I mean,
Ocular investigations, I would go with an OCT 100% for all the patients to look through the lesion and through the fovea. Look for macular edema, look for an epiretinal membrane that tells you that there is chronicity. Through the lesion, it characterizes whether it is retinitis, choroiditis, is there vitritis over it, is there an underlying choroidal elevation, or all these things it will tell you. A wealth of knowledge it gives you, so an OCT is absolutely necessary. FFA, will you do, like for example, toxoplasmosis? If you do not have access to a FFA, even if you don't do, it is fine. But if you have access, it is good. It will tell you how much vasculitis is there. Does it give any value addition to your management? No, it does not. But on the other hand, if you're looking at a condition of vasculitis, then an FFA is absolutely indicated, because there the important distinction that the FFA will tell you is whether it is just an inflammatory vasculitis or is it a vaso-occlusive vasculitis. Inflammatory vasculitis needs only inflammatory control and it will reduce. A vaso-occlusive vasculitis will require if there is a neovascularization already, it will require probably an intravitreal anti-VEGF and PRP. If it is going in for neovascularization or there's extensive CNP areas, along with your inflammatory control, you will need to do a pan-retinal photocoagulation, or at least in that sector which is involved, because otherwise the patient will go in for neovascularization. So FFA is absolutely essential. And in conditions like you have a mild vitritis, like an intermediate uveitis, and no proper posterior segment involvement, Madam has also shown that, like in Behçet's, you will see the ferning. All of that may not be picked up clinically. So angiogram definitely in patients who have vitritis with no obvious posterior segment involvement, patients who have vasculitis, characterized or uncharacterized, definitely need a FFA. ICG in the white dot, I have not touched on white dot syndrome. So in the white dot syndromes, it gives you some value addition to diagnosis if you have access to an ICG. And OCTA in follow-up. OCTA, when you're following up a scar, you can, and it's showing some sign of some fluid around the edges, then immediately without any invasive investigation, you can get a CNVM.
As ma'am told, OCT.
B-scan. B-scan for choroidal thickening, posterior scleritis, invaluable. And to rule out masquerades, especially in children. If whether you're looking at some tumor inside, if you cannot do a fundus examination.
In OCT is also very important, as you told, ma'am. Like you can see the choroidal elevations and the subtle amount of subretinal fluid that is present adjacent, which is maybe in favor of choroiditis. Choroiditis most often. Okay, thank you, ma'am.
Thank you.
Thank you, Natasha ma'am, for sharing this exceptional insight on posterior uveitis. Now I would like to request Dr. Varghese Joseph to hand over our token of appreciation to esteemed speakers and chairpersons. Welcome Dr. Lekha T. Dr. Natasha Radhakrishnan. Dr. Dhanya R.S. Dr. Lekha T. Sorry, Dr. Indu VP. May I invite the chairpersons and speakers of this session to join for a group photo with Dr. Varghese Joseph.
Thank you, sir and madams. We now move on to the final session before lunch, differential diagnosis of polypoidal choroidal vasculopathy, distinguishing between age-related macular degeneration and other retinal condition. May I invite Dr. Rahul R. Menon, consultant vitreoretinal surgeon, Chaithanya Eye Hospital and Research Institute, Palarivattam, to take the stage and guide us through this enlightening session. Over to you, sir.
Thank you. So at the outset, I would like to thank the Ophthalmic Society of Pathanamthitta for this opportunity. So I'll be talking about differential diagnosis of PCV, that is polypoidal choroidal vasculopathy. So the slides have been provided by Bayer. So the prevalence of polypoidal choroidal vasculopathy, that is PCV, is higher among the Asian population. Now, why are we so, why do we want to differentiate PCV from the normal neovascular AMD? Now, if you look at the age group, PCV can affect individuals in the younger age group, right? Second thing, in age-related macular degeneration, the wet AMDs, you will usually have precursor lesions like drusens. So, you can always follow up them closely and you get to know when, you can pick it up a little earlier. Whereas PCV does not have any precursor lesions. So, it is one fine day, unless you examine very closely, they might have a small PED and they have a small amount of subretinal fluid which we can probably overlook. And the pathology, wet AMD, the vessels, the neovascular network is immature vessels. So any anti-VEGF under the sun will work on them. Whereas PCV have much more mature vessels and they have the polyps. So that is the reason the normal like Avastin or bevacizumab or ranibizumab usually does not have a great effect on them. And the natural progression of the disease. Wet AMD, yes, it does cause a lot of vision loss, but the natural progression, if you look at it, it is a scarring. Whereas PCVs can come with massive submacular hemorrhage. So the vision loss is much more profound. Now, ICG is the gold standard for diagnosing PCV. So can we use alternative imaging modalities? Because ICG is not something which is available in all the clinics. So we have option of color fundus photography, OCT, OCT angiography. So color fundus photography in OCT is something which is very freely available in most of the clinics now. So what are the features of PCV on color fundus photography? So you will see something called as subretinal orange red nodules. You will see fibrovascular PEDs, that is pigment epithelial detachments. You can have, if you see massive subretinal hemorrhage, you have to think of PCV as one of the diagnoses. Even peripapillary location, the CNVMs around the disc, you have to think of PCV. And the other eye usually will not, it will mostly be unilateral and you won't have much precursor lesions or prusins in the other eye. In OCT, you will have something called as notch PEDs. So this is what it looks like. Then this is a notch PED, okay? And then you have something called as peak PEDs. So what happens is when you see the normal CSR PEDs, they'll have a subtle sloping, whereas in sharp PEDs the angle will be very acute. That is sharp PEDs, and also this is one very classical sign. You see a PED and you see some hyperreflective ring underneath. So that indicates a polyp. So you can see it over here. This is the polyp over here. This is the hyperreflective ring under the PED. And then the double layer sign, which is not very specific for PCV, but that indicates the location of the branching vascular network. Now, when we talk about wet AMD and PCV, wet AMD will have only the network, whereas in PCV you will have the network along with the polyps at the terminal. So the polyps are the large PEDs and the double layer sign is usually the location of the branching vascular network. So several studies have been addressed to look into the sensitivity and specificity of OCT alone in the diagnosis of PCV. DeSalvo and group found that almost 94% sensitivity in OCT alone with for the diagnosis. So they look for the presence of 3 or more OCT criteria, that is multiple PEDs, peaked PEDs, notch PEDs, and hyperreflective ring beneath the RP. So the PCB work group had presented a very wonderful study recently, Jemmy Chung and group. So what they found was they have found 9 criteria, not just OCT pictures on the clinical examination itself, where such a and these are the 3 the sub RP ring, the sharp PEDs, and the complex RP elevation on NFAS OCT. These are the most important criteria for diagnosing PCV only on the basis of OCT. So this is what a notch or hemorrhagic PED looks like. So this is a sharp PED that I was talking about. So you will have an acute angle PEDs there. And this is the notch PEDs that you can see over here. And hyperreflective ring underneath the PED. And just remember, whenever you see PCVs, you will usually see subretinal fluid. You can very rarely see intraretinal fluid. You will only mostly see subretinal fluid mostly, in most of the cases. Whereas in wet AMD, you will see more of intraretinal fluid as well as subretinal fluid. The reason being because if you look at the pathology, primary pathology, the damage is at the level of RP in AMD, whereas in PCV, it is at the level of choriocapillaries. So this is a case example. So you can see a hemorrhagic orange nodule over here with hemorrhagic PED, and you can see the multiple fibrovascular PEDs over here. So 1 point of among the 4 is checked. Now, if you look at the OCT, you will see the sharp PEDs and the thumb-shaped PEDs. Okay, and you will see the double layer sign. So 3 points are checked. Okay, and when you do an ICG, you can see a beautiful branching vascular network with the polyps at the terminus. So these are the polyps over here. Now, this is another 65-year-old male. So if you look at the left eye is fine. So this is you see an orange nodule over here. And if you look at the OCT, you don't see multiple PEDs. You don't see a sharp PED. You see more of a sloping PED with intraretinal fluid. Okay, so only 1 point is checked. So notch PED and no sharp PEDs. And when you look at the FFA ICG, you will see that FFA, you can see an anastomosis over here and some amount of leakage in FFA. And ICG, you can see a hot spot, and arterial and the venule is connected over here. So this is a type 3 CNVM and not a PCV. So yes, if you look, even if you don't have an FFA ICG and if you see such kind of picture, based solely on the base of OCT itself, you can actually pick up PCV. So what are the other potential benefits of anti-VEGF therapy? We give the treatment of anti-VEGF to give a good vision to the patient, but what else do you get? So there's something called as polyp regression and polyp inactivation. So what happens is, why do like the one point I probably forgot to mention about whether you want to differentiate between wet AMD and PCV is because of the recurrence. CNVM is recurrent, but PCV is much more notorious for its recurrence. So what happens is some of the polyps get inactivated or regressed, and then a couple of months down the line, new polyps develop. So that is the reason. So there's something called as complete polyp regression, where the polyp completely closes down, but after some times, some of the new other polyps can again, or sometimes this polyps can get inactivated for some time, and again after a few months, it will again get reactivated, and again it starts clinical activity. So with Eylea, what happens is it helps in getting a complete polyp inactivation. So in the PLANET study, more than 80% of the patient showed polyp inactivation, and there was a gain of more than 10 liters from baseline at week 52. Patients treated with aflibercept also achieved favorable visual gains and complete polypoidal lesion regression, which was maintained up to 12 months. So what is the importance of complete polypoidal lesion regression is because the chance of recurrence goes down, the patients require less number of injections, and the drug-free holiday, that is the patients having the number of injections, the frequency also comes down. So these are few of my cases that I'm showing. So this was a 42-year-old lady who had presented to me one fine day with sudden drop in vision since morning. So she had a large submacular hemorrhage. If you look at the OCT itself, You can see a large notch PEDs. You can see a SHREM, that is subretinal hyperreflective material, that is basically blood under the retina. And you can see some subretinal fluid over here. So I decided to treat with it injection. I started her on Eylea. This is after first injection of Eylea, 1 month post injection. You can see the subretinal fluid has completely regressed. There's a hemorrhagic PED still here. So when the patient presented to me, her vision was 624. This is after the second injection. You can see that the hemorrhagic PED has completely flattened, okay, and the foveal contour is very much normal. This is post third injection, and this was on last visit when she has regained a good vision. She has a vision of 6, 9, and 6 now, and this is the fundus picture on the left. This is another gentleman, old gentleman, who had a drop in vision for almost a month, and when he was told to have, he had taken, I think, 1 injection of Avastin somewhere, and he had come to me. So this was the picture. So you can see subretinal hemorrhage over there. And in OCT, you can see large PED. Okay, over here, hemorrhagic PED with notching. This is post first injection, where you can see that the PED has completely flattened. The fluid had completely regressed. This is after the second injection. And this is at the end of the injection when I saw this patient. The heme had completely cleared, the PED had completely flattened, but the only thing was, sadly, because of the chronicity, most of the RP and the ellipsoid loss area had completely got denuded, so the vision was not, there was not much great improvement in vision. I think he had come to me with CF half meter, it improved to CF 2 meter. So yes, ICG remains the gold standard for PCV. And however, alternate imaging modalities can also, such as OCT, can help in diagnosing PCV. And when ICG is not readily available, fundus picture and OCT together have a higher sensitivity and specificity in detecting polypoidal choroidal vasculopathy. And alongside achieving clinically meaningful vision gains, Eylea aflibercept monotherapy can achieve complete polypoidal lesion regression as early as 2nd month in patients with PCV, and which can achieve higher rates of polypoidal inactivation. So this finding does show that aflibercept is usually used as the first line therapy for both anatomical as well as visual outcomes in patients of PCV. Thank you.
Thank you, sir. May I invite Dr. Vijayamma to hand over token of appreciation to Dr. Rahul R. Menon.
Yes, sir. So, Octa, what happens is when you look at the polyps, they are a hypoflow structure. The blood flow is very less. So, SSOCTA has been proven to be very beneficial in picking polyps. Whereas normal SGOCTA, which most of us have, they can pick up. So, you have to sit on it and see. So, if you do an automated segment slab, which the machine provides, the chances around 30 to 40% you can pick up the polyps. Whereas if you do a manual segmentation, yes, it goes down. There are studies which shows around 80 to 90% where you can pick up the polyps on Octa, manual segmentation, but not necessary. It should be this thing. And one more thing, what happens is most of the patients, it will never be a treatment naive patient to you. So what happens is they would have taken some injections here and there, maybe aflibercept or Eylea or whatever, Avastin or whatever. So this branching vascular networks, there's something called as process called as hyalinization of the blood vessels. So because of hyalinization, the blood flow even goes down lower. And Octa picks up in a particular range. So if the blood flow is less or even higher than the range, it does not pick up. It shows as a hypoflow. So Octa is definitely beneficial. And there are, SSOCT is comparatively better at picking up polyps.
Thank you, sir. Thank you, ma'am. The dilemmas in treatment decisions for glaucoma through a spectrum of compelling case scenarios and challenges encountered in real-world clinical practice. We are privileged to have with us an esteemed group of panelists and experts in glaucoma care. Moderating this session is Dr. Anne Mary Matthews, Consultant Glaucoma Specialist, Chaithanya Eye Hospital and Research Institute, Tiruvalla. Joining her on the panel are Dr. Kiran Gopalakrishnan, Senior Consultant Glaucoma, Precise Eye Care Hospital. Dr. Roshni KR, Consultant Glaucoma Specialist, Chaithanya Eye Hospital and Research Institute, Trivandrum. Dr. Sarita VK, Professor, Department of Ophthalmology, Government Medical College, Ernakulam. Dr. Danya CA, Consultant Glaucoma and Cataract Services, Chaithanya Eye Hospital and Research Institute, Palarivattam. I kindly invite all panelists to step forward and take their seats. Let us embark on this interesting discussion. Over to you, ma'am.
Good afternoon and welcome to Glaucoma Grand Rounds. Since this is an ITIS conclave, I'm going to concentrate more on certain inflammatory scenarios initially which lead to glaucoma. So the first case is a 46-year-old female who came to us with complaints of pain and blurring of vision in the right eye since 2 days associated with severe headache. She had similar episode 2 months back in the same eye which was treated elsewhere with some eye drops. Her systemic history was not significant. The right eye had a best corrected visual acuity of 6/36. On examination, as you can see in the picture, she had circumcorneal congestion and diffuse corneal edema. Anterior chamber was of moderate depth with few cells. Intraocular pressure was measured to be 54 mm mercury and disc was normal. So here we have a unilateral, severe, acute spike in IOP. Everyone thinks of an acute angle closure attack here, but here is the catch. The other eye was normal with open angles. So we came to the conclusion of a Posner-Schlossman syndrome or glaucomatocyclitic crisis. This patient here was treated with oral and topical anti-glaucoma medications and topical steroids and cycloplegics. Oral antivirals may be given. Possible etiologies include autonomic dysregulation, vascular endothelial dysfunction, viral etiology, and association with HLA-BW54. Kiran sir, what is your take on oral antivirals for Posner-Schlossman, sir?
I don't usually give any oral antivirals when patients present with an attack, a single attack like this. Now there is some evidence of documentation of HSV, VZV, varicella, and CMV in some cases when PCR has been done. But that is mostly for clinical research purposes, because on a routine basis, we are not going to start a patient on an oral antiviral based on a presumed viral etiology when a patient presents with the first attack. Typically, a patient who presents like this with something that is similar to Posner-Schlossman, it may not be Posner-Schlossman, it has certain specific. I just wanted to know, was the chamber very inflamed in this case?
No, sir, it was a very mild uveitis.
But the eye looked really congested.
In the picture.
Circumcorneal congestion and all. That is usually not typical of Posner-Schlossman. The uveitis per se is usually very mild, and the IOP hike is usually very high. That is usually what you find. Generally, you might not find KPs, but you might find 1 or 2 KPs if you observe very carefully. So the first thing is to make sure you are dealing with a Posner-Schlossman syndrome, which is essentially a clinical diagnosis, basically ruling out other causes. For example, acute angle closure glaucoma is an obvious thing that comes to your mind, but with an open angle. Even in this eye, from the clinical appearance of a relatively deep chamber, you can basically rule out an acute angle closure attack. But here the important point is generally that the inflammation is very low and the IOP is very high. And generally the treatment therefore should be a combination of anti-glaucoma medications, and you can give topical steroids, but it need not be very powerful steroids. Even a dose of 2 times a day or 3 times a day is more than enough to control the inflammation. And the response is also very quick. Once you start the patient on a very small, even lotipretinol twice a day, and put him on an anti-glaucoma medication, the pressure comes down very rapidly. The problem is if it recurs. Once you give that course of treatment and the patient becomes immediately good, and then you slowly taper off and take off the medications, the patient is well and fine, and then after 2 months the patient presents with an attack again. So the question of giving antivirals happens when you have repeated attacks. A patient has repeated attacks. In generally, unless the frequency is very high, look, I researched the literature quite a bit on this. There is no consensus on giving oral antivirals for this condition. But if you have multiple repeated attacks, you can consider a course of oral antivirals. And then the question of how long you want to give oral antivirals, the discussion, right, which started from the very beginning, from epithelial keratitis to all this viral uveitis, that thing comes in. But in normal circumstances, after a lot of trial and error based on my experience, what I do nowadays is that the patients, after 2 or 3 attacks, are very clear what happens. Right from the moment the attack starts, they start to understand what is happening. They have this slight blurring of vision. Sometimes they see the colored halos. They very clearly know what is happening. In such cases, educating them very carefully about the potential issues, I usually ask them to always keep a low potency steroid and an anti-glaucoma medication like timolol, brimonidine or timolol dorzolamide combination with them. And whenever the symptoms start, immediately put a drop each and the next day come and show us. Because the problem generally happens is that with repeated attacks, the single episode damages starts accumulating over a period of time. So in repeated attacks, I might consider giving them oral antivirals, but it would be pretty much as a last resort. I hope others can.
Ma'am, would you like to add something to this? No, this patient didn't have any history of trauma. She just told the similar thing happened 2-3 months back. That time also no other history. She's just a housewife. She doesn't even go out much. So
in most of the cases, we don't usually get a history of trauma straight. Then we have to ask repeatedly. There can be a long term back. There must be a history of trauma. You have to do all investigations, and then it can be angle recession glaucoma or steroid induced. You have to rule out
this
that.
patient's gonioscopy was seen. It was open, but just that it was hazy. That's why I didn't add a picture.
Okay. The eye doesn't look like a typical post-nurse Schlossman. That is.
Yeah.
Gonioscopy can be done in another 2 or 3 days very clearly, because if it is post-nurse Schlossman, in 3 days the pressure will become normal, the cornea will clear up. It's very easy to do.
Yes, sir. Moving on to a second case, this is also an uveitic glaucoma. So this is a 32-year-old male with complaints of blurring of vision, photophobia since 3 days this time. He had had similar episodes on and off since 5 years. He was already on anti-glaucoma medications. His right eye at this time comes with circumcorneal congestion, keratic precipitates and cells, and an IOP more than 25 millimeter mercury in spite of being on maximum medical therapy. The other eye was normal. He was elaborately evaluated. His aqueous PCR for varicella, herpes simplex and CMV came out negative. Manto, VDRL, HIV and TPHA was also negative. The optic nerve head was grossly normal, both eyes. OCT was normal. So he's basically secondary ocular hypertension due to chronic uveitis. This patient of ours, he was treated with oral valcyclovir for 1000 milligram, oral Visalon, topical steroids and topical anti-glaucoma medications. As in May 2025, during his last visit, he is maintaining a 6/6 vision in OU on oral steroids, maintaining on once daily dosage of topical prednisolone and valcyclovir 500 milligram once a day on alternate days for another 3 months, and IOP has been in low teens. So when to do an aqueous PCR? This has been widely studied. So in the study of diagnostic utility of anterior chamber paracentesis, it has been suggested that we do an aqueous PCR in cases of uveitis of atypical clinical appearance, recurrent severe uveitis of uncertain etiology, and therapy refractory cases. However, the overall PCR positivity was found to be less than 10% in all the viruses. And therapy was changed because of the PCR results only in around 37% of the eyes. So now it would be interesting to know from our experts whether you would want to do an aqueous PCR, and if it turns negative, would you still give oral antivirals if the patient has been a patient of chronic uveitis on and off for a similar scenario for say 5 years? Roshni ma'am, what would you want to add?
I personally does not have much experience in this because we have a UVI clinic and we refer this to the UVI clinic. And I think Kiran sir, any?
The evaluation of uveitis, I basically leave it to my retina colleagues.
Yeah,
I
we
don't
anyway had a
usually
detailed class by ma'am also.
intervene on that particular regard. But if the whole purpose of positivity of these is very small, like 7-8%, and in spite of that, if the patient is having recurrent uveitis, if you are going to prescribe valacyclovir, I wonder why you want to do a PCR in any way.
I guess that's what even we did not do PCR in this case.
No, but why would you give valacyclovir in this patient? If you have a chronic uveitis that has been there for about 5 years,
yes,
and you don't have any, except the rise in IOP, you don't have anything else suggestive of a viral etiology.
Yes,
have you investigated for other etiologies?
Everything else was investigated, ma'am.
Yeah. So when you have a secondary ocular hypertension due to a chronic uveitis, it is highly unlikely to be a viral etiology, because viral etiology usually they present with what we suggested in the first case, recurrent acute attacks of rise in IOP in a short period of time, let's say 1 year or so. If you have a chronic uveitis, then what is the cause for your rise in IOP is what we should be looking at. So is it an angle closure? Is it like a synechial angle closure?
No, this patient had open angles, except he had intermittent peripheral anterior synechiae, which could be explained by the repeated attacks of uveitis. But the angles were deep.
No, the thing is, this patient is presenting with repeated acute attacks, if I am not mistaken.
Yes,
is that
yes.
right? He's presenting with repeated acute attacks. That
Repeated,
is why they...
acute attacks. So you have two ways in which rise in IOP can occur. One is the cells going and clogging the trabecular measure.
Yes,
the other is a steroid-induced rise in the intraocular pressure.
Yes.
So both these need to be, you have to figure out which is which and then go ahead accordingly.
But the patient had features of active uveitis also, ma'am, at these presentations.
So active uveitis with treatment of active uveitis with steroids. And but then why is he on AGMs already? Is he a open angle glaucoma?
He became a uveitic glaucoma because of repeated attacks. Every time he has been...
The thing is, when somebody... No, actually, whenever you have an active inflammation present, your primary aim at that point is to treat the active inflammation. So obviously steroids have to be given at that point of time. But then once the inflammation comes under control, and then if the pressure is still remaining high, that is when you think about any chronic changes in the angle, or you are thinking about steroid-induced glaucoma.
Yes.
So when you see a patient is presenting with KPs and 2+ cells and all, here we are trying to treat the inflammation first. Give steroids, within 2 weeks the inflammation should come under control. And if the pressure is still remaining high, that is when we look at mechanisms of glaucoma at this point of time. Whether repeated attacks have already scarred the angles, angle closure at peripheral anterior synechiae, few peripheral anterior synechiae can actually cause secondary ocular hypertension, plus the possibility of steroid-induced glaucoma. And at that point of time, you start maybe shifting the patient to a low potency steroid and then tapering it off. And if the patient has been tapered off steroids and the eye is quiet and still the pressure is high, now we are looking at a secondary angle, secondary glaucoma, whether it is due to a change in the angle, which you can understand by gonioscopy, or whether it is a secondary open angle glaucoma. At that point of time, treatment is strictly from the glaucoma side. The only question here is that the patient was already on anti-glaucoma medications earlier and the IOP was not under control. Maybe the IOP got under control only because of the acute attack itself. And in the other phases, with the routine medications, the pressures might have been under control.
He was being maintained.
The challenge happens usually when the eye is quiet and the pressures are high in spite of medications. Then the question one is, do we add prostaglandins? Because generally these would not be your first line drugs. And the literature is pretty strong on the fact that in cases which are not responsive to other cases, as long as the eye remains quiet, you can give prostaglandins. The literature is reasonably strong on that aspect as far as glaucoma is concerned, though the initial traditional teaching was that, in uveitic glaucoma, prostaglandins are contraindicated. That is not the case. Now we have a lot of systemic reviews which has covered something close to 30,000 patients, and prostaglandins do not usually cause an exacerbation of uveitis in most cases. There has been observational case reports where, yes, there is a strong evidence. For example, I distinctly remember one case report where there was a bilateral granulomatous uveitis after the patient was started on travoprost, and when the drug was withdrawn, the uveitis goes away without any addition of steroids. And when you re-challenge one eye with travoprost, then the granulomatous uveitis recurs again. That is a very, there is something called an algorithm, Nanjaro algorithm it's called, that's very strongly suggestive of a causality there. But in most cases, when you have other drugs not responding, when they're not able to reduce the IOP, please add prostaglandins and C. That actually is very helpful because it is the strongest hypotensive agent. That is the one question. And the other question is, even if you add prostaglandins and the IOP doesn't get controlled, then what do you do? What kind of surgical procedure would you then see? That is a different discussion. We will go into.
I would say that for this patient, there is no indication for a PCR, but in your first case, I would differ from the glaucoma specialist, because in our uveitis, generally, if you have a high suspicion of viral uveitis that is causing the spike in IOP in between more than 3 episodes in 1 year, you can do a PCR and look for the viral.
That particular patient came with second episode.
No, and that second episode maybe it's still not warranted. But there is no Posner-Schlossman anymore, is the general consensus in the uveitis world.
Yeah, let us call it glaucomatocyclitic crisis. Okay, let us call that. But obviously you have to think about the scientists. We can never forget these people. I think they came out with it in 1948, long before we were born, right? So as a mark of respect, I will still call this Posner-Schlossman. I don't like forgetting scientists. I always make it a point never to call Anderson criteria, but Hodap-Anderson-Parish criteria, because I don't want to forget the other scientists. So, okay. In these cases of these glaucomatocyclitic crisis, my question is why don't we empirically, if the episodes are too much, why don't we empirically start them, or should we do a PCR? Because the thing is, even if the PCR results are negative, in such cases with the repeated episodes, I am inclined to start them on an antiviral. That is the only thing.
Also, it's more or less the same, isn't it? So if you really analyze the second case.
No, the difference is the level of inflammation. Yeah, if you have a lot of cells and flare and KPs, we generally don't consider it in the classical picture of glaucomatocyclitic crisis.
And it becomes a viral anterior uveitis with secondary glaucoma.
Exactly, but in the so-called classical description of Posner-Schlossman, which we see quite regularly in generally young 20 to 30-year-old patients, the inflammation in the chamber is actually very low. And this is sometimes what happens. Like in the periphery, somebody might see the pressure is very high, and the patient is started on anti-glaucoma medications, but not on steroids, because the chamber looks very quiet. There, if you look carefully, you will find one, keratic precipitate in one, inferior area. That's it. The chamber cells are probably hardly any, occasional cells, an occasional KP. And what happens is that you miss the fact that there is a very low-grade uveitis, and you start only on anti-glaucoma medications. Usually the pressure does not come under control. You put him on loteprednol twice daily. In 3 days, the IOP becomes absolutely great.
And that's simply because of the trabeculitis element and not the actual uveitis.
So I think we'll have to conclude saying that I think we should need not do a PCR. But in repeated attacks, when you have a strong suspicion, is it okay to just start an antiviral along with yours?
Yeah.
In actual practice, that is what we end up doing. You have somebody with repeated attacks, but in most cases, they don't end up actually having glaucoma, in the sense there is a nerve damage per se. But yes, I do have a couple of patients who have had this repeated attacks for many years, has sustained a damage to one area of the disc. But in between, there is no point in giving them anti-glaucoma medications. That is the thing. One simple thing you can do when you have such repeated attacks is what I do: give them these 2 drugs, keep it with them. The only problem is there is always a chance of misuse. That is something that you have to educate them.
It is a Singapore group that has come out with a lot of evidence of this CMV being the cause. And they do serial PCRs. They actually do PCR negativity and then stop the treatment. So when to stop the antiviral, they actually you do it, and then once the PCR becomes negative, then you can stop the antiviral, which is not practical for us in India.
One thing is, if you are starting an antiviral, it's probably better to start valacyclovir if you are doing it empirically, because the CMV coverage would be better.
I actually had another 6 cases to go, but since we are running short of time, thank you so much. I am closing my section. Thank you all. Next is going to be retina grand rounds.
Thanks to our glaucoma panel for such a dynamic discussion. Now I request Dr. Amita Varghese to hand over a token of appreciation to our panelist and moderator. Welcome Dr. Kiran Gopalakrishnan. Dr. Sarita VK. Dr. Dhanya CA. Dr. Roshni. Dr. Anne-Marie Matthews. Thank you. I request all of you to assemble for a group photo.
Thank you, madams, and thank you, sir. We are very exalted to see the active participation in our Nethram quiz. This year, we have a record participation of 27 teams attending the prelims. So, we would like to give a token of appreciation to all our quiz participants. All the participants, please kindly come forward to receive a small token of appreciation and to have a photo session. I request all the PGs, please come forward.
It's my pleasure to announce the winners of the preliminary round who are going to participate in the finals. So since you all got your appreciation, I guess I don't have to particularly say that you're all appreciated for participating. But
The first team that has qualified, this is from lowest to the highest, is Dr. Shilpa M. and Dr. Don Philip from Pushpagiri Medical College. The next is from Medical College Alappuzha, Dr. Afia and Dr. Shruti K. Thomas. Next team is from GMC Kottayam, Dr. Jalisa and Dr. Parvati. Then from RIO Trivandrum, Dr. Gopika Gopakumar and Dr. Anu Philip. And the team that has scored the highest is Chaitanya Eye Hospital and Research Institute Trivandrum, Dr. Aparna and Dr. Safina Hamsa. We also appreciate the other team from Chaitanya Trivandrum, Dr. Apsara and Dr. Josmi, who also qualified, but because one team from their institute had already got a higher score, they could not make it to the final. So these are our 5 finalists. All of you be ready for the quizzing.
Now it's time for the retina grand rounds. This session will explore the evolving landscape of retinal disease management, examining a broad spectrum of intriguing retinal pathologies, each offering unique diagnostic and therapeutic challenges. We have the moderator, Dr. Meru Agustin, Consultant Vitreoretina and Ocular Oncology, Chaitanya Eye Hospital and Research Institute, Thiruvalla. Our distinguished panelists include Dr. Rahul R. Menon, Consultant Vitreoretina, Chaitanya Eye Hospital and Research Institute, Palarivattam. Dr. Manjit P.S., Associate Professor and Vitreoretinal Surgeon, Government Medical College, Kottayam. Dr. Biju John, Professor and HOD, Government Medical College, Kollam. Dr. Indu VP, Vitreoretinal Surgeon, Chaitanya Eye Hospital, Kottayam. I request all the panelists to come forward and get seated. Over to you, Dr. Meru.
Good afternoon, everyone. Welcome to Retina Grand Rounds. In this session, we'll be going through, or rather sprinting through, a few retina interesting cases. Here, we promise not to bore you with a lot of medical jargon, no confusing acronyms like drill, drama, and Eiffel. Instead, we will concentrate more on a few common case scenarios, some in an unusual setting as well. So we are all familiar with the enigma that is diabetic retinopathy. We expect a fundus picture like this, and on OCT we see intraretinal fluid like this, a subretinal fluid, hard exudates, or neovascular form that is seen in the preretinal space. So here is a gentleman, 45-year-old male, who came for a routine checkup, no visual complaints. He was just referred by his treating physician for screening for diabetic retinopathy. He gave history of uncontrolled diabetes mellitus since 10 years, and he was also on medication for dyslipidemia. The best corrected visual acuity in both eyes was 6.6 and 6. The anterior segment examination was otherwise unremarkable. Here's the fundus picture. Both of the eyes showed features of moderate NPDR. And look at this macula of the right eye. Here we see clinically significant macular edema. Here we see a lot of hard exudates and microaneurysms. And we see a hard exudate clump right next to the fovea. Here is the OCT running through the fovea of the right eye, showing intraretinal fluid, a neurosensory detachment or a subretinal fluid, hard exudate clumps. And in the other eye, the fovea was found to be dry. So here we have an asymptomatic patient with 6.6 vision with a fundus picture like this and an OCT showing significant macular edema. I would like to give the discussion to the panel as to how we will manage this patient. Would you choose to observe at the first visit or treat with an injection or a focal laser? Rahul, sir.
Yeah. So considering that the patient is asymptomatic, the first thing because he doesn't have any complaint, one. Second thing, he has a submacular detachment and his sugars are not under control. So probably if you look at the DRCR protocol we study, where they mentioned like even, diabetic macular edema compared to CNVM is a much more forgiving disease. There's no harm in observing such patient. So I would probably just send him back to his physician to control his blood sugars and observe. Probably if I feel that the patient is very anxious or something like that, since there's asymptomatic, nothing, I might start him on a topical NSAID and just probably review him in a couple of months' time. But I will not inject in the first go here.
Okay. If the patient comes back with a similar vision of maybe 6-9 parts or something, but the edema has worsened, what would be your
in the following setup, in the review, if the same is worsening, then probably I will consider injection, but not before that. And the thing is, I always feel in DME, especially, give the water to the thirsty. The patient is asymptomatic, there's no point of injecting him. And since his blood sugars are not under control, and if you look, there is an IRF, intraretinal fluid there, but there's a submacular detachment. This actually indicates that the systemic status is not very well. So I would probably refer him to make sure that his sugars are under control. Once the sugars are under control, that should probably resolve on its own.
Right, thank you. Manjit sir, we noted a very significant hard exudate clump very close to the fovea. How will we counsel the patient that down the lane it can migrate onto the fovea and can cause a sudden defective vision for him?
Even if his dyslipidemic status is still not under his own anti-hyperlipidemic agents, but even if it is not under control, I would suggest the physician to add another drug before considering an injection. Also, in this case, suppose the patient may had many times the vision drop occurs after a function loss occurs only after some weeks of edema. So if you wait for 1 month, this patient may have a drop in vision. Yes. So you can repeat the OCT maybe after 1 month or 1.5 months. And if the dyslipidemia is not under control, I would ask the physician to add another drug, increase the dose of the drug, or add a fibrate if he is on atorvastatin. And even if he is not on any dyslipidemic agents, I myself would add a low dose atorvastatin if they have a lot of hard exudates close to fovea.
Okay. If the patient comes back symptomatic to you and you've decided on an injection, would you prefer an anti-VEGF or a steroid in this patient?
I would prefer anti-VEGF. If there are a lot of hard exudates, there are some studies that steroids may be as good or even better than anti-VEGF agents. But if his dyslipidemic status is all under control, I would still suggest anti-VEGF as first choice.
Thank you, sir. We'll swiftly move on to the next case. Here is a 55-year-old lady who came with defective vision in the left eye since 6 weeks. She is a non-diabetic and hypertensive on treatment. The best corrected visual acuity in the right eye was 6, and 6, and in the left eye was 6, 12, and 8. Anterior segment was within normal limits in both eyes. The fundus examination of the right eye shows features of proliferative diabetic retinopathy. We can see a lot of flat fibrous proliferations at the disc and along the arcades. Here is the line scan through the fovea showing a normal foveal contour, and we can see a neovascular tuft temporally in the preretinal space. Here is the fundus picture of the left eye showing a fibrovascular proliferations arising from the disc, which is going over to the fovea, and a very evident traction on the fovea and maybe an early lamellar hole forming there. Now this is the OCT line scan passing through the fovea of the left eye. Here we see intraretinal fluid, there is a neurosensory detachment and an active traction right at the fovea. So here is a patient with PDR and a vision of 6/12 and an active traction at the fovea along with intraretinal fluid and subretinal fluid. Biju sir, how will you manage this patient?
I think once you identify an active traction and the traction is involving the fovea, then I think the management is mostly surgical. So we'll have to go in, probably do a vitrectomy and do the membrane peeling, release the traction, then do the endolaser, so as take care of the proliferation.
Okay. So here we have a lot of fibrovascular proliferations, quite vascular. So would you consider injecting an anti-VEGF prior to the vitrectomy?
Yeah, that I will do. But thing is that you are injecting that for facilitating your surgery only. So you should make sure that once you inject, then you take up the patient for the surgery within the next few days.
Are there any specific OCT signs that you look into to help you differentiate between a tractional edema or an exudative fluid in DME?
Once the traction is there, then you have to deal with the traction. I mean, you cannot say that there will be an exudation also. I mean, there will be fluid also there. But when you have an active traction, then I think we'll have to deal with the traction, and whatever is remaining, maybe you can manage that. So if you suspect, of course, that exudation also, after the surgery, maybe you can leave with one injection also.
Okay. Indu ma'am, any difference of opinion?
The only thing is, if you consider the vision is 612. He has got a pretty good vision. And of course, there is definitely the distraction. Maybe I may not rush into surgery. Maybe I might observe the patient for a few weeks or see how the disease is progressing. And during each visit, I might counsel the patient that if you have a drop in vision, definitely we will require a surgery. Because these kind of patients, we cannot guarantee that even after relief the traction, his vision is going to improve. So maybe for a practical point of view, sometimes I might wait and observe the patient for some time before jumping into surgery. It's a personal opinion, of course.
Thank you. So we had, in fact, injected the patient. This is 1 month post injection. The PVD, the traction had actually relieved on its own, which recurred 4 months later. This is after the second dose and third dose. 4 hours back to normal. So over to the third case, a 62-year-old gentleman who came with defective vision and floaters in the right eye since 2 weeks. He's a non-diabetic and hypertensive patient on treatment. He had history of angioplasty done 5 months prior to the visit. The best corrected visual acuity in the right eye was 660 in 36 and in the left eye 69 and 6. Both eyes showed features of immature cataract in both in the anterior segment examination. Now the fundus examination revealed vitreous hemorrhage, but as we can see in the picture, there is good view of the macula, the disc, and the peripheral retina. We could get an OCT scan which showed no growth for macular edema. The fundus examination of the left eye showed features of proliferative diabetic retinopathy, and the fovea was found to be dry on OCT. So here we have a PDR patient with a vision of 660, complaints only since 2 weeks. Vitreous hemorrhage, but view of retina is there. There's no macular edema. What would be the choice of treatment over to the panel? Rahul sir. Would you inject, start PRP, or consider vitreoretinal surgery?
If the retina is visible, I'm definitely starting PRP. See, there's a wrong notion among people like, giving an anti-VEGF will reduce the vitreous hemorrhage. Right. See, we have to realize that when you give an anti-VEGF, the primary process is it kind of regresses the neovascularization. It does not help in resolving the vitreous hemorrhage. Right. So it is a more of a secondary phenomenon because of what happens when you give an anti-VEGF because of syneresis. Sometimes you might see a resolution of the vitreous hemorrhage, but that is not the primary mechanism. So for that matter, even if you give BSS, it might do the same thing. So if the retina is visible, I will definitely do only a PRP. My indication for giving an anti-VEGF in a case of PDR, either it should be a preoperative tool, or if I'm seeing a lot of neovascular NVD, a large amount of NVD, chunk of NVD, or if there's a lot of NV, and I know that when I do a PRP, I might not be able to do a good justice. Only then I might probably prefer, or macular edema, before starting the PRP. Otherwise, I prefer to avoid anti-VEGF in such cases.
So in this patient, the patient is a non-cardiac patient. So even if you are considering a vitreoretinal surgery or an injection, would you advise stopping antiplatelets for this patient, Manjit sir?
We always get the opinion of the cardiologist before stopping antiplatelets. Sometimes if they are on dual antiplatelets, they tell you can stop one. But if it's a recent angioplasty, they usually advise to continue antiplatelets.
How will you counsel the patient regarding the chances of recurrent bleed and worsening bleed now that we are not stopping? This patient had angioplasty done only 5 months back. So how would you counsel the patient about chances of recurrent bleed or worsening bleed?
Without stopping the antiplatelets, there is more chance of bleed during, you can have a subsilicon hemorrhage post-op. So all these things should be counseled during the time of surgery, and always do maximum PRP so that you can reduce the bleeding during surgery. There will be some amount of regression which can help the surgery. And regarding anti-VEGF, and that it will not actually reduce vitreous hemorrhage, but it will definitely help to reduce ooze from the new vessels which are already there. So we have seen that the patients we have planning to take up for surgery, after giving an anti-VEGF. Sometimes you see resolution of VH after anti-VEGF. That's because further ooze is reduced, not actually faster resolution of VH, but further ooze will be reduced for around 1 month, and there may be a faster resolution of VH due to reduced ooze.
If it is a vitreous hemorrhage with a very poor view of retina, it is surgically indicated, then your mind is in that line of thought. But previously the consensus was you would wait for maybe 1 or 2 months before advising vitreoretinal surgery. In your practice, how early do you advise vitrectomy for a patient with significant vitreous hemorrhage?
Due to actual long waiting list, we don't. We have to wait up to three months before taking up. Practically, we can wait for 1 month and take up the patient for surgery.
Okay. Biju sir, any difference of opinion?
Yeah, I mean, if it's a treatment naive, that means that no laser has been done in the patient, and the patient comes with a VH, which is preventing you from seeing the fundus. Maybe you'll wait for, you'll be following up the patient. You call him after 2 weeks, so you'll know that whether the hemorrhage is going to subside or not. Some of these patients, you can see that after 2 weeks the hemorrhage subsides, and at least the one half, the superior half, you may be able to laser. Such patients you will be waiting a little more. But if that doesn't happen, then by the end of 1 month we take up for surgery.
So those patients who do improve with head and elevation and whatever. So if the vision improves and there is dense hemorrhage inferiorly, you've finished off all the superior PRP, but the proliferations are not getting avascular or not getting controlled as we are expecting it to. So how would you proceed then, sir? Would you still wait or go ahead with vitrectomy?
In that case, I mean, if half is cleared, I mean, there are all variations like that, practically, because I also have this problem with the waiting list like mentioned. So in such case, suppose the upper half you can see, and the rest of the area you are sure that there are no fibers tissue or anything. In such case, I try an anti-VEGF also.
Okay. Thank you, sir. So we'll quickly go through one last case. So the puzzle of CSCR, central serous chorioretinopathy. This is a typical fundus picture that we see, blister of SRF. Here we see pachychoroid or thickened choroid with dilated hollow vessels and attenuated choriocapillaris. We see a subretinal fluid with thickened photoreceptors and serous pigmental epithelial detachments like this. So here we have a gentleman, 45 years, who came with complaints of defective vision in the right eye since 1 month, non-diabetic, hypertensive and dyslipidemia on treatment. The vision in the right eye was 6/12 and 10, and in the left eye was 6/6 and 6, and anterior segment examination was within normal limits. Right eye showed features of moderate NPDR with dull foveal reflex. Left eye, again, moderate NPDR features with fovea appearing dry. We got an autofluorescence done, and we saw a few areas temporally which showed hyper-autofluorescence. The OCT line scan through the right eye showed a shallow subretinal fluid with very prominent pachychoroid in the right eye. And in the left eye, fovea was noted to be dry. However, there was a pachychoroid. So at this point of time, Indu ma'am, what is your thought process? What would you do next?
Go for an angio.
Okay, that's exactly what we did as well. So we did an FFA and ICGA. The FFA showed multiple leaking microaneurysms, but at the foveal area there was not much of leak. ICGA, again, we showed a lot of pachy vessels, but not really hotspot or network showing at the fovea. The left eye again showed features of moderate NPDR, multiple leaking microaneurysms, nothing more than that, and pachy vessels in the ICGA was quite prominent.
These are all very tricky situations.
Yeah. So this is a case, patient is symptomatic, there is a subretinal fluid. Now, would you inject? Would you advise observation?
See, the patient already has fluid there, but you are not definitely seeing any leak, a CSR leak or anything. Correct. But of course, you're seeing a lot of leaking microaneurysms. So probably then we'll have to think about the leaky microaneurysms could be the cause of subretinal fluid. You can definitely inject because there's no point of giving laser because you cannot give a laser, you're not seeing a leak there.
Right.
So then the only option that we have left is anti-VEGF. We can try an anti-VEGF.
Rahul sir, any difference of opinion?
I would prefer to take a conservative approach here. I would probably wait. Might give something, maybe start him on a maybe Dozox, because I'm suspecting more of a CSR kind of picture here. Don't see a leak because not always do we get a focal leak sometimes. Could I just see that ICG picture in the right eye? The early picture? I don't see any staining either, but I would prefer to wait. Like I said, DME, if it's you see, the two possible things is either it's a CSR or it's a DME. Both of them, since it is a 1 month symptom history, I would probably take a conservative approach, maybe wait for 1 month and then see how to go about, rather than going and directly injecting.
We had observed this patient for about 1 month, and it actually resolved on its own with topical medications, which are more indicated towards CSR.
So if you see SRF without neurosensory retina thickening, always look for uncontrolled hypertension or nephropathy. Usually they will present as bilateral subretinal fluid without much neurosensory retina thickening.
Yes, sir. Thank you, sir. This could be a mixture of both, sir. Like we gave it an trial of observation. We wanted to know if it is worsening or not. Could be just a CSR kind of a picture.
So the OCT, if you show the OCT right eye, there is a area of hypertransmission. The one more picture you had shown. The next one. This is the left eye. Right eye. It's one more.
That's just the one line scan, sir.
Okay, fine. I thought one of the pictures showed an hypertransmission area in the center. The first, was it before that? I'm not sure.
Yeah,
maybe you could have speed or something like that.
See, I've had a patient like this. I didn't go for observation. I gave anti-VEGF, and the patient responded. So it will respond to both, either observation or even if you give anti-VEGF and CSR with the DME, it will respond.
I want to add to the confusion. Recently we see many fluid overload patients coming with similar picture. Most of them are like diabetics like this, but may have renal problems or may have congestive cardiac failure. Conditions causing fluid overload, and the physicians there even make a diagnosis of fluid overload in the body and presenting with CSR like picture with the diabetic retinopathy. So I think like Natasha said, egg or chicken, which came first? We have multiple etiologies causing this particular problem. And also I'm sure all of you will agree that we keep seeing PEDs along with diabetic retinopathies, don't we? Many times we see that. We wonder why that's happening. Probably it is something else. We will have to still search on, find an answer completely. And yes, sometimes watchful expectancy is the best approach. And as doctor said, Indu said, anti-VEGF may have its role. So still we're not sure where have we reached as far as comorbid conditions are concerned.
The only thing is that it will take home message. See, you have suspected CSR and you look for CSR. You look at the FFA, nothing is there. Then what you have is diabetic retinopathy. You have got the microaneurysm, you have got subretinal fluid. Then isn't it better to actually take it as diabetic retinopathy, take it as central volume edema and inject?
Okay, sir. We had told the patient about the chances of if it is worsening, then probably we'll inject again. But we thought we'll get
yeah, I think you are getting lucky. Even in the first patient where you inject the anti-VEGF, you got a PVD, which is also, I mean, ideally should not be done actually, when you have so much fibrous tissue there.
Okay. Thank you everyone, we'll call it a day.
Thank you, ma'am. Now I request Dr. Anita John to hand over token of appreciation to the moderator and panelist. I welcome Dr. Biju John. Dr. Manjit PS. Dr. Meru Agustin. I request moderator and all panelists to engage in a photo session with ma'am. Thank you to all our panelists, moderators, and attendees for your keen engagement. These discussions are a testament to the power of collaborative learning in advancing ophthalmic care.
Now, get ready for an engaging and intellectually stimulating experience. It's time to witness our residents showcase their knowledge, skill, and quick thinking in a spirited battle of wits. We are delighted to present one of the most exciting segments of our CAB, PG Quiz, Igniting the Fire. It now gives me immense pleasure to introduce the person who will be steering us through this thrilling journey of knowledge and competition. A Kerala University MBBS gold medalist and rank holder, a DNB gold medalist, and an accomplished academician with over 25 publications in reputed national and international peer-reviewed journals. Please join me in welcoming Dr. Natasha Radhakrishnan, Senior Retina Consultant and Head of Pediatric Retina and Uvea at Chaithanya Hospitals, Ernakulam, our esteemed quizmaster for the resident quiz competition. She also serves as a retina consultant at Lizzie Hospital and Rajagiri Hospital and is a visiting consultant at multiple hospitals across Kerala. Actively involved in both undergraduate and postgraduate teaching, she is also shaping the next generation of specialists by offering short-term fellowships in uvea and retina. Ma'am, we are honored to have you with us. The stage is all yours.
Thank you so much. Thank you to Pathanamthitta Ophthalmic Society for having me here once more. I think the prizes on the stage are threatening to overshadow both the participants and the quiz. So let us familiarize ourselves with the prizes first. So we have an exciting range of prizes here for the winners. The first prize is iPads. 2 iPads for the participants. The second prize are 2 projectors, and the third prize are earbuds. So a big hand to Pathanamthitta Ophthalmic Society. I think it's a good time to do post-graduation now. You get better prizes than we did. So this is our postgraduate quiz. It's a little mix of both easy and difficult. As you know, some amount of luck will play a part. And as in all quizzes, the quizmaster's decision is final. May I invite the teams to come forward and take the lot. The first person who reaches will get the first chance. No, they know who they are. They can come. I just wanted a reference. So, first team who comes forward can get the first chance to select your place where you're going to sit. So, we have 5 rounds. 4 of which are straightforward. 2 will go from A to E, 2 rounds will go from E to A.
Straightforward rounds. Direct question will contain 10 marks and pass will give you 5 marks. Okay? And the 5th round is a rapid fire round. There is no passing, and you will get your set of questions, you will get your answers, how much you get right. We can keep a timer for that round. Other rounds also, 1 question, I think you can give them 20 seconds and 10 seconds for a pass. And for the rapid fire, we'll give them around 1 minute. The 4th round is it has a small twist, so that I will explain when the rounds come. Otherwise, it's fairly straightforward. Are the teams ready? Are the scorekeepers ready? Okay, okay. Is the audience ready? Yes. A lot of questions for you as well. So, and a lot of prizes, I hope. Are there audience prizes? Chocolates are ready? Yes. All mics checked and working? All right, let's go. So we'll start with basics. Team A, direct question. The following are derived from the surface ectoderm except.
Option C, trabecular meshwork.
Option C, trabecular meshwork. Does everybody agree? Yes, that's the right answer. Trabecular meshwork, that is derived from the neural crest cells and not from the surface ectoderm. So, direct question, direct answer, 10 marks. Team B, are you ready for your basic question? Local anesthetics act by increase in membrane permeability to which ion? Sodium, calcium, potassium, bicarbonate.
Sodium ions.
Oh, these people are really, really smart. So let's go. It's good to score in the first round, no? So the pressure is on team C. 10 marks, direct question. -5 diopter sphere plus 4 diopter cylinder 180. What is the final diagnosis? Mixed astigmatism, compound myopia with the rule astigmatism, compound hyperopia with the rule astigmatism, compound myopia against the rule astigmatism.
Mixed astigmatism.
I will pass that to team D.
Option D, compound myopia against the rule astigmatism.
Can you explain your answer? Was it guesswork because they eliminated the mixed astigmatism?
It's having both plus sphere and minus sphere and plus in cylinder with minus in 90 or plus in 180, which gives the against the rule astigmatism.
Yeah, when you transpose, both of it is myopic. It is not mixed astigmatism. So it is correct. So they get 5 marks and they also get the next direct question, team D. A corneal ulcer that shows brown-black pigmentation on slit lamp examination, is it aspergillus, demitaceous, fusarium or candida?
Option B, demitaceous.
That is right. So they get the direct question also. Demitaceous fungi, they contain melanin, so they could give a darker color to the corneal ulcers. Are you ready? The last people. Which of the following structures passes outside the annulus of Zinn through the superior orbital fissure? Is it the nasociliary, the abducens, superior division of oculomotor, or the lacrimal?
Option D, lacrimal nerve.
Excellent. Why is that? How is it so easy to get it?
LFT.
LFT passes outside. Perfect answer. So that is the first round over. Let's give them a big hand. That was a high scoring round, I think. Except a single team, all of them have scored their direct questions. Next round. Audience. Light follows the path of minimum optical path length. What is that principle called? You get the tough question. Because you have so many brains. Anybody? You know. Excellent. Tell me.
Fermat principle.
Excellent. Fermat principle. I think she needs a chocolate. You can give her. No marks for that, but she gets a chocolate. Fermat principle is a simple principle that light follows the shortest straight path. Next round, team A again. So it's all up front, cornea to lens in a clinical hunt, which means it is anterior segment. Okay. Which of the following statements is true regarding this device? It's a non-valve drainage implant in refractory glaucoma. It's a plate and tube with flow restricting valve mechanism. It is implanted in the AC without conjunctival dissection. Implant is contraindicated in neovascular glaucoma.
Option B. It consists of a plate and a tube with a flow restricted valve mechanism.
Is she right? Yes, I think majority is with you. That is right. It is a plate and a tube, and it is one of the indications in neovascular glaucoma. So it is not a contraindication. Team B. During a slit lamp examination of 4 different patients, you observe the following lines. Which of these lines require therapeutic intervention as early as possible? Or urgent therapeutic intervention?
Coda dust line D.
Can you explain why?
Endothelial rejection post-keratoplasty.
Do you know the other lines, or was it just a guess because you know what chordodose is?
Stoker's line in pterygium.
Okay. Hudson-Starlin? Old age. Warings? Nobody knows what Warings is. I also don't know actually. I think there's just tumor put there. No, it's there. Orthokeratology lens users or early keratoconus. Yeah, chordodose line definitely requires intervention. So direct question they have also got. 3, steroid that is least likely to cause this type of cataract is loteprednol, prednisolone, dexamethasone, triamcinolone.
Loteprednol.
Okay. What kind of cataract is that?
Posterior subcapsular cataract.
And why do you say it is loteprednol?
Least potent.
Very good. So it is the least potent steroid, and it is the least likely to produce the subcapsular cataract. Your direct question to team D, Schneider's dystrophy involves which layer? Subepithelial, epithelial, endothelial, stromal.
D. Stromal.
Very clear of their basics. Very nice. Yes, it is the stromal dystrophy. And other stromal dystrophies? Macular, granular, and lattice. Okay. Your question, direct question. This slit lamp finding is most likely caused by which drug? Latanoprost, netarsudil, travoprost, brimonidine.
Option B, netarsudil.
What is it? Very good. Honeycomb reticular edema that is produced due to Rho kinase inhibitors. That was again a very high scoring round. I think everybody has got their direct questions. I think we'll go into a tiebreaker finally. So good. Can we have the scores? I think except one team, probably everybody has the same score. Let's go to the third round. So we'll start with you. Okay, team E. Audience question. Identify this implant and what are the advantages of this. If you can just identify, that itself will give you a prize. If you can give me some advantages, one more chocolate. I think the glaucoma surgeon should not answer. Hydrus. What does it do? Agreed. Minimally invasive glaucoma drainage device. What is its advantage? It avoids the sudden drop in IOP. Okay, so that is the hydrous implant. It increases the aqueous outflow, but there is no sudden decompression of the anterior chamber. Can you tell me your name? Roma. And you're from? A big hand to her for identifying the hydrous implant. We are going on to your round, Team E. Posterior segment mysteries we are going into. Uveitis in children is associated with which of the following conditions? Atopic eczema, cystic fibrosis, celiac disease, Crohn's disease. Time up. You want to attempt?
B, cystic fibrosis.
I will pass. Excellent. Crohn's disease is the answer. The other three do not have any uveitic implications. So Crohn's disease is one of the inflammatory bowel diseases that is associated with uveitis in children. Second question is to Team D. A 11-year-old female patient had complaints of headache of 6 months, and this is the fundus finding. Peripheral retina was normal. What is this condition? Is it a capillary hemangioma, cavernous hemangioma, racemose hemangioma, persistent fetal vasculature?
The racemose hemangioma.
Very good. Do you know what the condition is called?
Wyburn-Mason syndrome.
Excellent. Racemose hemangioma, Wyburn-Mason syndrome is the right answer. So they get full marks. It was their direct question. Team C, your turn. Which of the following intraocular tumors is the most radio-resistant? Choroidal metastatic carcinoma, retinoblastoma, large cell lymphoma, choroidal melanoma.
Option A, choroidal metastatic carcinoma.
I think I will pass that to Team B.
Choroidal melanoma.
Team B. Your turn is over. You cannot change your diagnosis.
Large cell lymphoma.
Large cell lymphoma. Okay, now the 5 marks is becoming 50% chance. Yes, Team A.
Choroidal melanoma.
Yes, very improbable as it seems, the answer is choroidal melanoma. They are radio-resistant tumors, unlike the others which actually, like retinoblastoma, can melt under radiotherapy. Although we treat choroidal melanoma with plaque brachytherapy, even then it is a radio-resistant tumor. So melanoma is the answer, but your teammate had already attempted. Next. I didn't, yeah, I think that's fine. Yeah, yeah. Same score. 5. 5 for a past question, yeah. Next is to Team B. Are you ready? Which of the following anti-VEGF is a short chain variable fragment? Aflibercept, bevacizumab, brolucizumab, ranibizumab. Short chain variable fragment.
C, brolucizumab.
Brolucizumab. Is she right? The retina people here? Yes? No? She is right. It is brolucizumab. It is a single chain variable fragment. Unlike the aflibercept, which is a fusion protein, ranibizumab is an antigen binding fragment, and bevacizumab is a full length antibody. And last question to Team A. Traumatic retinal detachment is most common in which quadrant? Supratemporal, supranasal, infratemporal, infranasal.
Supratemporal. Supratemporal A.
Supratemporal. I will pass it.
Option D, infranasal.
Option D, infranasal.
Option B, supranasal.
Option B, supranasal. Okay. I think all of you have got it wrong, but I don't think we can give it to you because then that is not actually an answer. It is infratemporal. Infratemporal is the most common place where you will get a dialysis, retinal dialysis following a trauma. I don't know why you all, I would have chosen supranasal because the trochlea is sitting there, it can impact on the thing, but it is infratemporal. So nobody gets marks in that, for that question. Audience, are you ready? What is this condition called? Autosomal dominant, yes? Somebody behind you. Very good. Blepharophimosis epicanthus inversus syndrome. Blepharophimosis syndrome, isn't it? BPES. Telecanthus, ptosis, epicanthus inversus, and blepharophimosis is the right answer. Do you know the gene? FOXL2. Okay, the teams know it. All right. Yeah, so this is the round with the difference. We will start again from you. Scorekeepers, please note. So this is a little tricky round. I will show one picture first. If you get the answer, I want the ophthalmic diagnosis. Okay. And if you get the ophthalmic diagnosis, I want both, all the comprehensive diagnosis. So if you, which means there will be a condition and there will be an ophthalmic association with it. So if you get the full thing right at the first picture itself, you will get 15 marks. If you get it at the second picture, you will get only 10 marks. And if you get it at the third picture, you will get only 5 marks. Okay? So that's how it is connected. It will not be passed if they don't answer. The audience gets the chance. And we will start with team E. Time also, you have just 5 seconds after the first picture is shown for you to get 5 seconds, 10 seconds. 10 seconds, sure. So we'll give them 10 seconds after the first picture is shown, and then 10 seconds for each picture, okay? It's not very straightforward. You have to think a little bit out of the box. Time up. Can I give you your second picture? Second picture. Audience in Kathiya.
Madam.
Yeah. You want to attempt or shall I give the third picture?
Choroidal melanoma.
Yes. What is shown in the first picture?
Hepatomegaly.
Okay. Why is there hepatomegaly?
Choroidal mets in the liver.
Yeah. And what happened to his eye?
Enucleated. So,
yeah. So enucleated eye with choroidal mets in the liver was the first clue. Second clue is? Histopathology showing the spindle cells of the melanoma. And the third picture was the actual melanoma itself. So they get 10 marks. Okay. I know, give them a big hand. That was well spotted. So next question to you. That is your first clue.
Congenital glaucoma.
That was good. What is that seen there?
Lochness monster phenomenon.
What is that?
Presence of loop of blood vessels in the angle.
Yeah, abnormal blood vessels peeping over the angle, which is called the Loch Ness phenomenon, commonly seen in congenital glaucoma. What do you think would have been the second clue? Excellent answer. Give them a big hand. What's that? Habstray and ophthalmos. Okay. So ophthalmos, congenital glaucoma, you would have got the marks. So 15 marks to team B. Team C, ready? You have to look at it all together. Time up. We'll give, this is there are a couple of pictures there to see, so maybe we can give them few seconds more. You want to attempt, or shall I move to the next picture? Now put it all together. Time up, I think. Time up. Third clue. I think the audience has all smiles. Attempt, or I will give it to the audience.
Ocular
Yes.
syphilis.
Sorry?
Ocular syphilis.
Ocular syphilis. No, it's not ocular syphilis. Yes, time up, and I will give it to the. No, that's not passed. Audience, what is the answer? Wilson's disease. So here you have all the organs that are affected, the abnormal movements, and that is your sunflower cataract, and the other one is the brown ring, isn't it? The golden brown ring there, that is the KF ring. All right, so no marks for that round, and we go to team B. Next. Oh, sorry. Shush. I knew this was going to go wrong. Yeah. I'll give you a. So, what is the answer?
Herpes zoster ophthalmicus.
What is seen there?
Hutchinson sign.
Hutchinson sign and?
Dendrite.
What dendrite?
Dendritic ulcer. Pseudodendritic.
Yeah. So your disciform keratitis, Hutchinson sign, and pseudodendrite. So it was herpes zoster ophthalmicus. I will come back to you with a question because I don't think we can give them that. Did you get it at the second sign? Yes. Hutchinson sign you got. Okay, I think then we'll give it to them because I don't have a 3-set question again. I'll have to give them a direct question. So 10 marks you can give them. We will go to, is that okay? Yeah. Okay, team A, your question next.
VKH.
Wow. Wow. Okay. Awesome. So that is the poliosis. Second picture would be? That would give it away immediately.
Segura sign.
Segura sign is very difficult to pick up in a picture. I put granulomatous keratitis and then I put the sunset. Yeah. So that is your VKH. Very well picked up. So 15 marks for team A. Should we have a round? Should we have a round of the scores before we go to rapid fire?
Team A 40 points, Team B 40 points, Team C 10 points, Team D 55 points.
Wow.
And Team E 30 points.
All right. So we have some clear leaders here and a tie at the second place. Let us go to rapid fire. Rapid fire, we'll start with you. 1 minute time, Jainam. So what you will do is, as I read the question, you will give your answer. If you don't want to answer, you say pass. We'll go down. Otherwise, you will not finish. So say pass and go to the next question. And then if you have time left, you can go back and attempt what you have not. There is no negative marking, but you will get your marks for the correct answer. There are 6 questions, 2 marks each. This I forgot. Audience question. ഇത് വേണേ ചോദിക്കായിരുന്നു അവർക്കല്ലേ No, it's okay. We've already done the scores. In the scan, it's a blood vessel. It's a major blood vessel. Correct. Aortic root dilatation. Yes. And subluxation. Yes. Very good, well spotted. But I gave it away. Major blood vessel when we are in the way.
But Honavar had this question once for his quiz. Do you know what he showed? He showed a boy playing the piano. That was his first clue. Just the fingers, the arachnodactyly. So blink and think. Rapid questions, quick questions, and quicker answers. Okay, I have kept it as uniform as possible, but of course some will be tougher than the others. You have to forgive me for that. Round 1. Let's go. Fixed and dilated pupil after PKP in patients with keratoconus is called as?
UGH syndrome.
UGH syndrome.
Uret-Savalli.
Okay, Uret-Savalli syndrome. We'll do the scoring last. Second question. Trans hemorrhage is commonly associated with dash
Normal
type of
tension
glaucoma. Highest surface tension is for gas,
Gases.
PFCL, silicon oil.
Gases.
Only action of superior rectus when the globe is 67 degrees abducted is?
Elevation.
Kissing choroids on B scan is seen in which condition?
Choroidal hemangioma. Choroidal detachment.
Armali and Becker classification is for?
Steroid-induced glaucoma.
Steroid-induced glaucoma. Let's go to the answers, then we can do the scoring. Okay. So Uret-Savalli they got. Trans hemorrhage they got. Higher surface tension they got. Action of superior rectus they got wrong. It is intorsion when it is abducted. Kissing choroids, choroidal detachment, I will give it to them. They corrected it. Armali and Becker also they got. So that is 5 out of 6. Excellent. Team B ready? Which layer rejection is seen in PKP but not in DALK? Pass if you don't know. Next question. Melanin in pigment dispersion syndrome is released from the dash surface of the iris. Quiet audience, don't prompt.
Pigmented anterior surface.
Anterior surface of the iris. Perilimbal vitiligo in BKH is called? Segura sign. In Hess chart, each small square on the grid subtends an angle of dash degree at a working distance of dash centimeter.
5 degree.
Attempt, yeah. And centimeter?
30 centimeter.
10 centimeter. Double circulation on FFA is seen in? Come on, that is the easiest. One minute, I'll give you your last question. Modified Dandy criteria is to diagnose? Okay. So, layer rejection is endothelium. Melanin pigment is in posterior surface of the iris. Posterior bowing of the iris is what causes pigment dispersion. Perilimbal they got correct. Hess chart, we can give them 1 mark because they got the 5 degree correct, but the centimeter is wrong. It is 50 centimeters. Double circulation is seen in melanoma. Modified Dandy criteria is to diagnose IIH, idiopathic intracranial hypertension. Okay. So only 3 marks from this round for them. Team C, are you ready? Your first question. Pentacam works on which principle?
Sheen-Fleck.
Double hum sign on indentation gonioscopy is characteristic of?
Plateau iris.
Trial of ranibizumab in ROP is called?
Cruise.
Normal Kestenbaum index is? Double layer sign seen on OCT is in which condition?
PCV.
Huber's classification is used for? You want to rework any of the other answers? Time up? 15 seconds. So trial of ranibizumab in ROP, do you want to give another attempt? Very easy name.
Everest.
Okay, I think we'll stop. Yeah. Pentacam works on shrimp flood principle. Double hum sign is seen in plateau iris, they got. Trial is called rainbow, they did not get. Normal Kestenbaum, they got 10. Double layer sign seen in PCV. Huber's classification is used in Duane's retraction syndrome. So that is just 2 plus 2, 4 plus 2, 6 marks. PCV also they got 8 marks. Okay, big hand. Team D ready? Concomitant use of topical steroids and antibiotic in bacterial keratitis.
Cut trial.
Double ring sign of optic nerve head.
Hypoplasia.
Most frequent cause of chronic intraocular inflammation among children.
JIA.
You want to expand that?
Juvenile idiopathic arthritis.
Most common altitudinal defect in non-arthritic AION.
Inferior altitudinal.
Why does the disc appear dark on AF? On fundus autofluorescence, why does the disc appear dark? Next one, Roper Hall classification is for?
Chemical injury.
Chemical injury. Do you want to again attempt the disc appearing dark?
Lipofuscin.
Lipofuscin. Okay, they don't want to attempt it. So, concomitant use they got, SCUT trial. Double ring they got, optic nerve head hypoplasia, JIA. Inferior is the most common altitudinal defect. Disc appears dark because there is no RPE, and by default there is no lipofuscin. If you had just added no lipofuscin to that, I would have given you the mark. Roper Hall classification is for chemical injury. That's again 10 out of 12. Very good attempt. Last team ready for your rapid fire? Instrument used to measure corneal sensitivity is?
Cockett bonnet testaciometer.
Hoyt sign in glaucoma signifies?
Optic meningioma glaucoma. Pass.
Phenotype associated with
HLA
birdshot
29.
Most common location for cerebral aneurysm associated with acute third nerve palsy? Junction of which two vessels?
PCOM. ICA.
PCOM and?
PCOM and ICA.
PCOM and IC. Crab claw sign on OB scan seen in?
PMD, pellucid marginal degeneration.
Gas classification is
Macular
used
Holt.
in? Okay. You want to do the Hoyt sign once more? Time is there? 5 seconds more. Okay, time up. Instrument is the esthesiometer. Cockett bonnet is the right answer. Hoyt sign signifies RNFL atrophy. Phenotype is A29 that they got. PCA and IC is correct. Crab claw is pellucid marginal degeneration. Gas classification is used in macular hole. Excellent. 10 out of 12 for that. I think with that we have come to the end of 5 rounds. While the scores are being kept, do you need a tiebreaker? I don't think you need a tiebreaker, but let's just go through the questions if everybody is interested. This is not a round for you. It's open to everybody. What are these instruments and what? That everybody here knows. Yes, you all know? The Malugin ring and the B-hex expander for the pupil expansion. What is the likely cause of this visual field defect? I think all you HFA people will not know. This is our, prior to my generation, I think. We just got a bit of it. Excellent. Malingering, madam. What is it called, madam? It's called a spiraling field defect. Spiraling field defect we used to get on the Lister perimeter
to detect malingering, because they don't know that it is in the same isopter, so they will keep saying they can't see, they can't see, they can't see, so the field would go like that. So that was the spiral field effect in a perimeter. Madam, chocolate kodku. Identify the instrument and the technique. This I'm sure all of you will know, no? It's an immersion A-scan biometry. Prager shell for an immersion A-scan. I thought I was the only one who didn't know it. Okay, next question. OCT sign. ILM drape, IJT, I think everybody knows that. What is this visual field? Not a sedal, not a centrocecal. Yes, you're correct. It's a pistol shot. Derringer scotoma or a pistol scotoma. Derringer scotoma or a pistol scotoma. It typically seen in neuroophthalmic conditions like optic neuritis. It combines. You want to see the field again? This at least some of you will know what is the instrument. At the old timers. Correct. What keratometer? Correct. It's the Jawal-Shiotz keratometer. What was the other one? There were two keratometers that we used to use in the pre-auto keratometer era. Bosch and Lomb and Jawal-Shiotz. What was the difference in the Myers? Anybody knows the difference? Yeah, the circle Myers were Bosch and Lomb. Bosch and Lomb had circle Myers in which you had to overlap the negative sign. And in the Jawal-Shiotz, it is a step ladder pattern. It's a step ladder pattern for the Jawal-Shiotz. Flying saucer sign in HCQ toxicity. Osteodontokeratoprosthesis. It's an MRI sign. Not penialoma, not parinodes. Hummingbird sign seen in progressive supranuclear palsy. Hummingbird sign. It's a midbrain atrophy with preserved pons. That is the explanation given to giving an appearance of either a penguin or a hummingbird. Argus, the smart vision glasses used in low vision rehabilitation. Argus has all that pocket attachment and everything. This is just the glass alone. It's used as a low vision aid. I think we can stop now. I think the scores are ready. So the third prize goes to Pushpagiri Medical College with 43 marks. The second prize goes to Chaithanya Eye Hospital, Trivandrum with 50 marks. And the first prize goes to Team D, 65 marks, TD Medical College, Alappuzha. Team E scored 40, RIO Trivandrum, and Team C 18, GMC Kottayam. Congratulations to all the winners. And thank you all audience for your patient listening.
Now I request Dr. Cherianshin Matthew and Dr. Natasha Radhakrishnan to hand over the prizes to the quiz winners. Team C at the 5th position, GMC Kottayam. Dr. Jelisa and Dr. Parvati. Team E, In fourth position, RIU Trivandrum, Dr. Gopika, Dr. Anu Philip. Team B at third position, Pushpagiri Medical College, Dr. Shilpa, Dr. Dawn. Second prize goes to Team A, Chaithanya Hospital, Trivandrum, Dr. Aparna, Dr. Sapna. And the iPad goes to Team D. First position, TDMC Alapura. Dr. Afia, Dr. Shruti. We were treated to a very thrilling and spectacular quiz competition. Thank you, ma'am, for conducting such a scintillating event. I now request Dr. Shane Matthews, sir, to present a memento as a token of our immense love and appreciation to Dr. Natasha Radhakrishnan. With this, we have come to the end of our CME. We sincerely thank each and every one of you for gracing us with your presence and making this event truly memorable. Your participation has been a blessing and we are deeply grateful. Thank you, all of you.